Good morning, everyone. Am I audible?
Hello.
Yes, sir. Am I audible?
Yes, ma'am.
Yes.
Oh, thank you.
Good morning, Dr. Ganesh and Dr. Shobha. I'm just checking my audio. So, am I audible?
Yes, sir. You are audible.
Right. Thank you, ma'am.
Good morning, everyone.
Good
Am I
morning.
audible? Yes, ma'am.
Good morning.
The participants will be joining in a while, sir. We'll move on with the online proceeding. We invite you all for this IPHCon 2021. Today is our first day of our IPHCon, and today we'll move on with the oral presentation. It gives me immense pleasure to invite you all on the first day of IPHCon, jointly organized by JIPMER in collaboration with IPHA Puducherry. In today's program, we have 3 sessions of scientific oral presentations. To begin with, our first session on post-COVID. It is under the theme COVID-19 and related issues track. First, I would like to invite the chairpersons. We have 3 chairpersons here today, and Dr. Shobha A. Then comes Dr. Arvind Kumar Singh and Dr. Ganesh Kumar. I would like to display their CV as I introduce each one of you, sir. Am I audible now?
Yes.
Yeah, okay.
CV. Shall I introduce? So good morning, everybody, and welcome to the 65th IPHA conference. So in this oral presentation, I first welcome Dr. Shobha, Community Medical College. So Madam has 29 years of teaching experience and currently working in Kottayam Medical College. So welcome, Madam.
Thank you.
Welcome to this.
Thank
And
you.
also I welcome, thank you, Madam, thank you. And also I welcome Arvind Kumar, Associate Professor of Community Medicine, AIIMS Bhubaneswar. And he has got 8 years of teaching experience and also many publications, 55 publications in his record. I also welcome Dr. Arvind Kumar Singh on this occasion. Welcome, sir.
Thank you very much, Dr.
Welcome,
Ganesh.
sir.
My pleasure to be in this.
Am I audible?
Yes,
Yeah,
yes.
Dr. Ganesh, you are audible. Thank you very much. Thank you very much for introducing me. I am happy to be part of this IPHA conference. Thank you.
So now I will hand over this to Dr. Shobha to coordinate first 4 presentations, isn't it, Madam?
Yes, yes, yes. So, good morning. I'm talking about the general instruction to the presenters. The time slot given for each presentation is total 10 minutes, 1 minute for the introduction of the presenters, 7 minutes for the presentation, and 2 minutes for the discussion. Okay. So, first of all, there are 8 presentations in this group. First of all, I invite Dr. Amrita D. Abstract ID number 130. Title of the study, COVID-19 associated mucormycosis during the second wave of pandemic, for the presentation. Over to you, Amrita.
Thank you, Madam, for inviting me. Myself, Dr. Amrita, Junior Resident from the Department of Community Medicine, Government Medical College, Kozhikode, Kerala.
You can start the presentation, Amrita.
Okay, ma'am.
It is minor technical issue, Madam, sometime.
Tech team.
Hello, this is Dr. Anu Mitra here from the Department of Community Medicine, IPGMER, Kolkata, to present the study on perception of mucormycosis among postgraduate trainees working in a tertiary care teaching hospital of Kolkata. Introduction: mucormycosis is an angioinvasive fungal infection caused mostly by Rhizopus, Rhizomucor, and Cunningham. A change in the epidemiology of mucormycosis has been observed in the recent years with the rise in incidence.
It's not my presentation.
The presentation is different. This is
I-
from
I-
some other person.
I think we can go ahead, ma'am, with the sequence.
No, the presenter should be available, no? Is the presenter available? Otherwise, when we ask question, he should be available, no? Is Namitra Chakraborty available? Hello,
No, ma'am, he's not
I
available.
think it's not available.
he is not available, so it's the problem. The technical people, please answer whether he can upload the Dr. Amrita's presentation or not, or should I call which one they are presenting? They can message me so they can call that presenter.
Ma'am, we'll sort out in 2 minutes. Give us time.
Okay. Hello. Hello.
Hello.
Now, which are you presenting the same? Dr. Amrita or somebody else?
Uh,
I have to call them. That's why.
okay.
അല്ലെങ്കിൽ അവരുടെ മുറിയിൽ ദിനേശിന്റെ മുറിയിൽ ഇരുന്ന് എഴുതട്ടെ. Hello. Hello. Hello.
Hello, madam. There is some technical issue. We will wait for some time.
Okay, okay.
Will 5-10 minutes? 5-10 minutes, madam. 10 minutes. 5 to 10 minutes.
Okay, okay.
Hello. Ma'am, can we start from first video, first presentation?
Yes, yes. Yes, Dr. Amrita was called.
Amrita Chakravarti.
अरे आकाश वो आती पेन ड्राइव होगी बगल में दियो नीचे नीचे ड्रॉर खोल नीचे वाली
It is again wrong. They have uploaded another thing.
Ma'am, please tell me the presentation data name.
Name is COVID-19 associated mucormycosis during the second wave of pandemic. COVID-19 associated
Yes, Chandra.
abstract number 130.
130.
130 abstract number.
Okay.
COVID-19 associated mucormycosis during the second wave of pandemic.
Respected faculties, a very fine good morning to all. The topic which I am going to present today is risk factors associated with mucormycosis during the second wave of COVID-19 in a tertiary care center in North Kerala. Myself, Dr. Amrita, Junior Resident from the Department of Community Medicine, Government Medical College, Kozhikode, Kerala. The incidence of mucormycosis has risen rapidly during the second wave. It's a rare but potentially fatal infection. It was declared as an epidemic and a notifiable disease under the Epidemic Disease Act 1897. And as on July 15th, we had around 45,000 cases in India with around 9.4% mortalities. This posed a new challenge to the whole medical community, and there is only limited number of studies conducted so far, especially in Kerala. The most common cause of mucormycosis in Asian countries was diabetes mellitus, whereas in Western countries, it is hematological malignancies and solid organ transplants. And according to a multi-center epidemiological study conducted in India, the prevalence of diabetes mellitus among the patients with mucormycosis was 86%. Then 78.7% of them were using steroids. Then hypoxia was present in 60% of the cases. Other identified risk factors were zinc use, steam inhalation, and ICU stay. So my primary objective is to study the risk factors associated with mucormycosis during the second wave of COVID-19 in Government Medical College, Kozhikode, and to assess the outcome of these patients admitted with mucormycosis. Then it was an institution-based cross-sectional study conducted in Government Medical College, Kozhikode. It took 3 months from April to June 2021, and all patients admitted with features suggestive of mucormycosis were studied. Data was collected as a part of COVID surveillance at regional PEDSEL. Then variables under the study were demographic characteristics, COVID-19 status, diabetes mellitus, present or past treatment history of steroids, zinc, oxygen or steam supplementation. Then there were 40 cases studied, and When we look at the age distribution, the mean age was 55 years with a standard deviation of 12 years, minimum 29 to maximum 80 years, and majority of them were males. Then 33 cases, that is 82.5% were COVID positive, and the gap between COVID positivity to mucormycosis was more than 7 days in around 65% cases. Then this shows the risk factors associated with mucormycosis. According to our study, diabetes mellitus was present in 79% of the cases, followed by steroid use in 65%, hypoxia and followed by oxygen supplementation in 25% of cases, and zinc use was there in 75% cases, then steam inhalation 35% and ICU admission 15% of the cases. And outcome-wise, survival beyond six weeks was present in 55%, and 40% of them were cured, and mortality was 10%. This shows the relation of diabetes mellitus with other COVID-19 associated variables. We had around 31 cases with diabetes mellitus, and out of that, 61% of them were given with steroids. Then 22.5% were having hypoxia. Zinc use was there in 74%. And this shows the relation of steroid use with other COVID-19 associated variables. There were 26 cases supplemented with steroids, and out of that, 73% of them were having diabetes mellitus. Then hypoxia was present in 38%, then zinc use in almost all 100% of the cases. Then we got a significant relationship also between steroid use, then zinc, steam inhalation, and ICU admission. So 40 cases were reported, and all the cases were rhino-orbitocerebral type, which is the most common type of mucormycosis. First case was reported on April 4th. We got a prevalence of 0.27% among hospitalized COVID-19 patients. We got a male predominance, that is because at that time, almost all the majority of the admitted cases were males. Then mean age was 55, more than 55 years, that is elderly are more admitted, so they are more easily diagnosed. COVID-19 is directly or indirectly is a predisposing risk factor. Then other risk factors were found to be uncontrolled diabetes and excessive use of steroids. Zinc use also aid in fungal infection. We did not get much evidence regarding hypoxia or ICU stay as risk factors. Then steam inhalation, as this causes the seeding or attachment of fungal spores in the respiratory tract, definitely causes mucormycosis. Then outcome-wise, mortality was seen in 10%, and all the deaths were aged 55 years. So increasing age above 50, diabetes, steroid use, and zinc were found to be the associated risk factors. Patients and healthcare workers should be made aware of the importance of glycemic control, judicious use of steroids, early warning signs and symptoms of mucormycosis, and the importance of early reporting. So these are my reference, and my sincere acknowledgement to the faculties and junior residents of Department of Otorhinolaryngology and Department of Community Medicine. So that's all. Thank you.
Okay, Dr. Amartha, you have kept the time, even 1 minute before the scheduled time you have presented. I have one question. How can you say it is a risk factor when you have taken only patients with mucormycosis?
Ma'am, I have analyzed the non-risk factors. That is, we know that previously the thought risk factors were diabetes mellitus, and when during the second wave of COVID-19, from the literature reviewed, they have found out the risk factors as zinc, then steam inhalation, ICU stay, and oxygen supplementation. So we have analyzed the prevalence of these factors in our hospitalized cases. So if we conduct a case control study using those patients admitted with COVID-19 alone, we can find out that the odds ratio, and then can easily find out the risk. From odds ratio, we can easily get the prevalence of risk factors.
Similarly, some of your two tables, that is diabetes status and COVID-19 variables, steroid use and COVID, that is does not fit to your objective, you know. Yes, any questions in the chat box? I think Dr. Arvind sir or Dr. Ganesh can ask.
Diabetes mellitus and steroid use were in the non-risk factors. So Among that patients, have analyzed the prevalence of other risk factors like zinc use, hypoxia, and ICU stay.
Other chairpersons can ask questions.
Okay, only one question I have. What are the limitations of your study? Limitations.
Data was collected as a part of COVID surveillance. I was able to study only those cases admitted with mucormycosis. So if I could study other similar matched other cases with COVID-19 alone, I could really find out the odds ratio and then easily say the risk compared with them, with those without mucormycosis and those with mucormycosis. So the prevalence of risk factors could be better studied if I could study normal.
Comparison. Okay. Okay. Thank you.
Hello.
Thank you, sir.
Madam. There is also some other risk factors also, madam. Patient in the ventilators, those ventilators which are not been cleaned properly. That it is also one. Because of that, also these patients can get this mucormycosis. Also, wearing continuously same mask, also there are more chances of getting this mucormycosis. It is also some risk factor for this, madam.
Okay, sir. Thank you.
Yeah, thank you, Dr. Amrita. This is Dr. Arvind. It was a good presentation, but the
Thank you,
most
sir.
fundamental question which Shubha Madam has asked that remains very relevant and that reduces the validity of the study actually, because when you are seeing these factors, you have to do a comparison. You have taken CAM cases and you have just described the profile, right? So it is not the risk factors which are associated with COVID-associated mucormycosis. Your objective should have been the profile of risk factors among COVID-associated mucormycosis patients. So you are telling that 70% are diabetic, but what about those patients who have not got mucormycosis, right? So we have to compare that proportion of diabetic patient in that group with the CAM patient group. So then only we will know what are the risk factors, right?
Okay.
So this could have been a much better study in that sense. Second thing, your conclusions, I think, was kind of more extrapolation than what you have basically observed, right? So hypoxia and ventilation and all those things, it has not featured very prominently in the result, but it is showing in the conclusion. So I think those were the important limitations of this study. Otherwise, if you frame your objective as profile of risk factors, then I think it is good, right? And that has been reported very widely. So thank you very much. May I also request delegates the delegates who are attending the presentation to just pose their question in the chat box. Please don't ask the question because that will reduce the time available with us. Just put the question in the chat box and the chairpersons will take the question. Thank you.
Thank you, sir.
Can we go to the next presentation?
Ma'am, please tell me the abstract number and name.
Abstract number 137. Investigation of acute surge of COVID-19 associated mucormycosis reported to a tertiary care institution in Bihar. So,
hi all, I'm going to
yes,
present
next I call upon
COVID-19
Dr. S.S.V. Prasad.
reported in tertiary care institution Bihar. I myself, Dr. S.S.V. Prasad, Junior
I have
Resident
not-
AIIMS partner. So India is one of the worst affected country with more than 1 year of ongoing COVID-19 pandemic. Steroid was recommended for management of COVID-19 based on the evidence that outcomes are better in moderate to severe case of COVID-19. Injudicious use of steroid not only affects the blood glucose level but also suppresses the immune function, resulting in higher risk of contracting opportunistic infection. Acute surge of cases of post-COVID mucormycosis was seen in our institution during the second wave of pandemic, so this outbreak investigation is planned. Objectives were to describe the risk factors profile of COVID.
The presentation is not audible.
Presentation is not on.
Lead to COVID-associated mucormycosis among COVID-19.
Hello. Hello. Hello.
Hi all, I'm
Yeah.
going to present on a topic investigation of acute surge of COVID-19 associated mucormycosis reported in tertiary care institution Bihar. I myself, Dr. S.S.V. Prasad, Junior Resident Department of CFM Expert. So India is one of the worst affected country with more than one wave of ongoing COVID-19 pandemic. Steroid was recommended for management of COVID-19 based on the evidence that outcomes are better in moderate to severe case of COVID-19. Injudicious use of steroid not only affects the blood glucose level but also suppresses the immune function, resulting in higher risk of contracting opportunistic infection. Acute surge of cases of post-COVID mucormycosis was seen in our institution during the second wave of pandemic, so this outbreak investigation was planned. Objectives were to describe the risk factors profile of COVID-associated mucormycosis and to assess the plausible chain of event leading to COVID-associated mucormycosis among COVID-19 patients admitted in the tertiary healthcare institution Patna, Bihar. Material methods. Study design was descriptive cross-section study. Study setting was a Mucor ward of AIIMS Patna. Participants were COVID patient diagnosed with mucormycosis admitted in the Mucor ward of AIIMS Patna. Duration of study was 24th May to 13 June 2021. And study frame was all the COVID-associated mucormycosis cases reported admitted in the Mucor ward of AIIMS Patna. Inclusion criteria was all the COVID-associated mucormycosis cases admitted during the study period were included in the study, and definition of CAM was derived from the AIIMS Delhi. And exclusion criteria was all the patients who had psychiatric disorders, who were self-reported or documented, and were not given the written informed consent were excluded. Study tool was the information was actually collected using a predefined semi-structured rapid investigation questionnaire. Social-demographic details, details of COVID-19, rapid information of CAM were obtained by face-to-face interview by trained investigators. Outcome variables were socio-demographic profile of COVID-associated mucormycosis, possible risk factors of COVID-associated mucormycosis, and plausible chain of events and source of infection. First one showing the socio-demographic details of COVID-associated mucormycosis patient. This table we can see that there's an equal distribution of the age groups of between less than 45 years, 46 and more than 60 years, but slight increase in 45. And gender also shows that the maximum patients were admitted in the hospital were males compared to females. And occupation shows that the maximum patients admitted were unemployed, which can be due to the effect of pandemic over the lives. Table 2 shows the status of vaccination, chronic illness, and treatment of the patients. About only 13.1% patients were vaccinated, and 65.4 patients were diabetic. And a history of zinc was seen in 55.4% patients. And maximum patients showed the steroid use for COVID of 64.6%. This bar graph shows the age distribution of the vaccination, diabetes mellitus, and steroid use. We can also see one more thing from this graph that the vaccination shows some of the protective factor over the mucormycosis in COVID. As we can see, only 17 people were vaccinated, remaining maximum patients were not vaccinated. This table shows the details of severity of COVID-associated mucormycosis in patients, where we can see that patients who are reported to the wards were moderately advanced disease, which is 58.5%, which shows that the maximum patients would have neglected the initial symptoms of mucormycosis, and later on they would have come to hospitals when it becomes serious, or maybe other problem. This table also shows that diabetic people, 60% patients were diabetic in moderately advanced diseases. In clinical profile of COVID-associated mucormycosis patient, this is table 4, in which we can see that the maximum patients had headache in relatively early diseases, only 90%, while moderately advanced disease, 76.2% patients had eye swelling, followed by the eye pain in 71% patients. And very advanced diseases, 25.5% patients showed the throbbing headache. Diagnosis of all the patients were done maximum using CT MRI, which is 50.8%, which followed by QH mount and then biopsy and HPE. And current modality of treatment, medical management was seen 68.5%, followed by both medical and surgical management. Outcome, completely cured was in only 1.5%, and maximum patients were undergoing treatment when the study was going on in the hospital. So implications can be that the acute surge in case of CAM could be due to low immunity conferred as a result of diabetes and rampant inadvertent use of steroid for management of COVID-19 during the second wave of pandemic. And the majority of patients was not vaccinated, so the acute surge in case of CAM could be due to the lowering of immunity by newer variant of SARS-CoV-2, and the same was compounded by presence of diabetes and rampant use of steroid for management of COVID-19 during the second wave of the pandemic. Also, majority of the CAM cases were present in advanced stage of disease. Nearly 2/3 of cases had diabetes and history of steroid use for management of COVID-19. And more than 85% cases had not been vaccinated even with a single dose of COVID vaccines. And many patients reported breach in the maintenance sterility of nasopharyngeal swab during sample collections, and post-recovery strict adherence to using masks were not followed by many patients. Conclusion, you can say that screening and control of diabetes and rationally use of steroid only under medical supervision for management of COVID-19 are key to prevent occurrence of CAM cases. And strictly following the COVID-19 prevention guidelines, which include increasing the coverage of COVID vaccination, can help to check the emergence of COVID-associated mucormycosis cases. And COVID-associated mucormycosis awareness among the general public and health personnel, as well as setting up of COVID-associated mucormycosis surveillance mechanism, will be useful to avoid the CAM-related disability and deaths. So mucormycosis present in India for a long time, but adequate attention was not paid till the COVID-19 pandemic. Despite devastating health effect, it was never been a public health priority. And the acute surge in case of COVID-associated mucormycosis added a new direction to public health agenda in India. These are my references. Thank you.
Okay, Dr. Prasad is there.
Yes, ma'am.
Your title was investigation of acute surge, but in the objective you said that what are the risk factors of this? Again, you have taken only patients with CAM. How can you say that these are risk factors? Now, can you generalize your findings?
Ma'am, my finding, ma'am, there are some limitations in the study as I can't generalize the findings because the patient who were admitted to AIIMS only were being taken for the study. So there may like only the patient coming to AIIMS have been taken for study. So generalization is not much possible in the study.
Now you have to know about the sample size and the sampling technique. Then only you can say that it is generalized. It can be generalized or not. And your conclusion, how can you say that conclusion? It is as per your conclusion, only diabetes and steroid is responsible for developing CAM.
Yes, ma'am.
It is not, that conclusion is not from your study results, no? Can you say that from your study results? Yes, over to you, Dr. Ganesh. Dr. Ganesh, you can ask.
Yeah, Dr. Prasad. So this selection of subjects, you can say some point, how the participants were selected. During what period of time and how they were selected? Is it audible, Dr. Prasad? This is not audible.
Dr. Prasad?
Dr. Prasad, is it audible? There is some problem.
It seems he has lost the connection.
Yes.
Dr. Prasad, you can just, in case there is poor connectivity, you can just put your response in the chat box to the question which Dr. Ganesh is asking, in case you are there.
Is there as per the participants list?
Yes, ma'am. His name is showing, but I think
no response from him.
Okay, no problem.
You can just go ahead with the question, and if he's there, he can respond the thing.
Yes.
In the chat box.
That's all. Okay. So, Dr. Prasad, is it audible? I think can. Some problem.
No question in the chat box also.
Yes. We will move on to
Next presentation. Okay. Can we move on to the next presentation, sir?
Yes, ma'am. Yes.
Okay, madam.
So next, I invite Dr. Vinila Andapalli. The abstract number is 194 Abstract number is 194. Title is Assessment of Risk Factors of Mucormycosis among patients admitted to Government General Hospital, Kakinada. Abstract number 194. Assessment of Risk Factors of Mucormycosis among patients admitted to Government General Hospital, Kakinada.
Myself, Dr. K. Vinila, Junior Resident from Department of Community Medicine, Rangaraya Medical College, Kakinada. Title of my today's topic is Assessment of Risk Factors of Mucormycosis among patients admitted to Government General Hospital, Kakinada, Andhra Pradesh. Introduction. During the current pandemic of COVID-19, a myriad of manifestation and complications has emerged and are being reported on. As the devastating COVID-19 ebbs with more than 1 lakh new cases a day, India continues to achieve stability over the worst ever second wave of COVID-19. Another imminent threat has emerged as a challenge in the form of CAM, coronavirus disease associated mucormycosis. Mucormycosis, often referred to as so-called black fungus, is a rare fungal disease but potentially fatal infection. The mucormycosis outbreak has left thousands deceased or disabled. According to government numbers, India clocks over 40,845 cases and 3,129 deaths till 28 June this year. A month after reported his first case of mucormycosis at the height of second wave of COVID-19 pandemic, a host of hypotheses have floated regarding reasons behind the surge in the cases of rare fungal infection. The incidence rate of mucormycosis globally varies from 0.005 to 1.7 per million population, whereas in India its prevalence is 0.14 per thousand, which is about 80 times higher than the developed countries. The fatality rate of mucormycosis is 46% globally. Andhra Pradesh stood in third place for mucor cases. The objective of the study is to assess the risk factors for mucormycosis among patients admitted to GGH Kakinada, and the study described the socio-demographic profile of the patients. Material and methods. Study setting: mucormycosis squad, GGH Kakinada, a hospital-based observational study done between 26 May to 15 June 2021. 159 mucormycosis cases admitted at the time of the study are included in the study. Data collection was done by using pre-designed, pre-tested, semi-structured questionnaire and analyzed by MS Excel 2020 and SPSS 20. Descriptive statistics and test of significance was applied wherever necessary. Institutional Ethics Committee approval was obtained before data collection. All the confirmed mucormycosis cases admitted to GGH Kakinada and who are willing to participate in the study are included in the study. Patients who are unconscious and not willing to participate are excluded. Likely bias and its control: length of interview was kept constant for all the study participants to overcome the interviewer bias. Coming to results, majority of the study subjects belongs to 41 to 60 years, that is 57.9%. Majority are male, 71%, and female 29%, which comes nearly 3:1 ratio. Socio-demographic profile: 98% yearly are nuclear family, 81% are Hindus, followed by 10% Christians, and 73.6% are backward class, followed by 16% open category. 38% had studied up to 10th, nearly 1/4 are illiterate. 77 points belong to upper lower class, followed by 17% lower middle class. Distribution of study subjects based on presenting complaint: nearly more than half, that is 54%, came with eye complaint, followed by 23% cheek complaint, and 20% tooth and 3% nasal bleed. All the images were clicked at the time of a study. Coming to distribution of study subjects based on risk factors, the risk factors includes 96% history of COVID-19, 77% had history of steam inhalation, 75% had comorbidities, 68% had history of hospitalization at the time of COVID positive, 64% used steroid, and 61% had home isolation. Coming to story of steroid, the history of steroid uses among COVID at the time of COVID-19 is 64.2%, and of which 76.5% used methylpred and 23% used dexamethasone. Of all the study subjects who used steroid, 95% has steroid hyperglycemia. Coming to comorbidities, out of 105 out of 159 had diabetes, followed by hypertension, 5 had HIV and sinusitis. Coming to type of number of comorbidities, one comorbidity in more than 50%, that is 56%, followed by 38% two comorbidities and 6% three comorbidities. Hidden conflicts. At the time of study, we found that 7% had 7% is the mortality rate. The mean duration of symptoms of black fungus is 12.93 days from the day 1 of COVID positive. It is so surprising for us to find that more than 50%, that is 56.7%, had history of home isolation for more than 1 week, and 50% had history of steam inhalation more than twice per day, and 72.2% had history of nasal swab given for COVID-19 testing. During the hospital stay for COVID-19, 74% had stayed for more than 1 week, 90% are on oxygen support. Highest is 84% mass, followed by Bronx and ORM. It is very sad to know that only 28% report daily change of water in the humidifier. All these are the hidden culprits for mucormycosis. Outcome we categorized into severe and moderate. 31.5% had surgical intervention and 68.5% had medical intervention. Table 1 shows the significant association between risk factors and disease outcome. The severity of in severe disease, nearly 98% had 4 to 6 risk factors, whereas in moderate 1 or 2, that is 93.3% had 4 to 6 risk factors. Coming to table 2, when compared with severe and moderate disease, the history of COVID-19 is 100% in severe disease, which is more. 80% had home isolation, 76% had steam inhalation, nasal swab, which is more than twice and thrice respectively, and 66% had hospital stay, and 64% had comorbidities, which is only 18 in moderate, and 58%, almost equal, both of them had steroid hyperglycemia. Coming to conclusion, early identification of risk factors increase the possibility of early diagnosis and treatment and also prevent disease progression. This study has revealed patients with 2 or more comorbidities and are more likely to progress easily to severe disease. Steroid usage, hyperglycemia, home isolation, nasal swab, change of water in humidifier are also potent risk factors for which showed significant association. Most of the patients have at least 3 to 5 risk factors which cumulatively worsen the disease. All these risk factors worked in synergy to increase the patient's susceptibility and disease severity. These are the references we used at the time of our study. I would like to conclude with the slide that we have passed the era of prevention is better than cure. Now to fight the present and future pandemics, prevention is the only cure because prevention is easy, negligible cost, healthy family and happy family, whereas cure is complex, expensive, time consuming and stress on family. Thank you.
Kept to time, but actually you have presented the prevalence of the risk factors among the mucormycosis cases, is it not so?
Yes, ma'am.
If you want to find out the actual risk factors of mucormycosis, which study would have been preferred?
I would have taken the cases and controls, ma'am, and
Then
find out the odds
collect
ratio.
the informations.
Ma'am, I have taken all the confirmed mucormycosis cases in my study period, and
No, the variables, how do you ask the questions? To whom did you ask the question, or how do you verify?
Ma'am, I have designed the questionnaire for the mucormycosis patients itself. I have asked the questions, ma'am, and
they are aware of daily change of humidifier, etc. Patients in the mucormycosis patients, they are looking for the daily change of humidifier and all. How do you get that question from the patient? That is why I am doubting.
Yes, ma'am, they are the only one which are allowed in the ward at the time of admission when they are COVID positive, ma'am. So they have been continuously observing what the water has been changed or not, and the patients are also only 1/4 are illiterate, and rest of them they have a good education so that they can find out whether the nurse has changed the water in the humidifier or not, ma'am.
So what type of bias can occur when you ask such questions?
Might be recall bias, ma'am.
Okay. Yes, over to Dr. Ganesh Kumar.
So here 1 or 2 participants were used steroids, isn't it, in your study out of 189?
Sir. Yes, sir.
So whether you can tell how long they used the steroids and
the steroids were steroids were used both IV and oral, sir. At least more than 2 weeks we considered. I mean, that is about more than 14 days we have taken in our study, sir.
Okay,
at least for 2 weeks. Okay,
thank you. Thank you.
Over to Dr. Aravind.
Yeah, thank you, ma'am. Thank you, Dr. Vinila. Thank you for your presentation.
Thank you, sir.
So more or less all the three studies which you have seen apart from yours have been similar. So the issues as well as the concerns are also similar. I'll take the question which has come from Dr. Nish K. So he has asked whether there is any relation with the vaccination. So have you studied that point, or that is one of your limitations?
Yes, sir. I have mentioned it in the hidden culprits, sir. Only 3 of the 159 patients have been vaccinated for 1 dose of Covishield, sir. If the vaccination is if they were vaccinated with the 2 doses, the disease progression and effect may be decreased. I want to conclude with that, sir.
Right. Yeah, and most of the patients seems to be severely ill. Right. So that is probably a issue with the study setting. So most of the hospitals from which you are coming are tertiary care centers, and they deal with the severely ill cases. So that is quite possible. Right. Again, my general comment to all the presenters. Right. So just stick to your study findings and make the conclusion accordingly. Right. So we are seeing the general mistake that you're kind of over extrapolating the conclusion as well as implications. Right. Just stick to your objectives. Based on that objective, the result has to come, and based on those results, we have to make the conclusions. Right. Otherwise, all the studies were good in terms of describing the known risk factors of COVID-associated mucormycosis. But you cannot say very confidently unless and until you do a case control study or a cohort study of all the COVID patients and see how in whom the mucormycosis has occurred. Right. So that's all from my side. Thank you, Dr. Vinila.
Thank you, sir.
Can we move on to the next presentation, sir? I invite Dr. Poonguzhali Rajashekar for the presentation. Abstract ID 290. Title: Persistent symptoms and comorbidity status among COVID-19 recovered patients in a tertiary care hospital, Chennai, a cross-sectional study. Abstract number 290. Yes. Murli, you can present.
Morning all, I am Dr. R. Poonguzhali, postgraduate, Institute of Community Medicine, Madras Medical College, Chennai. My abstract number is 290. Persistent symptoms and comorbidity status among COVID-19 recovered patients in a tertiary care hospital, Chennai, a cross-sectional study under the guidance of Dr. Uma Maheshwari, Professor, Institute of Community Medicine, Madras Medical College, Chennai. Introduction. COVID-19 is an infectious disease caused by a newly discovered coronavirus. The clinical spectra of COVID-19 are varied, ranging from mild to moderate symptoms. People suffered from COVID-19 experience symptoms persisting for weeks to months after their initial recovery. The recent phenomenon of healthy individuals developing new comorbidity after COVID-19 and information lacking on persistent symptoms that persist after recovery remains a major concern among medical fraternity globally. So, objective of my study is to assess the persistent symptoms and comorbid status among COVID-19 recovered patients attending follow-up clinic in RGGH, Chennai. Methodology. My study design is a cross-sectional study. Study population, all COVID-19 recovered patients attending COVID-19 follow-up clinic at RGGH, Chennai, and willing to participate were included. Study duration is 5 months from October 2020 to February 2021. Study tool. Interviewer administered questionnaire includes symptomatic profile, details of comorbid condition, and HAD scale. Investigations, FBS, PPBS, serum creatinine, ECG, blood pressure measurement. So table 1 shows the demographic characteristics of the study. My study population is 1207. So this table describes the age, gender, comorbidity, and symptomatic status. Among the age variable, 30 to 50 years were more frequently included. 513 patients were around 30 to 50 years, and in gender, female were predominantly affected, about 720 to 24 patients, and comorbids were present in 733 patients, which include 60.72%. Figure 1 shows the symptomatic profile of post-COVID patients. N is equal to 614. of which 274 patients had myalgia, 150 had dyspnea, and 134 have cough, and 56 presented with headache. Figure 2 shows the distribution of comorbidities. 352 were on diabetic, were detected to have diabetes mellitus, 241 with systemic hypertension, 44 with CAD, 59 with hypothyroid, and 37 with CKD and bronchial asthma. Figure 3 shows the persistence of symptoms in patients with or without comorbidity. Among 733 with comorbidity, 381 had persistent symptoms, and out of 474 without comorbidity, 200 patients had persistent symptoms. Figure 4 shows the glycemic status of diabetic post-COVID patients. Known diabetic were 352, of which 224 were uncontrolled, and 128 were on diabetic control. Figure 5 shows the reasons for uncontrolled glycemic status. Of about 108 persons were on steroids and antivirals, and 52 had discontinued insulin. Figure 6 shows the risk factors in new diabetics. 38 people had obesity, and 16 had family history of diabetes. 25 were on steroids and antivirals. Figure 7 shows the diabetic and hypertensive status of the study population. 352 people were known diabetes, 70 were newly detected diabetics, and 241 were known hypertensives, and 30 were newly detected hypertensives in the newly detected in post-COVID clinic. Figure 8 shows the psychiatric status of the study population. 194 had sleep disorders, and 114 had anxiety disorder, and 44 reported with depressive disorder. Conclusion, out of 1,207 patients, 57% reported one or more persistent symptom, predominant being myalgia, 22.65%, and difficulty in breathing, 18.35%. 733 patients had one or more comorbidities, of which 45.29% with diabetes mellitus, and 37.88% with hypertension. 70 and 30 were newly detected diabetics and hypertensives respectively. Of the 352 known diabetes, 36.45% were on glycemic control, and 63.55% were not under control. Thus, post-COVID follow-up is an absolute essential one in need of the hour. Recommendations are: close tracking of post-COVID patients is mandatory to know whether new comorbidities has developed when the infection remains unknown. Registries to be established. Separate psychiatric counseling and yoga therapy to be established in all tertiary care centers. These are my references. Thank you.
That I think in your slide you have studied about the persistent symptoms.
Yes, ma'am.
But what about in your conclusion? You told that the persistent symptom is difficulty in breathing. But in your bar diagram, you have told written as cough. You have not included difficulty in breathing. So nothing is mentioned about the respiratory comorbidity. You say about diabetes, hypertension, etc. And 18.3% are presenting with difficulty in breathing. Have you done a lung function test or any other test to find out whether there is deterioration in the lung function which lead to this respiratory morbidity? It was not mentioned in your.
No, ma'am, we didn't do it.
Actually, you didn't do about the respiratory morbidity. Have you done? Have you done what is the prevalence of respiratory comorbidity? Yeah. Now, is there a difference in the persistence of symptoms between those with comorbidity and without comorbidity? You have done, there is a figure. You have some network issue, I think. You can put the answer in the chat box.
Okay, ma'am.
You are not audible. It is said that your bandwidth is low.
Am I audible, ma'am?
Hello.
Ma'am?
Is there significant difference in the persistence of symptoms between those with morbidity and comorbidity?
Yes, ma'am. I have showed it in the figure 3, ma'am.
Only number, is it significant? How can
No,
you
ma'am.
do?
I didn't put the.
Which test you can do for finding out whether there is significant difference? I think she is having a network issue. Please put.
Ma'am, am I audible now, ma'am?
Yes, doctor, you are audible. Please go ahead.
Yes, sir.
Please respond to the question which madam has asked. Dr. Pongalevi.
Yes, sir.
You had told just difference, only number among this. If you want to find out whether
Ma'am,
the
I didn't
difference is,
put the significance, ma'am.
huh?
I didn't do the significance test, ma'am.
You didn't do. So that,
Yeah, yes, ma'am.
that is a relevant thing because you want to find out whether the comorbidity, the symptoms are persisting in those with comorbidity or without comorbidity.
Okay,
And you
ma'am.
should have also studied about the respiratory comorbidity because nearly
Okay,
18%, because all diabetes and hypertension, majority are previously diabetic.
Yes, ma'am. Only
Others,
newly
we
detected
don't
were
know
very
the
minimal
previous
number.
status. How can you say it is a newly detected? Are you sure that they are newly detected during the follow-up? If the blood sugar has not been done when they are admitted and it was normal, are you sure that?
No, ma'am. I was not sure of
Then how
that,
can
ma'am.
you
It
say
was
then? How
only,
can you say then? How can you say then it is newly detected in the post-COVID clinic then?
only when we detect new patients in post-COVID, that
If
is
they
one.
are admitted, usually we are giving them steroids and all those things. We usually
ma'am.
give them the medicines. Is it not so? So we will
Yes, ma'am.
see. We would have done that also. But when you say that it is newly detected, that means before that they were having normal blood sugar. And now it is newly detected. So if they are hospitalized, it is unlikely that their blood sugar was not normal. Or if they are detected newly after the COVID, you can attribute it to the steroid use or not, and maybe some other risk factor.
Okay,
So
ma'am.
are you sure that they were not diabetic before?
Yes, ma'am.
You are sure?
Because we call the patients
Did you
only
collect
who
the
were
data?
admitted.
How did you collect the data? Personal interview?
Yes, ma'am.
Yes, over to Dr. Arvind.
Thank you, madam. So, Dr. Pongalevi,
Yes,
so when was the symptoms evaluated? When did you do the interview?
Sir, patients were called after 20 days of COVID positive, sir.
After
We
20
usually
days,
call
and
the
what
patient for
was the longest distinct time gap? 28 days to
86 days. 86 days, sir.
86 days.
Yes, sir.
Right. So, because long COVID, we say when the symptoms persist for more than 1 month after testing positive, right? So, otherwise your study, I'd like to your study, apart from the questions which Dr. Shobha madam has asked. So, some of the patients would have got diagnosed at the time of admission of the COVID-19,
Yes, sir.
and that they would have mentioned as a new diabetes, right? Because
Okay.
72 patient getting diabetes is a big number, right? So I think you need to evaluate it more clearly. Then also control status. What was the control status when they were admitted at the time of illness, COVID-19 illness? So you must be having the hospital record available with you since most of them were hospital patients, although all of them were hospital patients. So I think that also you can incorporate to increase the significance of your study. So this is a very good study, and there's a lot of focus on the long COVID, and you have did a good work on this. And with these comments, I think you can improve the significance of your study when you publish it later on, right?
Sure. Thank you.
Second thing, I was not very clear. What was the sample size of your listing study? How many COVID patients you have followed?
Sir, 1207 patients, sir. 1207.
Right, right. And what was the response rate? Because all the COVID-19 patients will not respond to your calls, right? So what was the
Actually,
response rate?
it's a part. Okay, sir. It's a part of our post-COVID follow-up study, sir. We those who were admitted in our Rajiv Gandhi Government Hospital hospital were called for the post-COVID follow-up, sir. Of which those who attended the follow-up study, 1207 patients were called. 1207 patients attended the clinic, and I inquired about their status, sir.
So this was based on the patient who followed up in the COVID-19 clinic, right?
Yes, sir. Yes, sir.
Okay, and most of those patients were admitted in your hospital, over?
Yes, sir.
Right, right. So you can see what was the response rate, because you know what are the patients who were admitted in your hospital, and whether the profile who are coming to your hospital is different from that or not, right? Because somebody who's not having the problem will definitely not come to the hospital, yes or no?
Yes, sir. Yes, sir.
Right. So this will be overestimation of your COVID-19 post COVID-19 complications,
yes,
because
sir.
only those patients will be coming who are likely to have some problem, right?
Yes,
so
sir.
maybe you can also augment your
actually,
study by doing a telephonic follow-up and see what is the profile.
Okay.
One question which has come from one of the participants, I'll just read it out. So what was the, did you notice any death among these participants during the follow-up? So I think she has done only follow-up in the OPD, so she will not know what was the death of among those patients, because they will not come. And did you find out any cardiovascular diseases associated with these symptoms? So this is one question which is coming up. So would you like to respond to this question?
Actually, that's for the first question. This is the answer, sir. Actually, we called only the patients who are alive and those who are willing to come to the post-COVID follow-up, sir. So that is the answer for the first question. And for cardiovascular diseases associated symptoms, there were only minor symptoms, sir. So I didn't include it in the study, sir. About saturation level, we found, during the post-COVID follow-up, we find the saturation. We actually examine for all these, sir. Saturation level is also been done, sir, for all the patients. But I didn't mention it in this study, sir.
Okay, thank you very much. Over to Shobha, madam. That's all from me.
Okay.
Hello. Hello.
Yes, ma'am, you're audible, ma'am.
Dr. Aravind, you can introduce the next speakers.
Right. Okay. So we have finished the 4 abstracts, and we will be going to the second half. So abstract number serial number 5 to 8. So the fifth abstract ID is 368, and the title is Impact of COVID-19 on Quality of Life among General Population in Rural Area of Chengalpattu District, Tamil Nadu, a cross-sectional study. So this will be presented by Dr. Aarti. So may I request the technical team to please share the video. Thank you.
Greetings to everyone. So my study is on impact of COVID-19 on quality of life among general population in rural area of Chengalpattu District, Tamil Nadu, a cross-sectional study. So coronavirus disease, which is commonly known as COVID-19, is an infectious disease caused by coronavirus. So the infection ranges from simple common cold to severe respiratory tract infection. Moving on to quality of life, WHO defines quality of life as an individual's perception of their position in the life in context with the culture and the values they live in, and in relation to their goals, expectations, standards, and concerns. So the quality of life of a person is affected by a complex way. So they include it may be due to the person's physical health, psychological state, personal beliefs, and social relationships, and the relationship to the salient features of the environment. So all these have been affected during the COVID-19 pandemic, which makes necessary to do this study.
as we all know, India ranks second among the countries that hit badly by the COVID-19. We have 3.31 crore people affected by COVID-19, and we have lost 4.41 lakh people in the pandemic. So this makes it clear that people living in our country have faced various devastations. So it is important to, it's not only important to treat the physical effect of the COVID-19, but it's also important to know and solve the other effects due to the COVID-19 pandemic at an earlier stage and solve it before it becomes worse. So this makes it necessary to assess the quality of life of the people. The primary objective of my study is to determine the impact of COVID-19 on quality of life of the general population living in rural area of the Chengalpattu district, Tamil Nadu. The secondary objective is to determine the socio-demographic factors affecting the quality of life. So this study is a community-based cross-sectional study done among the rural health done in the rural health training centers, field practicing area for tertiary care, private hospital for duration of 3 months. It was studied among the adults living in the study region, excluding the migrant population living in that region. So the sample size was calculated based on the study by the Ingfei Zhang and Zhang Ma. The prevalence was 52.1% with a 95% of confidence interval, an allowable error of 10%. The sample size was calculated using the formula n is equal to 4pq by l square. After adding a non-response rate of 10%, the final sample size was obtained to be 125. Simple random sampling technique was used to calculate to select the participants for a study. WHO breath questionnaire was used to collect the data from the participants. So it had 4 domains, namely the physical domain, psychological domain, social domain, and the environmental domain. So the physical domain had questions related to the pain, their easy fatigability, their the demand for the dependence on the medicines during the pandemic and everything. Psychological domains had questions related to the positive and the negative feelings, their opinion on the bodily images. The social relationship domain had questions related to their relationship with the friends and family members during the pandemic and their sexual activity. The environmental domains had questions relating to their physical environment, their housing and the housing environment, the transport facilities available, their financial status during the COVID-19 pandemic, and opportunities for leisure activities and acquiring new information. Additionally, social demographic profile questions related to the social demographic profile were added to the questionnaire. So after obtaining institutional human ethics committee approval, enlisting of the eligible population in 12 villages under the RHTC was done. Through simple random sampling, 125 participants were approached. They were explained about the study and informed consent was obtained. The data was collected using the WHO breath questionnaire, and the obtained data was entered in the Microsoft Excel and analyzed using SPSS software version 21. So the results of my study are as follows. Most of my participants are female, accounting for about 58%, and they were between the age group of 30 to 44 years, accounting for about 36%. And the educational status of my study participants were 20% of the participants were illiterate, 5% had obtained only the primary education, 22% of the population had obtained only the middle school education, and 36% of the participants had completed their high school education, and only 17% had been graduated. Occupation, seeing occupation, 55%. Most of my study participants are doing a skilled or semi-skilled kind of work, and only 10% have been employed with a professional or semi-professional work. So moving on to the frequency table of each domain. So the domain scores were calculated using the WHO breath questionnaire guidelines, and the score was given for each question, and the domain score was calculated and it was transformed, and then the transform score was adding up all the transform scores, and the mean scores was obtained. So the mean score for physical health domain is 68.86, and 60.8% of the population scored above the mean, and the mean score for mental health domain was 65.7, and 53.6% scored participants scored above the mean score, and the social relationship domain had a mean score of 54.84, and 54.4% of the participants scored above the mean, and the environmental domain had a mean score of 66, and 53.6% of the population scored above the mean. So adding up all the domains for we got the total score of the quality of life, and the mean was calculated from this total score, which was found to be 255.85, and those participants who scored below the mean were considered having poor quality of life, and those having higher scores above the mean were considered as a better quality of life. So 58 participants, that is 46%, had a poor quality of life, and the 67 participants, that is 54% had a better quality of life. So association of socio-demographic factors with the quality of life was studied. So accordingly, age had a significant association with the quality of life with a p-value of 0, and education had a significant association with a p-value of 0.017, and occupation had a significant p-value of with a significant association with a p-value of 0.002. Hence, I conclude by saying that despite of the pandemic, 53.6% of the participants had better quality of life. This may be due to the subsidies and free rations from the government to the people. Also, people in the reproductive age group with a better education and occupation had a good quality of life. This implies that government's future plan should focus on better education to the children and improvement of employment opportunities. These are my references. Thank you.
Thank you, Dr. Aarti. That was a good presentation, and throwing a new perspective on the quality of life. Right, I will take the comments. I'll just the questions which I had. First thing is that the title says impact of COVID-19 on quality of life. Right. So I think it is not about the COVID-19 disease, but the COVID-19 pandemic in the population.
Yes,
so it is, yeah. So, and the second thing is impact of COVID-19 on quality of life. So that is a very loaded statement. Impact of COVID-19 on quality of life. So whether can we say that yes, that was not the baseline quality of life of the participants when there was no COVID, right? So that is something which has to be considered when you are seeing the impact of COVID-19 on quality of life.
Actually, a few months back, before COVID-19 pandemic, my seniors have already studied the impact of quality of life of these people. So I chose to study because as there was a data before the pandemic, and I've take a continuation study. So I've studied it.
Yeah, so in case it was a continuation study, I think it would have been very great to present the quality of life in both the period and see what difference has happened, right? Because I may say that in Chengalpattu district, this is the usual quality of life in patients. Second thing, what was the study period and what was the background infection at that time, right? Because when you see the quality of life, for example, at this point of time when there is no lockdown probably in that district, it will be different, and so it is linked with the study period. So what was the study period and what was the background infection at that time?
Study period was like from October 2020 to December 2020. I collected the data, sir. So following pandemic was like the first wave was reducing at that time. With the proper precautions only, we went to the participants and collected the data. So we maintained social distancing, and then we wore masks. And I ensured that I wore mask and the participants also wore mask, and proper sanitation was also maintained, sir.
Right. And third and the last question. What kind of sampling error do you expect in this study? Are you sure that whether the 120 participants which you have selected were representative
due
of
to pandemic, I wasn't able to visit much participants, so I took a minimal sample size. So the sample
size is different. So sample size, you have calculated the sample size, and that may be adequate. But I'm talking about the sampling strategy, which would have led to a large sampling error or sampling error. So yeah, so you can just think over that, right? So one question from participant has come. I'll just take that question, ma'am, and then I'll go to the other chairperson. Okay. So the question is, did you find any factors related to the lockdown period, how people adapted in the rural areas?
Sorry, sir.
Did you find any factors related to the lockdown period and how people adapted in the rural areas?
Actually, rural area it wasn't affected much in the rural areas, sir, because they don't use much transport. One of the problem is that public transport is affected and the job was affected, sir. But due to the rations they are providing in the government, free rations, and they are providing free money, sir. So with that they were able to lead their life, sir. And usually they used to follow the same thing before the pandemic also, so there wasn't much.
So that was your observation. So that was not part of the study, it seems. So I'll move to the other chairpersons. May I request Dr. Subha, madam, to please forward the question.
I agree with Dr. Aravind because if you say the impact, you should know the previous quality of life before COVID. Another thing which I want to ask her, you told that there is significant association in the quality of life between age group with the age. So can you say that it is due to that impact of COVID? Because as age advances, the quality may differ. How will you prove or disprove that association? What method you will choose to find out whether it is?
Ma'am, for proving that we have to do further analysis, ma'am.
How that is why I'm asking, because age group, yes, age group itself is a factor for affecting the quality of life. In such cases, how will you do?
We have to find odds ratio.
No, odds ratio is not there. Any other thing? Because you want to know whether age is affecting the quality of life rather than the COVID. What type of analysis you want to do? Okay. Go to next chairperson can ask.
Okay, Dr. Arati.
Yes, sir.
So one question I have, this WHO QL BREF. So
Yes,
overall rating is there. Overall rating of this quality of life.
Yes, sir.
Whether it was done. Because you mentioned only 4 domains, isn't
Yes,
it?
sir.
4 domains.
I calculated the total score of 4 domains. So for each person, I calculated the sum of the domain scores and then took a mean of it. And then those who stand above the mean are considered having better quality of life, and below the mean are considered having poor quality of life, sir.
Okay. So this first and second question, overall rating, quality of life, whether it was done.
Yes, sir. This was done, sir. I have showed a pie chart depicting the overall quality of life, sir.
So what is the finding?
Sir, about 53% had better quality of life, sir. And the remaining had a poor quality of life, sir.
Okay, thank you.
Thank you.
Thank you very much, Dr. Aarti, for your presentation. Now we'll move to the next presentation in the sequence. So the abstract ID is 429, and the title is Profile of COVID-19 Recovered Patient in a Tertiary Care Hospital, Chennai. And the presenter is Dr. Shweta RS. So may I request the technical team to please project the video. I hope Dr. Shweta RS is there with us. Dr. Shweta RS, are you there?
Yes. Yes, sir. Good morning, sir.
Okay, right.
Good morning. I'm Dr. Shweta, second year postgraduate, Institute of Community Medicine. My abstract ID is 429. My topic is Profile of COVID-19 Recovered Patients in a Tertiary Care Hospital, Chennai. My guide is Dr. Uma Mageshwari, Professor MMC. Introduction. A novel human coronavirus, SARS-CoV-2, was identified first in Wuhan, China in December 2019. This COVID-19 presented with varied symptoms in acute phase. Knowledge about the long-term sequelae of COVID-19 remains limited. Reports have shown that COVID-19 has a variety of long-term effects affecting all systems, including respiratory, cardiovascular, GI, neurological, psychiatric, and dermatological systems. When post-COVID syndrome clinics are established, characterization of epidemiology of the disease will help in appropriate diagnosis, care, public health intervention, policy, and resource planning. COVID-19 vaccine is considered to be key to limit and eliminate infectious disease, but the success of vaccination program will rely on the rate of vaccine acceptance among the population. Vaccine hesitancy is defined as a complex and context-specific, varying across time, place, and vaccine. It is influenced by factors such as compliancy, convenience, and confidence. Hence, this study is done to assess the profile and vaccine hesitancy among post-COVID patients. Moving on to our objective, to determine the demographic and clinical profile of patient attending COVID follow-up, and to assess the vaccination status and reason for not getting vaccinated. Study design is a cross-sectional study in all COVID-19 recovered patients attending COVID follow-up clinic at RGGH were included. And study area is a follow-up clinic. Study duration was for 2 months, June and July of 2021. Data collection was done by semi-structured questionnaire which included symptomatic profile and post-recovery period and details of comorbid condition. And investigation included fasting and postprandial blood sugar, serum creatinine, ECG, BP measurement. And the data were entered in MS Excel and analyzed using SPSS version 16. The age distribution of the study population, the major contributed between being 51 to 60 years, contributed to 33%, followed by 41 to 50 years, and age distribution being male predominant, that is 60%, and female being 40%. Occupation of the study population, semi-skilled worker was 27%, followed by skilled worker, unskilled worker, and the least being professional and semi-professional. And the relation between the type of bed on admission and persistent symptom was done, and 66% of the patients who were admitted in O2 bed had symptoms in post-COVID period, and 26% of the non-O2 bed patients had persistent symptoms. The post-COVID symptom of the study population was myalgia, followed by difficulty in breathing and cough, and minor ailments like loss of smell, loss of taste, chest pain, and all being the minor contributors. The mucus status of the study population was assessed, and 20% was positive and 80% was negative for mucor. And the comorbidity of the population, 76% was comorbid, and no comorbid was 23.8%, diabetes being the major contributor with 51%, followed by hypertension with 37%, followed by bronchial asthma, coronary artery disease, hypothyroidism, CVA, CKD, and others. Coming on to the new onset diabetes, 5.3% had new onset diabetes and 3% had new onset hypertension. Then we took the vaccine status. 73% was unvaccinated and 26% was vaccinated. Of this 26%, only 6% took both the doses, and 20% had only one dose of vaccine. The vaccine preference was Covishield with 53% and Covaxin being 46%. When the reason for vaccine hesitancy was analyzed, fear of side effects was 46%, followed by unavailability of vaccine and fear of injection. Conclusion: 62% were symptomatic with post-COVID being predominant, being myalgia, difficulty in breathing, cough, and majority of them had a comorbidity with diabetes and hypertension being the leading one. Large population remained unvaccinated still. The major reasons for vaccine hesitancy was fear of side effects. Recommendation: considering the persistent symptoms after acute phase, the post-COVID patient should be assessed vigilantly for long-term sequelae. Screening of new onset diabetes and hypertension need to be focused, and unvaccinated people not only put themselves at risk but also people around them. It should therefore be a priority, and the controversy regarding side effects need to be addressed, and vaccine shortage issues to be sorted out to prevent further waves. These are my references, and thank you for your valuable time.
Thank you, Dr. Shweta, for the nice presentation, and it was a good study, I would say. Some questions from my side. When were these symptoms evaluated? At what point of time after the COVID-19 infection?
After 28 days of discharge from the tertiary care hospital, the patients were called. Around 100 patients were taken and called by the volunteers, and we were asked them to come for follow-up in the following week.
28 days
and
what was the longest?
Longest was 3 months. Till 3 months, we had patients.
In 28 days to near 28 days. Most of the patients would have come near.
Most of the patient returned in 28 days. We took the list according to the admission date, according to the discharge date, and we called them. So but majority of them didn't turn up. That was a limitation. The major limitation was that, and among whom Yes, sir.
Right. Thank you. So, and regarding the COVID vaccination, what was the guideline at that time when the study was done
Sir, after 3
for
months
the
of
COVID recovered patients?
after 3 months of recovery, sir.
After 3 months of recovery. So, why you are expecting them to get COVID vaccination when they are coming at 28 days of follow-up? Right. So,
That's what, sir. Even before getting this COVID infection, few of them had got vaccination already. At least 1 dose of vaccination, few has got, and the patient who were returning late, who came to us, we advised them to get vaccinated on the same day. When they came us for follow-up, we asked their preference and we sent them to the vaccine clinic, which was on the first floor, and we had this follow-up clinic at the second floor. So it was easy to mobilize the patient there and had them vaccinated.
thank you. So, I'll hand over to Dr. Shobha, madam, for
You told that, Dr. Shweta, you told that the vaccine preference was Covishield. How do you?
Yes.
Is there an opportunity for the people to choose vaccine at that time?
Yes, ma'am. We had enough vaccines in our tertiary care hospital, so we gave the patients
It
their.
is not tertiary care hospital. The people who are recovered from these means they have admitted before they have been admitted in the tertiary care hospital. They would have taken the vaccine from some other. Only those with severe would have been admitted in a tertiary care.
Yes,
you have found out the outcome of only those patients who are treated in a tertiary care.
Yes, ma'am.
So, what type of bias would have occurred if you are going to generalize this finding? Can you generalize this finding, or what is the limitation in generalizing the finding?
No, ma'am. This can't be generalized because this vaccine availability varies from place to place.
Not
and,
about vaccine availability. Your findings.
Finding is most of the patient who turned up for follow-up had few symptoms. Who were normal didn't turn up for follow-up. So this can't be generalized as it is an institution-based study. If it was done in community, then it can be generalized, I think.
Even if it is any institution-based, if you want to generalize, what are the other things you have to follow?
I would like to
the
compare.
Basic things in a study when you want to have the external validity for the study.
I will take those confounding effect and effect modifiers and all into the analysis.
Yes, next over to Dr. Ganesh.
Okay. Dr. Shweta,
yes, sir.
Regarding this vaccine hesitancy,
yes,
so majority had vaccine hesitancy, isn't it? 76%.
Yes, sir. Fear of side effects of vaccine.
Yes. So during what period it was done? Because that is also important. And how it was done?
So during the July of 2021, sir.
June, July. Oh.
Yes, sir.
Because the timing is also important. And
yes,
how it was collected, how the data was collected.
All the patients who were attending the follow-up clinic were asked few questions, sir, in order to motivate them to get vaccinated. We asked all those set of questions and we gave them counseling, sir. As a postgraduate, we were posted there for.
So the reasons how it was assessed, reasons. There is
reasons. Yes, open-ended questions. Why didn't you get vaccinated was our question, and those who didn't get vaccinated were motivated to get vaccines, sir.
Okay, thank you.
Thank you, Dr. Ganesh, and thank you, Shobha, madam. Thank you, Dr. Shweta, for your presentation, and we'll move to the next one.
Thank you, sir. Thank you.
Right. So the next presentation is abstract ID 726, and the title is Perception of Mucormycosis Among Postgraduate Trainees Working in a Tertiary Care Hospital of Kolkata. So this will be presented by Dr. Anamitra Chakrabarti. So I just wanted to confirm if Dr. Anamitra is there with us.
Yes, sir. Yes, sir.
Dr. Anamitra, you are there, right? So may I request technical team to please project the video.
Hello, this is Dr. Anu Mitra here from the Department of Community Medicine, IPJMER, Kolkata, to present the study on perception of mucormycosis among postgraduate trainees working in a tertiary care teaching hospital of Kolkata. Introduction: mucormycosis is an angioinvasive fungal infection caused mostly by Rhizopus, Rhizomucor, and Cunninghamella. A change in the epidemiology of mucormycosis has been observed in the recent years with the rise in incidence, new causative agents, and susceptible population. Globally, the prevalence of mucormycosis varied from 0.005 to 1.7 per million population, while in a recent estimate of the year 2019 and 20, its prevalence is hiked by nearly 80 times. The rhinoorbital form of the disease is seen to be associated with COVID-19, uncontrolled diabetes mellitus, immunosuppression by steroid, prolonged ICU stay, other associated comorbidities with COVID increases the risk of the disease in COVID-19 patients. A recent estimate shows that incidence of mucormycosis has risen more rapidly during the second wave compared with the first wave, as compared to first wave of COVID-19 in India, with at least 14,872 cases on 28th May 2021. In the West Bengal, the PGTs, postgraduate trainees of all the tertiary hospitals, are working as frontline health workers, and their knowledge is of utmost importance for the better management of mucormycosis. Objectives: to assess the knowledge of mucormycosis among PGTs working in a tertiary care teaching hospital of Kolkata, to find out the association of knowledge with the socio-demographic profile of the study population, if any. Materials and methods: the study type, that it was an institution-based observational descriptive study of cross-sectional in design, and the study was conducted in IPGMER, that is Institute of Postgraduate Medical Education and Research, SSKM Hospital, with the study population being the postgraduate trainees. Exclusion criteria: those who did not give consent, and the study period was entire June and July, that is 2 months, 2021. Materials and methods continued. The sample size was 242. Finite population correction was done. 10% non-response was added. It was a simple random sampling without replacement, and with the study tools being the pre-designed, pre-tested, semi-structured questionnaire, and the method of data collection was self-administered questionnaire, with the study variables being the dependent variables, that is number 1, knowledge on mucormycosis, and number 2, independent variables, socio-demographic and professional variables, age, gender, year of residency, training obtained, and history of COVID-19 in the family and within the self. Materials and methods: data were analyzed in MS Excel 2010 and analyzed in IBM SPSS version 20.0. Descriptive analysis and inferential statistics were done. Ethical issues, institutional ethics, and informed written consent was taken. The result: most of the respondents were in the age group of 25 to 35 years, with the mean age of 30.55 plus minus 5.75 years. 59.5% were male participants. The participants from the first year, second year, and third year were respectively 40.1, 26.9, and 33.1% respectively. 81.8% of the respondents performed any type of COVID-related duty during the last 6 months. 20.6 received any form of training. 18.6 participants suffered from COVID during the last 6 months. This is a pie diagram showing a good knowledge of having 70% knowledge on the of the study distribution of total knowledge scores, having 70% knowledge. This is a box plot were plotted separately on the epidemiological and diagnostic aspects were plotted in the box plots. Now the distribution of respondents according to the knowledge on mucormycosis regarding the etiological agent: 50.8% responded correctly, 93.8% responded correctly about the hyperglycemia as the risk factor, and 85.5% responded correctly about neutropenia as the risk factor. The manifestation of rhinocerebral form of the disease has been responded correctly, with the black discoloration and the nasal ulcers being respectively 89.7 and 55.0. The diagnosis was responded correctly by 85.5% of the respondents, and the management regarding strict blood sugar control and reduction of steroids and surgical debridement were respectively responded by 73.3, 71.5 and 79.5% of the respondents. The preventive measures and the drug of choice were responded correctly by the 71.5 and 95.9 as amphotericin B as the drug of choice, and the regarding advice on regular self-examination for facial swelling to all the discharged COVID-19 patients were responded correctly by 73.3% of the respondents. Then the binary logistic regression was performed to see the association between the socio-demographic characteristics with their knowledge. With respect to, it is seen that with respect to third year residents, first and second year residents significantly had less knowledge. Conclusions and implications: 81.8% participants were involved in COVID duty, which may have increased their understanding about mucormycosis. Overall knowledge on mucormycosis was good in 70% respondents. The above study was conducted in a tertiary care hospital, which was designated as a center of excellence for mucormycosis. That can be a very good reason for good knowledge on the disease. Conclusions and implications: knowledge on mucormycosis is deficient in aspects like etiological agents, symptoms, and management protocol among the first and second year residents and who were involved in the duties other than what duty. Training of the PGTs on mucormycosis and their importance on the backdrop of COVID-19 may increase the identification of the disease in the early stage, thereby reducing the occurrence and severity of the disease. These are the references. Thank you so much.
Thank you, Dr. Anumitra, for your wonderful presentation. And it was a different study from what we have seen earlier. So most of the earlier studies were limited to the COVID-associated mucormycosis risk factor and long COVID. So this is a new aspect which you have opened. But starting from the most fundamental and basic questions, so your title starts with perception of mucormycosis among postgraduate trainees, right?
Yes.
So there's a fundamental difference between the perception and the knowledge. What I have studied is knowledge. It is not the perception. Perception is what they think about that, their attitude, beliefs, kind of, right? So you could have upfront knowledge about mucormycosis patient among postgraduate trainees. The second question, background. Since you are talking about the knowledge of mucormycosis, in background, I did not find any information which could have told the audience, readers, about what is the knowledge of doctors, young doctors regarding mucormycosis. We are just told about the burden of the mucormycosis, and that is not your research question, right? If you see your introduction, most of the introductions which is coming up regarding the burden of mucormycosis, right? It should have been more inclined towards the knowledge of mucormycosis among doctors. Right. So, so it has to be based on the research question which we are asking. Then few questions which I have right now. How did you calculate the sample size? You have come up with 242, and so how was the sample size calculation done? Whether it was based on assumption?
Sir, it was an enumeration method, and the sample size is being calculated by simple random sampling without replacement. And finite population correction has been done with taking as 10% as non-responders. Finite population correction was done.
I'm asking about the sample size, not the sampling strategy. So finite population correction you have done, but what was the prevalence you have assumed for the calculation of sample size, and from where that prevalence has come?
Sir, as because it is a new study, we have I have done the sample size as the taking all the postgraduate trainees, and the simple random sampling without replacement was done using the formula.
Right. So we will go ahead, but simple. I'm not talking about 1 minus 3. We will go ahead to the next question. Right. So you presented the knowledge score. So whether this knowledge score, whether it was a weighted knowledge score or whether you gave 10 weightage to each and every question, you asked plenty of questions. So how this knowledge score, overall knowledge score, was calculated in your study?
Sir, it was calculated using giving 0 to it was a 14 questionnaire round. The questionnaires were self-administered questionnaires. It was given to the PGT.
The question is different. The question is different, Dr. Anumitra. Please understand. I'm asking how did you arrive to the knowledge score, overall composite knowledge score?
Yes, sir. I'm telling that. I'm coming to that. for correct responses, for every correct responses 0.5, or if there are 4 questions and if there are 4 correct responses, if a PGT gives a 4 correct response, then 2 he or she will be getting 2, and 0.5 will be the correct response for one option, sir. And if there are accordingly, if there are 5 correct questions, then the 2 by 5 will be the would have been the calculation, and likewise, sir.
Okay, right. So I have a few more questions, but due to shortage of time, I'll move ahead with the other chairperson.
Since it was
May I
a
request Shobha Madam
multiple
and
choice question and
Ganesh sir, please.
multiple answer type question, it was
Okay, right. Thank you, Dr. Anamitra. Let the questions come from Dr. Shobha and Dr. Ganesh.
Yes, sir.
Yes. Dr. Anamitra,
Yes,
how
sir.
did you do the simple random sampling? How have you done that simple random sampling?
Simple random
You told
sampling.
that you have done simple random sampling. You have taken the postgraduates of your institution. How have you done that simple random sampling?
Yes, ma'am. The simple random sampling was being done. First, the PGTs were taken. Number of the PGTs were taken from the dean office, and then every PGTs were being asked by a face-to-face self-administered questionnaire.
No. That is not simple random sampling. How you have selected the simple? This method of selection is simple random. Okay, you have first taken the list of the PG students from the dean office. Then how you have selected this?
The PGTs,
how many PGs are there in that list?
Ma'am, about 642, ma'am.
So from 642, how many you have taken for the study?
242.
So how you have taken 242 from that 642? For that you told that you used simple random sampling. How was it done?
Just, ma'am, by lottery method, by approaching those PGTs who were in the department and
that is not lottery method. That is not lottery method. So yeah, simply please don't, from the community medicine PG, please don't write simple random sampling and all. Just when you have taken, I think you have taken a purposive sampling. When you went to the department, those who are available, you have taken. That is what I think you have done.
Yes, ma'am, I have done that.
That is not at all simple random sampling. Please, okay. Yes, what you have done when you went to the department, you have seen those who are available and you have asked them. That is not at all simple random sampling. It was a purposive sampling or a convenient sampling. Okay. Then you told why you have used this binary logistics and all those things.
Binary logistic regression was done to find out the association between the dependent variable and the socio-demographic factor. The dependent variable was knowledge in my study, and the socio-demographic and professional variables were the age, gender, the type of COVID duty done, and the persistence of and having COVID in the family or in the self PGTs.
So how that helps?
It was seen that
you told that many patients have good knowledge, but only 18% has received any training.
With respect, madam, with respect to the third year PGTs, the second year and the first year PGTs were had less knowledge. It is seen using the binary logistic regression.
Yes, over to you, Ganesh sir.
Okay, Dr. Anamitra, see this postgraduate trainees, so whether you can categorize which are the departments included. It was mentioned, is it mentioned?
Sir, all
because
the
knowledge
teaching the MD curriculum.
Which are the departments included?
Departments included all the department: anatomy, physiology, biochemistry, then the forensic medicine, microbiology, then general medicine.
Okay. So it would have been better if it is classified. Okay, fine. It is classified preclinical, paraclinical, and clinical. because the knowledge depends on the work where they do also. Okay.
The
Isn't
work
it?
they do, but the knowledge doesn't depend on the work they do, sir. I think the knowledge is universal. Knowledge can be in the pharmacology PGTs who are not involved in the COVID ward duty, but they are not in the practice of giving the medications and treatment to the management to the COVID patients.
So all the
But
PGs work in COVID ward. All the PGs work.
No, all the PGTs didn't work in the COVID ward. They worked at the different. They worked in the different COVID scenario, like telemedicine. They worked in fever clinic. All were pertain to the COVID-19 related duties. But the knowledge can be there. But I think, but the practice of the management.
Okay. Thank you.
Thank you very much, Dr. Ganesh sir and Dr. Shubha madam. Thank you, Dr. Anumitra, for your nice presentation. We'll move to the next and the last presentation of this session.
Thank you.
So the abstract ID is 738. The title is Evaluation of Quality of Life of Patient previously infected with COVID-19 disease in the urban and rural field practice area of a tertiary care center in Pondicherry, a cross-sectional study. And the presenter is Dr. Omreen Fatima. Dr. Omreen Fatima, may I confirm whether you are there with us?
Yes, sir, I am here, sir.
Dr. Omreen is there. So, yeah, the video can be started.
Good morning to all. Myself, I'm Dr. Omreen Fatima, second year community medicine PG from Arupadeveedi Medical College. My guide is Dr. Arun Daniel, associate professor from community medicine, Arupadeveedi Medical College, and my title is Evaluation of Quality of Life of Patients Previously Infected with COVID-19 Disease in the Urban and Rural Field Practice Area of a Tertiary Care Center in Puducherry, a cross-sectional study. In December 2019, the COVID-19 was identified in China, and the first laboratory confirmed case of COVID-19 was reported in India on 30th January 2020. Since then, there were exponential growth in the cases, with India ranking 4th in the global burden of COVID-19 in 2020. Within few months of this report, the COVID-19 has become a worldwide pandemic, significant threat to public health. In India, the highest number of cases in a day was 4,14,188 reported on 7th May 2021. Then there was a continuous decline in daily case. Now India reports 28 daily cases per million population in 15 to 20th July as compared to 8 to 13 July. All state and union territory has shown a decrease in cases except Andaman and Nicobar Islands, Naga Island, Mizoram and Manipur, and Sikkim, Kerala, Arunachal Pradesh and Telangana. Objective of my study is to evaluate the quality of life of post-COVID-19 infected people after 3 months of disease onset among the field practice area. Coming to material and methods, the study design here is a cross-sectional study, and the study setting is the rural and urban field practice area, and the study was done from August 2021 onwards, and the technique used here is sampling technique, simple random sampling technique. And coming to the inclusion and exclusion criteria, under inclusion criteria, above 18 years after 3 months of previously confirmed COVID-19 by RT-PCR or RAT population residing in urban and rural field practice area of a tertiary care center and willing to participate in the study were included. In exclusion criteria, the participants previously confirmed COVID-19 by RT-PCR or RAT less than 3 months duration, and population not residing in the urban and rural field practice area and those not concerned to participate in the study were excluded. The study procedure, the study was conducted among the previously COVID-19 infected patients after 3 months in the urban and rural field practice area of a tertiary care center. The first house was selected randomly, and then the subsequent house selected using simple random sampling. The housing list was done in urban and rural field practice area, and then the housing was included randomly in the study. And if any of the members of the selected house cannot be reached after 3 consecutive visits, the next house was included in the study. The selected population was interviewed using a pre-tested structured questionnaire after obtaining informed consent. The data entry was done in SPSS software 22 version, and the analysis done by using proportion and chi-square test with p-value of less than 0.05 was considered statistically significant. Of 200 of the 200 above 50 years of age showing poor quality of life, in which from male gender 55 in male gender 50% showed poor quality of life, whereas in female 55% showed poor quality of life. Coming to socioeconomic status, in middle class 54% showed poor quality of life, whereas in lower middle class 62% showed poor quality of life, whereas in lower class 61% showed poor quality of life. Coming to education, in higher school, the 57% showed poor quality of life, whereas in middle school 52% showed poor quality of life. In primary school 63% showed poor quality of life, whereas in illiterate 55% showed poor quality of life, whereas hospital admitted in government hospital showed 54%, in private hospital 23% showed poor quality of life. Coming to chronic condition, hypertension showed 69% of poor quality of life, whereas in diabetes 62% showed poor quality of life, whereas others 66% showed poor quality of life. In this, only the hospital admitted and chronic condition influenced the quality of life with the p-value showing significant with the 0.031 and 0.003 as statistically significant. Coming to conclusion, our study shows poor quality of life among above 50 years and more in female compared to male, and among educational status below high school certificate has poor quality of life. Those who are government hospital admitted shows poor quality of life, and suffering from chronic conditions shows poor quality of life. These are the reference for the study.
Thank you, Dr. Omrin. So, my request was to Dr. Shobha Madam, please, and Dr. Ganesh, please put forward the question. It was a good presentation by Dr. Omrin. My request questions from Madam and Sir.
How you have assessed the quality of life?
Ma'am, by WHO quality of life brief questionnaire, ma'am.
So you have not assessed the poor quality in which domain or something like that? It was not done.
No, ma'am, by 4 domains I have assessed, ma'am, like physical and social, psychological and environmental, ma'am. By taking
you have not individually presented that. That is why I asked.
Ma'am, actually I mentioned and I have corrected video. I have sent it, ma'am. They haven't played it, ma'am. It's old.
That was in the presentation. It was not there. That is why.
Okay.
Then how did you take that simple random sampling? You have gone to the houses, no? So
No,
how you have selected?
Ma'am, I collected the COVID positive list from our nearby PHC, ma'am. After collecting the list through table random, I selected the house, like the random houses, and we approached the houses, ma'am.
That means, so if there are more than one COVID patient in one house, what have you done? You have taken all them?
Yes, ma'am, I have taken them also, ma'am.
And you told that those who have come to the government hospital has poor quality. If I say that it is a confounding, what would be your...
Ma'am,
you told that those who are having attended the government hospitals had poor quality of life.
Yes,
if you
ma'am.
say that you are say confounding, it was due to confounding, what could be the other factor which are actually produce this?
Ma'am, maybe income, ma'am, their income status, so that they are approaching the government hospital.
So their living condition also should be difficult. Not so. So suppose if there are more than one COVID patient in your house, but you are going to take only one patient. In any method you can choose to take one without bias. Any method you know. Because you don't want to take all the other in the same house, because it will, the housing condition, all that will affect the quality. So you think that you are going to take only one patient, person from one house, but when you go there, there are 4 persons affected. Any method by which you can choose only one without any bias.
Ma'am, actually, I took those who are positive along with the cases also, ma'am.
No, I'm asking not that. You are not. My question is not clear. In a house, there are 4 positive patients. You will take only one because that was your strategy in your suppose.
Yes, ma'am.
So if there are 4, how can you take one without introducing bias in the selection?
I don't.
Yes. Arvind sir.
Maybe table.
Thank you, madam. So, Dr. Ganesha, do you have any questions?
1 or 2 questions. So, Dr. Fatima,
yes,
so here you have selected 200 participants from rural and urban area, isn't it?
Yes, sir.
So, how you selected rural and urban equal numbers? Is it?
Sir, actually, sir, I didn't have any proportion like for rural this much. Because my objective was not to compare between the rural and urban, sir. So, like, I took from the list how much I can take, sir. But in my study, like comparing to the urban and rural, there were less cases, sir, compared to urban people.
Okay. So another point is, so here you included above 50 years age group. Why only above 50 years age group?
Sir, above 50 years only showed poor quality of life, sir. Actually, the aging factor played a role here, sir. Actually, I felt so. Because the most of the younger people actually after getting COVID affected, they were like engaged with their occupation, sir. Like above 50 years, they were made to be in their houses, so they were psychologically also affected, sir.
But still you can compare, no? The relation between lesser age group and more age group. And another point is, with respect to any other limitations you are finding out in the study.
Sir, like I had only 1 month like period, sir. In case I have got like more months of duration, I could have even collected more samples, sir, so that I could have got better association results, sir.
So here, poor and good, what is the meaning of this poor quality of life? Whether you can...
Sir, like from the different domains, like I will be calculating the global scores, the mean of the 4 domains. From that, like from global score, a mean less than mean will be like calculated as a poor quality, and more than the mean from the global score will be taken as a good quality of life, sir.
But still, it is not correct, no? See, those who are in the borderline.
Yes.
So some of them may be poor. Suddenly they becomes good. Is it like that? Is it difficult to tell like that based on that?
Okay,
isn't it? Because many of the answers, if it is in borderline, it is difficult to interpret based on the result, isn't it?
Yes, sir.
Okay, thank you.
Thank you, sir.
Thank you very much, Dr. Ganesh and Shubha Madam. Thank you, Dr. Ambreen, for your presentation. So with this, we have finished the 8 presentations which were scheduled for this session. And all the postgraduate students have, with the limitations in the study, have done a good job presenting their abstract. May I request Dr. Ganesh to please conclude the session?
Okay, we'll come to the end of the session. So I thank Dr. Shobha Madam from Kottayam Medical College. Thank you, Madam, very much.
Thank you.
For being chair with us on behalf of organizing committee. And also I thank Aravind Kumar Singh, Dr. Aravind Kumar Singh from AIIMS Bhubaneswar. Thank you, sir. Thank you.
Thank you so much, sir.
So we'll close the session. So this completes this session. So next session will be connected shortly. Thank you. Thank you all. Thank you all the participants. Thank you all the participants. Okay. Thank you one and all.
Thank you.
Good morning, जी. Good morning. Yeah. हाँ जी मैम, प्लीज बताइए. हम्म. हम्म. हाँ. ओके. ठीक है मैम. लाइन लिस्ट तो मैं आपको भिजवाती हूँ कल, बिकॉज टुडे इज मेरा ऑफिस बंद है. हाँ, है ना. हाँ, तो जो भी लाइन लिस्ट या एंड at times our line list will not match totally with all your cases. वो आप मतलब because कई बार क्या रहता है कि आपके ओपीडी से जो केस रिपोर्ट होते हैं वो हमारी लाइन लिस्ट में नहीं आएंगे. हमारी लाइन लिस्ट में वो आते हैं जो जिनको हम चंडीगढ़ का एपिड नंबर देते हैं, जो हम इन्वेस्टिगेट, जैसे अब मोहाली से कोई ओपीडी बेसिस पे या ऑब्जर्वेशन में आया, then once it goes back we cross notify it to Mohali and then Punjab people investigate that case. तो वो लाइन लिस्ट में, बट आई विल ट्राई टू हैव अ मेजर आइडिया कि आपका क्या क्या रहा है, बिकॉज हम लोग जो मेरे पास लाइन लिस्ट होगी वो मेरी यूनिट की लाइन लिस्ट है जिसमें मैं चंडीगढ़ एपिड नंबर देती हूँ. तो बस बहुत कम होते हैं यूजली ओपीडी बेसिस पे, तो 2-3 केस ही होता है, ज्यादातर तो आपके एडमिटेड ही होता है, तो है ना. एंड एक आध ये भी हो सकता है कि कई बार वो जो केस आपने रिपोर्ट किया वो, जैसे अभी पिछले महीने एक आध केस रिपोर्ट हुआ, ऑलरेडी जिस डिस्ट्रिक्ट से आया था वहां से ऑलरेडी इन्वेस्टिगेट हो चुका था, है ना. तो वो फिर हम उसको डबल रिपोर्ट करके उसको अपनी लाइव लिस्ट पे नहीं लेते, बिकॉज दैट हैज ऑलरेडी बीन इन्वेस्टिगेटेड इन अनदर डिस्ट्रिक्ट. सो मतलब जस्ट मैं इससे पहले आपको बता दूं कि डोंट बी वेरी श्योर कि सब केसेस हमारी लाइन लिस्ट में होंगे, बट यस इट विल कैप्चर मोस्ट ऑफ द केसेस दैट हैज बीन रिपोर्टेड फ्रॉम 30. नहीं, उनकी लाइन लिस्ट पर डिपेंड करता है मैम कि मतलब वो जो केसेस होंगे कि वो कहाँ जाके इन्वेस्टिगेट हुए हैं, वहां से मैं वही कह रही हूँ कि एक बार ऑफिस जाके मुझे पूछना पड़ेगा, मतलब माय जो भी वो डेटा वेटा देखता है बंदा, कि वो कोई तरीका है निकालने का, देन आई विल गेट बैक टू यू. वैसे वो पहले देख लेंगे हैं कितने केसेस आप अगर लेके, वही मैं कह रही हूँ कि अगर आपको मेजरली क्वांटिफाई करना है ऑन द स्पेक्ट्रम ऑफ clinical diagnosis post polio, non polio AFP date को जो contribute कर रहा है, because it is now after 2011 it is only non polio AFP date that we are having, right? There is no polio, so आपको वो idea तो हो ही जाएगा, अच्छा खासा हो जाएगा, है ना, from the cases that are being reported. नहीं 49 तो कुछ ज्यादा लग रहा है मैम. आप ये कह रहे हो 2020 से लेकर 2021 तक आप 49 केसेस कह रहे हो? हाँ 19 का, हाँ, और से 21 का मे भी हो, क्योंकि इस साल तो जैसे अभी 14 केस हैं. ओके, तो 2020 में तो बहुत ही कम केस हुए, 2020 में तो पैंडेमिक ईयर था, तो पूरे साल हुए ही 8 या 9 केस हैं फुल रिपोर्ट. तो ये आई वाज वंडरिंग कि ये केसेस आपके पास कैसे आ रहे हैं 49, ये कहाँ
This is like not connected. Hello. Can you hear me?
Yes, ma'am.
Hello, can you hear me all?
Yes, ma'am.
Yeah, okay. Good morning, everyone. I welcome you all again for a short
I think the voice is not clear.
ഇതിപ്പോ തന്നെ പ്രൈസ് ഒക്കെ പറയൂ. മസാല വേണോ?
Your voice is breaking, madam.
Can you all hear me now?
Yes, ma'am.
Okay, thank you. So now we'll move on to introducing our chairperson. We have our first chairperson, Dr. K. Caroline Priya. She is a professor from Madras Medical College. Ma'am has got 12 years of teaching experience, and she has got 8 research publications. We welcome you, ma'am. Can you switch on your video, ma'am?
Good morning to all.
Yes, ma'am.
It gives me great pleasure to be here this morning.
Yes, ma'am.
Thank you, organizers, for inviting me to be the chairperson. Thank you.
Okay, thank you, ma'am. Now I would like to invite our second chairperson, Dr. Velavan A. He's currently working as an associate professor from Department of PSM from Pondicherry Institute of Medical Sciences, and he's got 7 years of teaching experience. And he is also a recipient of Vijay Narayan Award in the IAPSM conference. He also has 21 index peer-reviewed national international journals published. He's also a reviewer in 2 national journals. Sir, we invite you to today's IPHA Con.
Good morning, Manandal. Thank you, organizers.
Yes, sir. Now we shall start our session. There we have 4 presentations. We have 8 presentations, sir, today, and first 4 may be moderated by Dr. Caroline, ma'am, and the second 4 will be moderated by Dr. Velavan, sir. Is that okay, sir? Is that okay, ma'am?
Yes, yes.
Okay, sir. So
yes, thank you.
We would like to request Dr. Caroline ma'am, to start over and to read out the presenter's name and abstract title so that the video can be played.
Okay.
Okay.
Is it in the order in the
Yes, ma'am.
Google Sheet? Okay. So the first presentation is 793 on the offensive modeling risk mitigation strategies for the next COVID-19 wave in Delhi. And the presenter is Dr. Mridula Garg. Yes.
Greetings of the day to everyone present here. My name is Mridula Garg and I'm absolutely honored to be
Dr.
presenting my
Mridula, can we
thesis
have
on
your
COVID-19 modeling
presentation?
in Delhi. So this pandemic has shown us the importance of modeling studies and how they effectively govern government policies. Some models have been very successful, others not so much. And so we try to understand as to what led to gross failures of a lot of such models. And we realize that there are a lot of challenges that modelers face. So we would like to start with a disclaimer that no model can ever be perfect, but we can always try to make them more accurate by learning from previous models. So our objectives are primarily three: to model the COVID-19 pandemic in Delhi using a system dynamics model. Secondly, to assess the risk of the development of a third wave in Delhi in the year of 2021, and to assess the impact of different interventions on the advent of the third wave. So what new do we bring to the table? First of all, as mentioned, we use a system dynamics model, which makes it easy to visualize complex population dynamics. Secondly, there were no prior models for Delhi according to our literature search on PubMed, and that was a great lacuna in the current literature that we found. Thirdly, our model accounts for temporal adjustment of key variables. So, for example, we understand that R naught is not a biological constant, but rather time dependent, and so our model accounts for that. And there are a lot of other strengths of our model. So, as mentioned, we use a system dynamics model, and we would like to thank the COVID-19 localization group who helped us localize this model for Delhi. An SC model basically works on the principle of stock inflow. So essentially, the entire population exists in different stocks and they move from one stock to another based on different factors and delays that are incorporated into the model. Our stocks are mutually exclusive and collectively exhaustive. So this is an oversimplified version of our SEIR model. As you can see, there are different stocks for susceptible, exposed, infected, and resistant people, and people move from one stock to another based on different factors. So the data collection part of our model was pretty robust. We used a lot of different sources so that we could dampen down the noise that exists in the data. So we use a lot of government and non-government websites. We use research articles, not just from India, but from across the world. We used news articles so that we could understand what was happening at the ground level. And then we also used a lot of research that came out of our own college from the PSM and the microbiology departments. So once that we adjusted the model for Delhi, we started creating scenarios to simulate future possibilities. So the three primary scenarios that we created were around vaccination, lockdown, and a combination of both. And we tried comparing the outcomes to understand what is the most ideal solution to the current problem. So before I start discussing the results, I would just like to preface this by saying that ST models are best inferred as trend depictions, essentially how a pattern occurs over time, and they're not really accurate for calculation of absolute figures like deaths per day or new cases per day. So with that, our model predicts that there will be no third wave in Delhi as of 2021. This is considering the continuation of the current coverage of the vaccination that the Delhi government has been doing. So currently, the Delhi government is vaccinating at a rate of around 1,40,000 doses per day. And if we continue on that rate, even if we increase the infectiousness of Delta variant to 2.5 times the base variant, our results would still hold. So this shows that the effect of vaccine is absolutely crucial in the prevention of the pandemic. So as these graphs can also show that there is such a drastic impact of vaccination, and that is the most important intervention that anyone can come up with in times of emergency such as this pandemic. So we discussed the enforced lockdown, and I would like to preface this by saying that enforced lockdowns are just emergency measures. They can only delay a pandemic, but they cannot prevent one. So at this stage of the pandemic, where most of the people in Delhi have either become infected with the pandemic in the second wave or they were vaccinated, so most people are already resistant to the COVID-19 virus, and therefore introducing another lockdown at this stage does not really help much. It can actually be counterproductive because people who have developed resistance, if they stay for prolonged times at inside their homes, and if you do not accommodate for that with a robust vaccination plan, we might actually cause people to become susceptible over time. And once they again move into the circulating population, they will actually cause a burden on the healthcare system, something that we were trying to avoid in the first place. So this graph shows how the susceptible population varies with different vaccination rates. So a combination of vaccination and lockdown is the closest to reality, and it is also the ideal scenario according to our model. So we tried creating a heat map of the combination of vaccination plus lockdown, and we had very interesting findings. So when we have a very robust vaccination system, say to the tune of 4 lakh doses per day being administered, we see that the lockdown does not really have an impact on the advent of new cases thereafter. So a robust vaccination plan essentially obviates the need of a lockdown. Now, problems start arising when we have a lower vaccination rate. So something like less than 1 lakh doses per day administered, that is when a lockdown will start playing a key role. So currently the Delhi government, like already mentioned, is vaccinating people at a rate of 1.5 lakh doses per day, which is pretty ideal for the current situation. So our conclusion is that the course of the COVID-19 pandemic in Delhi over the next 4 months is going to be more or less uneventful. There are some very important few limitations of our model which also act as scope for future research. First of all, our model does not account for any other new variant. So for example, the Mu and Kappa variants that have been in talk recently, we cannot account for them because we do not have substantial data on the behavioral characteristics of these variants, and therefore we cannot model them. Secondly, and very importantly, vaccination data for India is very lacking. So especially the first dose data on Covaxin and also the differential efficacy of the vaccine on infection rate and severe cases and deaths is amiss. We understand that a vaccination might not be able to prevent breakthrough infections, but it can actually cause a sharp decline in the severe cases, and that is something that we need more solid data on. So for the government, our implications are that there is no need for a future lockdown if we continue vaccinating at the same level. And for the public, our model says that we need to keep taking necessary precautions to prevent another wave and also development of future variants. Thank you very much for providing us with this platform.
Do we have any questions from the audience? Yeah, I have two questions. One, can you explain your, in 1 minute, can you explain your model, Mridula? And also, can you tell me what software was used to analyze your data? You have to unmute yourself. Unmute yourself.
I'm so sorry. I'm so sorry. All right. Thank you very much, ma'am. I'm very honored to be here. So first of all, the software that we used to make the model was the Silico software. And then we used Excel to extract data out of that model thereafter. And that is how we analyzed our data. So ma'am, to explain the entire model in a minute is going to be a little tough. But so basically how system dynamics model works is that so people are essentially moving, there are different stocks that people exist in. So for example, a person initially is a susceptible person and they slowly move to the exposed population and thereafter the infected population. So this movement is governed by flows. So the flows here are affected by factors such as the infectivity rate of the virus, the contact rate of the virus, hygiene, all of that. So if there is vaccination, so people will move from the susceptible group to the temporarily resistant group. And all of this is dependent upon a lot of factors and it is a time varying thing. So for example, we know that people are not resistant indefinitely, right? People lose resistance over time. whether it be because of the COVID vaccine or it be because of getting infected by COVID itself. So again, after some time, those people that have been moved into the stock of temporarily resistant people, they are moved back into the susceptible population based on some time delay. So that is basically how our model works. It has three components: stock, flows, and time delays.
What are all the various associated factors that you took into account?
Ma'am, so we had a lot of factors that we tried incorporating. So first of all, regarding the virus. So for example, first we had the base variant and then it changed to the Delta variant in Delhi, right? So we tried incorporating the factor that there was an increased infectiousness of the Delta variant for the second wave in Delhi. We also took into account the factor that hygiene practices of the people were changing. So for example, wearing masks, hand washing, and social distancing. We also took into account the enforced lockdown that we had by the Delhi governments and the phase-wise reopening that they had thereafter. So we tried modeling it in stepwise manner, the way Delhi had it actually. And so a lot of other factors were the delay that there was in people recovering, the delay that was there in people getting infected, and then they're showing symptoms. Because we understand that there is an incubation period associated with the virus, and there's also a latent period associated with the virus. So not like if I get infected today, it might take some time before I actually start becoming infectious, and it will take a little more time before I start showing symptoms. So all of that.
So how generalizable is your results?
Ma'am, so we tried working on the sensitivity analysis of this project. And so there was one particular slide where I was talking about the fact that we understand that we do not have a lot of data on the Delta variant, right? So we are just basically trying to guess here based on other people's work. So what we tried doing was that we tried playing with the infectivity rate of the Delta variant. And so we brought it down to 2 times, we brought it down to 2.5 times. Yes, ma'am. So we saw that our results were still very valid. Sorry?
Is it specific only to Delhi or can it be generalized further? That was what
Okay.
I was asking.
Ma'am, so the data we have used is for Delhi right now. But if we change that data, we can account for any, like if you want to do it for some other state, some other country, we can very well do it. So the model that we used was not initially used for Delhi. It was actually used for London and thereafter for Mumbai and other places also. And we were the ones who calibrated it for Delhi. So the data here is for Delhi. Otherwise, it is generalizable.
Okay. Thank you.
Thank you very much,
Sir,
ma'am.
you have any questions?
Yeah, just one clarification. First of all, congratulations for presenting it well.
Thank you, sir.
What were some of the sources of your data? You said from various sources you have taken.
Yes, sir. So primarily we had the government website that was covid19.org. We were using that. And sir, we also had the Delhi, the Delhi bulletin that was updated regularly on daily basis by the Delhi government. Sir, also there were a lot of research articles from like not just Delhi, but like out from international articles also that were talking about the infectivity of Delta variant and the efficacies of vaccines. So we tried incorporating all of that. We used different data, and then we tried figuring out that which one fits best for the scenario in Delhi, considering our population, considering our socioeconomic factors and all of that. And sir, also there were some studies that were conducted by my own college. So the PSM department and the microbiology departments from our college, they have been actively working on research for COVID-19. So we have been using their data as well. And then newspaper articles also, because they were actually the ones reporting what was happening at the ground level. So that was how we realized that the deaths were being grossly underreported in Delhi. And we tried updating that in our model because newspapers were showing how the morgues were full and people were not able to cremate their family members because so many deaths were there that the crematories were completely full. So all of that data we collected from newspapers as well, and that is how we gathered our data.
Okay. Thank you very much.
Thank you very much, sir.
That's all from me, ma'am.
Thank you, sir. Shall we go on to the next presenter? Thank you, Mridula.
Ma'am, a small change in the order, ma'am. Just the next alone,
Yes.
we can call upon Dr. Sabira, abstract ID 382.
Okay. Okay. Abstract ID is 382, nutritional behavior change post lockdown. Dr. Sabira Alia and Dr. Sabira, you can start presenting.
Respected Chairperson, senior faculty, and my dear friends and colleagues, I'll be presenting my paper, Nutritional Behavior Change Post-Lockdown. My abstract ID is 382, and I am Dr. Sabira Alia Dakhar, demonstrator in the Department of Community Medicine, GMC, Srinagar. Introduction. An actual prophylactic step against the COVID-19 infection can be a balanced diet and nutrition. A positive behavioral change in our eating habits during lockdown must be sustained beyond the pandemic to ensure its long-term positive impacts. The pandemic and the corresponding lockdown seem to have had a stronger than projected impacts on the eating habits and the food choices in various forms. Objective: to assess the nutritional behavior change post-lockdown. Methodology: study design, a descriptive cross-sectional study design. Study tool: the study data was collected using an online questionnaire through Google Forms. The questionnaire was developed by the researcher and pre-tested in a pilot study on 30 people above the age of 18 years, and necessary changes in language, style, and responses were done following the pre-test. Selection of study subjects: all participants who were above 18 years of age. Study population: general population of Srinagar city. Sample size: taking prevalence from previous study, it came up to 167, but we recruited till 190. Sampling technique: convenience sampling. Statistical test: all analysis was done in Excel for descriptive results. Results: gender: 61% comprised of female participants, whereas 39% were the male participants. Marital status: 17% were married, whereas 83% were single. Change in body weight: 35% gained weight, 19% lost weight, whereas 46% had no change in body weight. When asked for the preference of home-cooked food post-lockdown, 73.7% said yes, 17.9% said no, 8.4% said maybe. When asked for whether they paid attention to the kind of food, 49.5% said yes, 29.5% said no, and 21.1% said maybe. Takeaway from restaurants: 42.1% said rarely, 8.4% said regularly, 11.6% said often, whereas 37.9% said sometime. Whether they paid attention to the cleanliness and hygiene, 91.6% said yes, 2.1% said no, 6.3% said maybe. Whether they had a balanced diet, 48.4% said yes, 22.1% said no, and 29.5% said maybe. Whether they paid attention to water and hydration, 61.1% said yes, 18.9% said no, whereas 20% said maybe. Conclusion: although there seems to be an onslaught of bad news in the pandemic, there has been a silver lining. That is, a visible positive behavioral change in the nutritional habits of the people. The need to practice a sustainable and healthy lifestyle continues to be the need of the hour, now more than ever. Implications: as life slowly returns to semblance of normalcy, there is a possibility of resurgence in unhealthy eating habits. It is crucial that the healthy habits adopted by people are carried forward. An individual who has started practicing and relishing home cooking food should continue the same, eating out occasionally instead of doing so regularly. At the end, the onus is on us to make our health and nutrition a priority in post-COVID life. These are the references. Thank you.
Good morning, ma'am. Yes, ma'am. Thank you so much, ma'am.
Shabira, so can you just take me through what, I mean, like what were the dietary changes that you found most peculiar to this COVID?
Ma'am,
How do you say it in?
Ma'am, I couldn't get it. It was breaking in between. Can you say it again, please, ma'am?
Yes. How do you say that this nutrition is better in lockdown period?
Yes, ma'am. Ma'am, actually, what we had actually done another study. This study was supposed to be done after COVID first wave, ma'am. But because we could not access the people, so we had we just did a small pilot study on people on their nutritional habits post prior to the lockdown, ma'am. So it was a very small pilot study. Then we got the idea of doing it post lockdown, thinking we would compare the changes before and after, ma'am. So since second wave came in again, so during first wave we had a trouble to do it because we couldn't access the people. So in the second wave, what we did was we did online study, ma'am, because that was more easier for people, and they were we knew that they would be able to do it and they would not come in contact with us because they were in a lot of fear to do that, ma'am. So through that pilot study, that small pilot study, we got an idea that there has been a post change, post lockdown nutritional behavior change, ma'am.
So your sampling technique, can you tell me a little bit about that?
Yes, ma'am. Ma'am, we took from a previous study the data of prevalence, and the study, it was done on post lockdown, the changes on how COVID emotional eating hampered their eating, ma'am. So we took they had 3 degrees, like mild, moderate, and severe. But the data on the moderate and the severe the prevalence data were quite similar. So we took the moderate change, moderate emotional effect on COVID eating habits. So according to that, we got a sample size of 167. But since, ma'am, it was an online survey, we could not put it stop exactly at 167. So it continued till 190, ma'am.
So can you tell me about the demographics of your population?
Yes, ma'am. Kashmir has 10 districts. So, ma'am, it's like Srinagar is the capital. So what happened is, ma'am, in the second wave, the lockdown didn't happen at an extensive period, but it was on small interval of days, and we had more of corona curfew. So the districts which had faced lockdown, they were not like the whole city had gone on a lockdown. It was on phase wise, ma'am. So it would be 5 districts in a one phase lockdown, then say 10 districts at the peak. It had all gone in lockdown, but it was from April 29 to 3rd May, ma'am. And then other districts would go in small, like 2-3 districts would go into lockdown in small intervals, but not at the same time.
So how sustainable are your study results, and how can you take this forward?
Ma'am, we can do a study again maybe after 6 months, or hopefully after 1 year, to see if this change has been carried forward, or there has been like they're going back to the previous behavior change. So we can do a study again, a follow-up study, ma'am, and then we can compare the results. Has there been a change? Like we did this immediately after post lockdown, ma'am. So that time we could have expected the results to be at of the favors we think, a positive change. So if we do a study again after 6 months and maybe 1 year, we can compare the results of both.
Okay, thank you.
Thank you so much.
Thank you, ma'am. Thank you, Dr. Sabira, for your presentation.
Thank you so much, sir. Good morning, sir.
Yeah, actually, your methodology is slightly not clear.
Yes, sir.
Have you done a pre and post study?
So we had done a pilot study, not a pre-study actually, but we had done it immediately during the winter months. Sorry, sir. So, like after lockdown, first lockdown had got over, and like we saw that people were becoming more relaxed and all. That time we had done a study, and we were seeing that was a small pilot study, so on only 30 or 40 people. Then we decided when the second wave happened, we decided to do this study again.
So you're comparing the results of pilot study and this study, isn't it?
Yes, yes, there was a good change. I mean, like since after first lockdown, people had become more relaxed. So there was like the result which we had were not so good. I mean, I would not say they were not very positive. It would be like I personally I would feel subjectively, I would feel that it would be the same even it would have been prior, because people here were very, very relaxed. So when second wave happened and mortality was very high here, sir, during second wave, COVID wave. So after that, when we decided, let's see how people are taking, because first wave had happened and second wave had happened. So what result we got was very much different, sir. So that's why we have titled this study as a positive change.
Okay, thank you.
Thank you so much, sir.
The next presentation will be number 278, COVID-19 Surveillance System Evaluation, Lucknow, Uttar Pradesh, India 2020. And the presenter is Dr. Surabhi Tripathi. Ma'am, you can start your presentation now.
Greetings everyone, myself Dr. Surabhi Tripathi. I am going to present COVID-19 Surveillance System Evaluation of District Lucknow, which we did in 2020. As all we know that COVID-19 cases and death have caused public health concern, Uttar Pradesh, which is the most populous state in India, established web portal for COVID-19 surveillance for guiding public health action. We evaluated the COVID-19 surveillance system in Lucknow district to understand its strength, weakness, and assess its usefulness. Our objective were to describe the surveillance system, the disease epidemiology, and to assess the attributes of the surveillance system. To describe the system, we interviewed health functionaries at both district and sub-district level. We selected 2 sub-district units purposely, having maximum and minimum number of cases. We used semi-structured questionnaire for interviews. We analyzed COVID-19 web portal data between March to September 2020 using Microsoft Excel. To assess attributes, we referred to US CDC guideline for evaluation of surveillance system to evaluate selected attributes of COVID-19 surveillance system. Simplicity was assessed by understanding of testing strategy for COVID-19 among rapid response team and surveillance team members of selected sub-district units. Data quality was assessed by person actually negative as against mentioned on DSO portal, and person actually having symptoms of SARI who were tested under SARI category, and also reviewed proportion of blank fields in the line list. Acceptability was assessed by frequency of district and sub-district level COVID-19 meetings held. Timeliness was assessed by speed of data flow of COVID-19 tests done from sub-district level to district level. We compared positivity rate, test per million, and death rate with state. Usefulness was assessed by whether increased tests had led to increased identification of containment zone. Now coming on to the result. All COVID-19 tested either in government or private lab are uploaded on DSO portal. Every day, data from DSO portal is extracted and disseminated to central and sub-district level unit. From sub-district unit, cases are allocated to RRT and surveillance team for activities. In evening review meeting, for home isolation, hospitalization, and contacts identified and tested are compiled and sent to DI office and from DI office to state. The surveillance system generated data was used to describe epidemiology of COVID-19 in district. Lucknow reported 54,730 cases between March to September 20. Most affected age group was 21 to 40 years of age with median age of 35 years. 65% males were affected. Out of reported cases, only 27% were symptomatic and about 1/4 required hospitalization and less than 1% required oxygen and ventilator support. Of 17 stakeholders interviewed, 16, that is 94%, were aware of case definition and testing strategies. The portal captured demographic and clinical information for 13,68,250 fields tests for COVID-19 and 10 had missing information. Out of 15 COVID negative, contacted only 13, that is 87% were actually negative. Like was 17 interviewed patients for COVID-19 mentioned in SARI category, only 2, that was 12% were actually having cough and breathlessness. All 19 sub-district units submitted report daily and district held more than one review meeting per day. Cases and death per million population were 10,017 and 142 respectively. That is 6 times higher than the state, and case fatality was 1.4. Surveillance was established at 19 sub-district units and testing result guided the containment activities in the district. So we found that simplicity, acceptability, timeliness, comparability, and usefulness was good, but data quality was poor. We can conclude that Lucknow COVID-19 surveillance system is useful in guiding containment activities. Lucknow had 6 times higher burden of cases and death per million than the state. Lucknow did more than double test per million than the state average. Periodic training and evaluation of data entry operator, RRT, and surveillance teams are required to improve the quality of their portal data. Thank you.
Good morning, ma'am. First, let me congratulate you on your excellent study. Ma'am, you're muted. Please unmute yourself. So,
now it is audible. Thank you, ma'am.
Yes. Yes, ma'am. So, very lovely paper presentation, ma'am. Just how to take this forward, ma'am? How are you going to improve, like the how better to improve the data? You said the data quality is a little poor. So how can we take this forward? And what are the things that will go into the details?
Actually, RRT and surveillance teams are hired in Lucknow for mainly for data entry and for testing. So these are hired vaccinators and data entry operator. So regular training when they are hired, when it is done, it is already being done, but frequent trainings are done so that we can continue for so that we can maintain the quality data.
This criteria, how simplicity, like you have interviewed the you have interviewed some health workers. So what have you actually, I mean, you said some semi-structured questionnaire. What have you actually asked?
Actually, for simplicity, I asked them what is the testing criteria when they are going to test the person for having some symptoms. Like for RRT teams, it was when they go, RRT teams mainly goes to positive patient to identify primary and secondary contact and to decide whether they need hospitalization or not. So for them, we interviewed on the questions like what are the primary contacts, what are the secondary contacts, to whom you will test. And for surveillance team, which mainly goes in the containment area, we asked them testing criteria like cough, fever, and breathlessness, some comorbidity existing or not. So this was the two different set of questions for RRT and surveillance team.
Ma'am, and you have mentioned Chinhal and Mal. So these are the areas, is it?
Hello.
I did not get that. Hello, ma'am. Which district or in Lucknow, where exactly you have taken the samples, ma'am?
Actually, Lucknow is divided into whole Lucknow rural plus urban is divided into has been divided into 19 sub-district units, and Chinhat is a block, rural block, which caters Gomti Nagar population also, and Chinhat was having maximum cases from March to September 21, and the number of cases was 1,641, and most of the cases was from Gomti Nagar, which is a posh area of Lucknow, and having 594 cases. And Mal is the interior block, entirely rural block of Lucknow, having only 96 cases between March to September. Therefore, we wanted to know whether what is happening, why the sub testing or sub district units are having more cases and other is having nil or no cases or less number of cases. That's why we selected them to identify whether there is any operational gap or something like that. That's why we selected maximum and minimum number of cases.
This was what sort of sampling you have done, ma'am, in this study?
For interview purpose, we selected 5 RRT and surveillance team from both maximum and higher number of blocks from maximum and minimum number of cases, and 10 person per block for COVID, like mentioned, who were mentioned as negative for COVID-19 on total or were mentioned in SARI category. We took that, and by calling them, we interviewed them on questionnaire whether you have been tested, yes or no. If tested, what was the result, what was told to you, and like in SARI category, whether you are having any symptoms of cough or breathlessness or not.
Okay, ma'am. Thank you so much. Dr. Velavan, over to you.
Thank you, ma'am, for sharing your experiences from Lucknow.
Thank you, sir.
What was your recommendation, ma'am? You said the data quality was poor. What was your recommendation?
Sir, actually, data entry is being done by data entry operator, and the data is collected by surveillance or RRT team, which consists of mainly ASHA and Anganwadi worker. So like in all other programs, only solution for this is frequent and regular trainings of data entry operator and for surveillance team, like for ASHA and Anganwadis. Okay. And finally, to check the data to take sample out from finally at the end of the day or end of the week or month to check whether all entered negative or not, and like something take sample of criteria mentioned in the line list to see that whether they are fulfilling that criteria or not.
Okay, ma'am. Whether any sero survey was done there, ma'am? What was the prevalence?
Yeah, sero surveillance was done initially and during that time and after that also, and sero prevalence was quite high. Sero prevalence shows that infectivity was more than from the surveillance data, from surveillance portal.
Okay, ma'am. Okay, thank you very much for this nice presentation.
Thank you, sir. Thank you very much.
Our next presenter is number 532, Pandemics and Social Media, Content Analysis of Government Agencies' Tweets During COVID-19 Pandemic in India. And the presenter is Dr. Parameshwar Satpathy.
Good morning, everyone. This is Dr. Parameshwar Satpathy, currently working as Assistant Professor in the Department of Community Medicine, Vimsar Burla, Odisha. Today I am here to present our topic titled Pandemics and Social Media, Content Analysis of Government Agencies' Tweets during COVID-19 Pandemic in India. Now, we all know the COVID-19 pandemic has scarred the world forever, spreading to more than 200 countries. The nations are not only fighting the virus, but also contagious misinformation by engaging in social media platforms such as YouTube, Google, and Twitter. Risk communication and community engagement is an integral part of a public health emergency response to prevent infodemics. The National Risk Communication Plan exists in India since 2016. Let's have a quick look at the Risk Communication Framework by Peter Sandman. Now, it consists of 4 quadrants, namely outrage management, stakeholder relations, crisis communication, and precautionary advocacy. What it basically deals with is, with an increase in hazard, what we see is an increase in the emotional response of people. Now, in our study, since we have taken the first wave of pandemic in India, it mainly deals with the crisis communication. The Twitter is a prominent social media platform with proven role in providing medical information. The risk communication during COVID-19 through Twitter has not been assessed in India. Attempts to analyze Twitter content for appropriateness of content delivered during the COVID-19 pandemic are still lacking. Moving to the objectives, to assess appropriateness of content in the tweets by various government agencies of India during COVID-19 pandemic, and to describe the risk communication approach used through Twitter by government Twitter handles during the COVID-19 pandemic. Moving to the methodology, for data collection, we selected the verified handles at the union or federal level, that is of Prime Minister, Prime Minister's Office, PMO, Home Minister, Health Minister, Ministry of Health and Family Welfare, Press Information Bureau, ICMR, the Director General of ICMR, and National Health Portal. We archived the tweets from 1st January 2020 to 30th June 2020 using Octopus software. Coming to the data analysis part, the content analysis was done using NVivo version 12 software. We used manual deductive coding to derive the sub-themes. 2 of the authors reviewed the tweets in the initial coding phase to develop the preliminary coding scheme. A codebook was developed which served as an assessment tool. The final codebook was developed based on extensive discussions among all the authors and after review of literature a priori and assessment of preliminary coding scheme. 2 authors coded the tweets. The coders then discussed and agreed upon the sub-themes before developing the themes. The intercoder reliability was checked with Cohen Kappa, and there was a strong agreement with a Kappa score of 0.75 and p-value 0.03. Coming to the results section, the classification of tweets for analysis, nearly 30,106 tweets were retrieved from the mentioned handles, and original 5,589 tweets were kept, and 14,918 reply tweets and nearly 9,500 duplicate tweets were excluded. Again, out of the original 5,589 tweets, the tweets which were not related to COVID, nearly 2,000 tweets were excluded, coming down to final COVID related tweets, that is nearly 3,386 which were included in the final analysis. 4 key themes emerged from the analysis of data, that is government instructions comprising nearly 35%, government measures, information, and emotions and feelings. The COVID-19 pandemic related tweets were primarily used by government agencies to disseminate information to the public. Moving to the table showing overview of themes and sub-themes, as we can see in the table, that is the sub-themes such as testing and diagnosis, self-care, hospital visits, NPI, and travel. Such sub-themes were converged into a single theme, that is government instructions. Similarly, sub-themes such as Atmanirbhar Bharat, monetary help or relief for farmers, development fund, such sub-themes were converged into a single theme such known as government measures. Then sub-themes such as masks, disease properties, corona warriors, health facilities, these were merged into a single theme called as information, and sub-themes such as condolences, supporting each other, and not to discriminate COVID survivors, these were merged into a single theme called as emotion and feeling or sentiments. having a look at the few tweets, a tweet which showing which was under government instructions is, let's have an example of that. NHP India's tweet on 14th Feb, that is the beginning of the pandemic, is standard recommendations to prevent infection spread include hand washing, covering mouth and nose when coughing and sneezing. So this is basically sensitizing the public to the eventual pandemic. Moving to government measure, this is PIB India's tweet on 13th May 2020. PM CARES Fund Trust allocates nearly 3,100 crore for fight against COVID-19 and 2,000 crore for 50,000 ventilators, 1,000 crore for relief. So this is how the government measures at the peak of the pandemic during the first phase. Then talking of information, MOHFW tweeted on 2nd May regarding some medication, that is hydroxychloroquine, which was the talk of the hour. So this was the information provided regarding its prescription medicine and not to be used without medical advice. And regarding emotion and feeling or sentiment, MOHFW tweeted again during the peak of the pandemic to keep a positive attitude towards the healthcare workers. Implications and conclusions. This study demonstrates the feasibility of using Twitter as an effective medium to conduct infodemiology studies, and Twitter handles of government agencies played a key role in dissemination of valuable health information. The tweets have attempted to follow the risk communication principles, and this was based on qualitative content analysis. For accurate analysis, the pictures, videos also should be included. So that's a limitation. These are my references. Thank you.
Thank you, sir, for your presentation. It is a very novel study and in the upcoming field of social media, and it's a good initiative that you have done this, sir. And questions are like, one thing is, how far is it, it is people only have this social media and only on smartphones. So how applicable is your study in disseminating? Of course, the youth will be reached, but how can we take it forward, sir? This is my question.
Good morning, ma'am. Speaking about which, basically risk communication is a domain which I have, recently unearthed, especially from the beginning of the pandemic. What happened basically was, I thought various studies coming up, people coming up with surveillance and everything. So I thought, what is it which will be in a quicker time? And basically, I was a senior resident in AIIMS Bhopal then. So I was a part of our RRT team. So I thought that what is a quicker mean? And what happened was, during the COVID-19 pandemic, the search of the Indian media or the Indian public, basically they were more into Google Trends, Twitter, YouTube, for any such new information that government was disseminating. So I thought, why not let me try and hand on risk communication. So that is how I got into this. We went ahead first with Google Trends. We saw how that is communicating. So as you asked about Twitter, so basically what we did was, we initially tried our hand at Google Trends, which I have got a publication in a highly reputed journal as well. Then went into Twitter, and we saw how it was taken ahead. And then again, this we are taking ahead by another research where we are confining to YouTube. So how our population is basically changing when we move. Also, when I compare Twitter and YouTube, Twitter is a more educational population that I see, more well-versed, and YouTube is more, almost everybody has access nowadays, also because of everything, because the schools also were, IT people, everybody was using this media. So those who were not having access, or those who were not educated earlier, even they had an access to this. So why not a simple means or cheaper means to reach to the public? So that was the whole idea behind it.
So, what is your take on WhatsApp? Because many people are using WhatsApp as a news, update, and we often get very much, false news and things like that. So, what is your take on that?
Yes, that is another study that we are working on. Basically, during the first phase of the pandemic, what we did was, it has not been conceptualized fully. The ethical is still to be done. Basically, the thing is, what we did was, since you have brought this up, what we did was, we selected groups, WhatsApp groups from different domains. Like, I had friends in IT sector, I had my brother in sports field, I had the group of uncles, aunties. So we basically selected 9 or 10 such different WhatsApp groups, and with their permission of all the group members and the group, I think we have admins, the group admins, we asked for them the data during the peak, during the initial phase, that is again, so, and that we have archived. So, well, it's up to, well, how we analyze it. It is it will be up probably by next year on the floors.
Yeah. You don't want your trade secrets coming out.
That is why.
Okay.
Yeah.
Okay, sure. Okay, so just how did you conceptualize this, the analysis part of it? Because it's very difficult to analyze such qualitative data. So can you just take us through that?
Yes. Basically, whatever softwares we have for qualitative, they're only for arranging whatever the data we do analyze. Ultimately, it has to be done manually, and then you feed it to the system. So content analysis, basically, myself and one of the co-authors, we started eventually by developing a code book. Code book developed, first we came up, we screened a few 100-200 tweets, and we came up with few coding for that. Along with that, we also researched previous literature on the this previous pandemics as well, and we saw what all Twitter coding and what all similar people have done in India as well as outside. And then we finally came up with the code book. Basically, it was an iterative process where we were doing something, we were coming up with a new one, we're adding with the code book, and probably every 15 days we had to have a meeting to chalk out the final codings. And eventually we went ahead with that. Then it was entered into the software NVivo, and finally the results are there for everyone to be seen.
Thank you. Dr. Velavan, sir.
Thank you, ma'am.
Over to you.
Thank you, Dr. Parameshwar, for sharing this innovative.
Good morning, sir. Morning, sir.
I was about to ask the same thing.
Okay.
How to handle this rumors which spreads through WhatsApp and other things. I think you replied for that.
Yes.
Because I know as soon as we saw your title, pandemics and social media. So the first thing which comes to our mind is about these rumors which drastically affect the public.
Correct.
So you answered it. Thank you very much. Nothing from my side.
Thank you, sir. Thank you so much.
Okay, next I think abstract ID 666, effects of COVID-19 lockdown on school-age children from an urban slum in Gulbarga city, Karnataka. The presenting author, Dr. Nilofer, kindly start the presentation.
Hello everybody. My topic for the 65th IPHECon 2021 e-oral presentation is effects of COVID-19 lockdown on school-age children from an urban slum in Gulbarga city. I am Dr. Nilofer Nas. I am a MD Community Medicine student from Mahadevappa Rampure Medical College. The co-authors for this study are Dr. Pallavi V. Tenglikar, Dr. S.R. Nigurgi and Dr. Shishal Godi. The introduction for my topic is, school closures carry high. My basic objectives for this study were to study the effects of COVID-19 lockdown on the education of the school children between 8 to 15 years of age, because class 3 to class 7th only had the access to online education in my area of study. And the second objective is to assess the mental health status of these children. The methodology we used is a study design, a community-based cross-sectional study. Study period is 2 months, that is between July to August 2021. Place of study is the Urban Health Training Center in Rajapur, Kalburgi. The sample size is 150 student participants and their parents. Sampling procedure is data collected from a questionnaire and child behavior checklist. Inclusion criteria, all school-going children between 8 to 15 years and their parents. Exclusion criteria, children below the age of 8. Student participants along with their parents provided response to a cross-sectional survey about their experiences during the lockdown period from March 2020 to August 2021. But duration of study which we used, the data collection program was carried out between 1st July 2021 to 31st August 2021. The basic method used in conducting the survey, the study was the survey method which used a questionnaire as a tool. A structured questionnaire with 20 questions was used to collect the general and relevant data. Consent was taken from the parents of the student participants. Questionnaire data was then imported into Excel program for a clearer and graphical representation of them, which facilitated their analysis and interpretation. Child behavior checklist was used to assess the mental health status. The scoring scale was analyzed using the Excel program. So, and with the important factors were calculated, and what are the distinctive respondents were concluded by using the Excel program. The results concluded were, first the socio-demographic factors, 129 students were from the upper lower category, 20 were from the lower middle and 1 from the upper middle. 36.7 of children percentage of the children from class 3 to class 7 who were from the government school had no access to online education and were unaware about the latest syllabus. Only 20% of the high school students from government school had some online classes and were able to cover the syllabus since the last 6 months. In comparison, private school children, that is about 43.3%, had access to online education and were updated with the syllabus. Another finding was the inability to access the online classes due to the absence of devices at the home of 32 students who were from the government high school, which constituted to about 21.3% of students. Here is a tabular explanation wherein you can see that the kids belong to the upper lower, the student participants belong to the upper lower category, 129 students, 20 to the lower middle and 1 to the upper middle. And these are the characteristics of the socio-demographic findings. Next is, you can see that the government school children from 3 to 7th class, 36.7% in the red mark, which showed that they had no access to any online education. Private school children from 3 to 10 had all the access. Government high school, that is about 20%, they also had some access to the online education. Coming to the count of devices at home, 32 of the children did not have any devices at home. Smartphone users were 114, tablet users were 3 and laptop users were 1. The child behavior checklist results are as follows. Based on the percentage, the attention related factors were found in 36% children, mood in 4.67%, oppositional behavior in 8%, anxiety worry in 2.6% and conduct in 1.33%. These are the scoring which has been incorporated into a percentage, wherein attention was in 73.04, mood in 11.3, oppositional in 10.43, anxiety 3.48 and conduct in 1.74. Finally, the conclusion was that 46% of the total respondents are impacted by one or the other factor during the COVID-19 lockdown. The other results, which included that the parents being worried about the children education being affected due to the school closures. This question revealed that 45.7% of parents were worried that their kids are not getting the required education. And some, like 54.3%, were still worried about the COVID disease and the protocol which will be followed in the school or not, and how safe their kids will be for going back to the school. Another important question was how much time are they spending playing games. So herein you can see the red line shows there is more than average and the blue line shows the average. That means most of the parents were worried that the kids are spending more than the average time for playing games or being outside, etc. The conclusion drawn is, like in most of the countries of the world, in India also the schools and students were not prepared for the abrupt shift in learning to online modes. School closures not only exposed the socio-economic educational inequality but also exacerbated as it relied on family support and resources. The closure of the schools has not only differentially interrupted the learning of the students but also restricted their opportunity for overall physical, social and emotional development in a way that could have lasting repercussions. We included certain points from the IAPSM recent advisory on opening of the school, which was given in a latest article. As per the UNESCO, over 32 crore children have been affected in India due to school closures. What started as a public health emergency has snowballed into a formidable test for the global development as well as development of the future generation. The loss of education during COVID-19 lockdown needs to be compensated soon by reopening the schools based on the COVID-19 scenario in the city. The schools can ensure preparedness by training the staff, vaccination of teachers and limiting school hours. Children must also be trained and educated by both parents and teachers to maintain the COVID protocol and avoid the spread of the disease. These are my references. And finally, a comparison picture wherein the left hand side picture is actually from the field practice area where you can find children are outside most of the time, and here in comparison that they can be in a classroom studying. So this is to conclude the study. Thank you everyone. I hope you enjoyed the presentation.
Thank you, Dr. Nilofer. Couple of questions.
Good afternoon, sir. Good afternoon, sir.
Yeah. How did you arrive at this sample size, and how did you select these participants?
Firstly, sir, the online class was going on only for the 3rd to 10th standard. So we were concentrating on the age group of 8 to 15 years. And the field practice area, that is the urban health center, the urban slum which we are catering to, the population is about 5,000. And the school going children were about 450, sir. So taking the sample size was like we randomly, it was a cross-sectional data. So randomly we went. So we reached to a conclusion that at least 150 students from all type of schools between the age of 8 to 15 years were selected, sir.
Was there like how many from private school or government school?
Yes, sir. We separated the data, sir. So 36.7 were for only from government school, 20 were from government, 20% were from government high school, and the remaining 43.3 were from the private school, sir.
Okay, you didn't follow any sampling technique in that.
No, sir. Based on the random studies, sir, because unavailability of the students was also there, sir, and schools were closed, sir. So we couldn't get the data from exactly from the schools.
Okay, it is an important study. What about midday meals? Is there midday meals being provided to school children there?
Few students, yes, sir. That was one of the question in my questionnaire also, sir. In the 20-item questionnaire which we selected, the government school kids up to from 3rd to 7th were getting the midday meal, sir. But from the past 1 month, even that they are not getting it regularly, it seems, sir.
Okay. Okay, thank you very much. Caroline,
Yes,
ma'am, can ask.
Thank you, sir. Thank you, sir.
Yes, ma'am. Did you find any difference between the urban and the rural children in terms of using in the social activities after school?
This population is also from the urban slum only, ma'am. They belong to Gulbarga area only. Actually, they come under urban population itself, so we did not find the rural kids more. And they were having that, most of them knew to use the devices and everything. But they were like playing outside. That thing we found it more, ma'am, than using the devices in these kids, actually. They were not attached to the gadgets as much, ma'am.
Okay. Because that's a good thing compared to like the children who are staying at home and fixed on the thing. So yeah, just wanted to.
That's why I incorporated that picture also. Yes, ma'am. Thank you so much, ma'am. Thanks a lot.
Thank you. It's a very important story. Thank you.
Yeah, thank you, ma'am.
Okay, we will move on to the next presentation. Article ID 766. Outcomes of home isolated COVID-19 patients of Ballari during first and second wave comparative study. Dr. Kusaba M.
Yes, sir. Good morning, sir.
Yeah, we can run the presentation.
Greetings, everyone. Myself, Dr. Kusman, and today I'll be talking about outcomes of home isolated COVID-19 patients of Ballari during first wave and second wave, a comparative study. Co-authors being Dr. Ramesh K, Associate Professor, Dr. Priyanka, Postgraduate, Dr. T. Gangadhar Gaul, Professor and Head of Department. Introduction. COVID-19 is caused by severe acute respiratory syndrome coronavirus 2, that is SARS-CoV-2 virus, identified in December 2019 in Wuhan. It has spread worldwide, and on 11th March 2020, the WHO declared it as a pandemic. This infection is transmitted from human to human through nasal route or oral droplets or through close contact. COVID-19 infection has a broad spectrum of severity, ranging from asymptomatic cases to severe acute respiratory syndrome, which may require mechanical ventilation. The main therapies being used till now are antiviral drugs, plasma therapy, monoclonal antibodies, respiratory therapy, and other supportive therapies. Though many therapies have been proposed, quarantine is the only intervention that appears to be effective in decreasing the contagion rate. Although quarantine was found to be effective, many developing countries like India with available limited resources were not able to quarantine all cases. Based on the severity of the disease, patients were either treated at their home or hospitalized. Ballari, a city of Karnataka state, also witnessed a surge in COVID-19 cases and hence resulted in establishment of home isolation. Objective. Objective of this study is to describe outcomes of home isolated COVID-19 patients of Ballari during first and second wave. Methodology. Study area is Ballari Taluk, Karnataka State, India. Study design is observational cross-sectional study. Study subjects are home isolated COVID-19 affected patient during first wave and second wave. Source of data is a digital record-based taluk-wise line listing of COVID-19 cases. Sample size being 22,330 entries. Statistical tests applied are frequency, proportions, and chi-square. Results. Table number 1 depicts distribution of age group in first and second wave. As seen from the table, we can make out majority of the patients affected in first wave belong to the age group of 31 to 40 years, which accounts 22.7% of affected population. Whereas in second wave, majority of the patients affected were in the age group of 21 to 30 years, that is 24.3%. Table number 2 represents distribution of gender in first and second wave. As seen from the table, we can make out that males were majorly affected in both the ways. Whereas 59.3% males were affected in first wave and 54.9% males were affected in second wave. Table number 3 depicts outcomes in first and second wave. In this study, we have seen majorly 3 outcomes, that is first being the discharge from home isolation, second is shifted to hospital for further treatment, third outcome being the death. So considering these outcomes, majority of the patients were discharged from home isolation in both the rooms in first and second wave. Whereas 92.2% patients were discharged from home isolation in first wave and 96.8% patients were discharged from home isolation in second wave. And 7.8% of patients were shifted to hospital in first wave. Table number 4 shows a relation between age and outcome in first wave. As seen from the table, we can see majority of patients shifted to hospital were in the age group of 41 to 50 years, and majority of people shifted, discharged from home isolation were in the age group of 31 to 40 years. When chi-square test was applied, p-value was found. P-value was found to be 0.00 and was statistically significant. Table number 5 again shows relation between age and outcome in second wave. Again, we can see from the table that majority of the patients discharged from home isolation belong to the age group 21 to 30 years, whereas 90 patients were shifted to hospital for further treatment under the age group of 41 to 50 years, and majority of the deaths, that is 36 deaths, were seen among the age group of 51 to 60 years. Again, when chi-square test was applied, p-value was found to be significant. Table number 6 represents or depicts relation between gender and outcome in first wave. As seen from the table, majority of the males were discharged from home isolation. Again, majority of the males were shifted to hospital for hospitalization, further treatment. When chi-square test was applied here, it was found to be not statistically significant. Table number 7 depicts relation between gender and outcome in second wave. Again, from this table, we can see that majority of the males were shifted and discharged from home isolation. Again, when chi-square test was applied, it was statistically not significant. So, Well, after applying chi-square test, we found that age was statistically significant, whereas gender was not statistically significant. Conclusion. Present study shows majority of the home isolated patients were discharged in both the ways compared to hospitalization and deaths. So hereby we recommend that home isolation is a good strategy to contain the disease. These are my references. Thank you.
Thank you, Dr. Kusuma. We could not see your slides, but we were able to hear the audio.
Yes, sir.
So, what are the factors which were affecting the outcome of your study?
So factors were like majority. What we saw is majority of the patients were discharged from home isolation. That is, majority of them were recovered from home as COVID-19, sir, in home isolation. So we would recommend home isolation as a good strategy when compared to other quarantine facilities. And since ours is developing country and with limited resources, we couldn't quarantine all the COVID-19 patients. So, and seeing this study, again, we can recommend or go with home isolation, which is a good strategy, sir.
No, I was asking what was the factors associated with the positive outcome and about those who are getting hospitalized? Did you find any association or something?
Yes, sir. Sorry, sir, for the interruption. There was tables were not able to seen. Once we see the results, we got to know that in first wave, majority of them were discharged from home isolation or recovered from COVID-19. But when we see the second wave statistics, we can see that there was a rise in hospitalization rate and death rate again. So, which shows that people didn't consider it like as they gave importance in first wave, people didn't give importance in second wave. There was some, there was slight increase in the hospitalization rate, which shows people may not have followed the COVID appropriate behavior during home isolation. So if people follow proper COVID appropriate behavior, then home isolation is a good strategy. Outcome will be very good, sir. Like most of them will recover from COVID-19.
Okay. Okay, thank you. I will request Caroline ma'am to ask.
Okay.
One question, data analysis, how did you take and how did you do the follow-up of how they were admitted or recovered? How did you do that?
Yes, ma'am. We approached district surveillance office here in Ballari. So they were line listing all these records, digital based. It was a digital record, ma'am. So through that, we approached a digital surveillance officer here, and we got the data to them, sir.
Okay, thank you. Thank you. Good presentation.
Sorry, it was technical issue. Thank you.
No problem.
Thank you.
Thank you.
Okay, next would be the presentation by Dr. Kavita. Abstract ID 890. She'll be presenting on impact of COVID-19 lockdown on glycemic status in patients with type 2 diabetes.
Introduction is the managing diabetes is more of an art. Diabetes mellitus is a chronic metabolic disorder characterized by persistent hyperglycemia. Type 2 diabetes mellitus accounts for around 90% of all cases of diabetes. In 2020, according to the International Diabetes Federation, 463 million people have diabetes in the world and 88 million people in the Southeast Asia region. Of this 88 million people, 77 million people belonging to the India. 1 in 6 people with diabetes in the world is from India. India has the second highest number of diabetes patients in 2019. The prevalence of diabetes in India is 11.8%. The pillars for good glycemic control are good lifestyle modification with the proper medication under medical guidance and follow-up. All these pillars may be shaken during this pandemic COVID-19 lockdown period. Objectives are to study the changes in glycemic status of the patients with type 2 diabetes due to COVID-19 lockdown, to identify the various risk factors associated with the glycemic control among the study population. Materials and methods. It's a cross-section study, was done at the Government Upgraded Primary Health Center, Kelampakam. Study duration is the April to July 2021. Sampling method based on the prevalence of diabetes, sample size calculated and sample selected by simple random sampling. Study populations are 350 type 2 diabetic patients who had attended NCD clinic and had good glycemic control in the past without any chronic complications and willing to participate were included. This was identified based on the previous follow-up clinical records. Exclusion criteria included sick patients, and both patients have established microvascular or macrovascular complications of the diabetes are excluded. Study 2, SME structured interview schedule with included demographic parameters, risk factors related to COVID-19 lockdown, fasting and postprandial blood sugar, and anthropometric measurements. Data entry and analysis with IEC approval. The data were collected and analyzed in MS Excel 2013 and also analyzed using SPSS version 22 IBM. The data expressed in percentages and means paired t-test multilinear regression performed to analyze the test of significance. Materials and methods. The definitions are according to ICMR guidance, targets for glycemic status in type 2 diabetes, the cutoff given for ideal, satisfactory, unsatisfactory, for fasting and postprandial blood sugar, blood pressure and body mass index. The results showed the frequency distribution of socio-demographic and behavioral risk factors assessment of the diabetic patients. 61% were women and 38.9% were men. Mean age of 59.27 plus 11 years. 52.2% were illiterate, 75% belonging to class 4 social class, and 81% were from joint family. 80% have the duration of diabetic between the 5 to 8 years. 90% of them altered sleep. 8% of them have exercise regularly. This figure shows interpretation of the glycemic status before and after lockdown. The unsatisfactory glycemic status of the fasting blood glucose is increased 81%. Before lockdown is having the 11%. The unsatisfactory glycemic status of the postprandial blood glucose increased to 95% after lockdown. The before lockdown they are having the 28%. The frequency distribution of the risk factors are that missing the once in 3-month blood glucose monitoring in government health centers, it's mostly that unavailable of transport is the main reason for that, 94%. Next one is crowded health facilities, 89%, and dependency on proxy to get medication or 88%. Reason for the psychological stress is the low income, is the having the 80%, and loss of job is 72%. Fear of COVID-19 infection is 80%. The loss of social gathering also 77%. And also reason for irregular medications for diabetes, missing medications for 82%, unavailable lab facilities 82%, lack of physician guidance also 79%. The statistical test we have produced, paired sample t-test, explain the significant average difference between the mean fasting blood sugar before and after lockdown. The t-value is 24.6 and the p-value is very significant. And also mean postprandial blood sugar before and after lockdown also very significant. T-value is the 23.5. And the mean difference is the BMI also, the 2.6 points higher than the pre-lockdown of BMI. The simple linear regression, this figure showed the positive linear relationship between the fasting blood sugar and the body mass index. This depicted the equation model also, the R square equal to closer than 1, the 0.83. The multilinear regression was run to fasting blood sugar having the multiple variables like age, BMI, BP, altered sleep, regular exercise, low income, loss of job, loss of social gathering, difficulty in getting the drug, and unavailability, lab facility. Variables all significant. These variables statistically significant predicted to fasting blood sugar after lockdown. The F ratio is 108. The P is significant value. R squared also 0.88. For conclusion, changes in BMI was a very important determinant for the worsening of metabolic disorders, where concerned and also only 8% had regularly exercised during lockdown. One of the most worrisome factor was a restriction to routine physician consultations. Study concluded a severe disruption in diabetes care activities during lockdown. The COVID-19 pandemic had created additional challenges for the healthcare sector and people with diabetes. Implications of my study explored the multi-dimensional factors like physical inactivity, altered sleep, regular exercise, low income, loss of job, loss of social gathering, difficulty in getting the drug, and unavailable lab facility, which affected the glycemic control among type 2 diabetes patients during COVID-19 pandemic. And this helped to plan and provide a comprehensive approach to maintain their glycemic status via promoting healthy lifestyle and preventing complications. These are references. Thank you.
Thank you, Dr. Kavita, for
Good morning, sir.
It's a very important study. You presented it well.
Thank you.
I just have a couple of questions. Can you share us, how did you identify this study participants based on what criteria?
The time to the previous records are NCD clinic. They have the record NCD card. They identify the patients in the NCD card itself. Sir. Before lockdown period, they having the normal blood sugar, fasting and postprandial is under control. That ideal category we selected. Sir.
Oh, did you have any cutoff for blood sugar values based on blood sugar values, or did you use any other thing?
No, sir. The ideal values.
No, you are telling no. They were previously having a good glycemic control.
Yes, sir.
Was there any cutoff value to identify those individuals?
Fasting was less than 110, sir. That postprandial less than 140. Sir.
No, I'm just asking, what about these study participants whom you recruited?
Okay,
did you apply any criteria to select them, or you selected all the participants?
No, sir. The daily they came for NCD clinic for 60 patients, sir. Only 10 patients they included for my studies. A simple random sampling they included for look on the previous record. I select for the 10 patients only, sir.
No, your final conclusion is there is definitely a pre and difference in the pre and post glycemic status.
Yes, sir.
Isn't it?
Yes, sir.
That's what I'm trying to find. What was their status before? Where everybody having a really good glycemic control before also. That's what I was trying to ask. Okay, thank you. Over to Caroline now.
I have one question. Did you look for any incidents of diabetic complications in these patients, and did you come across any? No, they have the follow for after 6 months. They that patients only put in the study participants. They don't have any complaints. All right. Okay, so okay, yes. So any, what ethically, what else have you done for these patients now that you have discovered that the level of sugar is higher than what is expected? Yes, sir. Ma'am?
Kavita, madam is asking you like what investigations you did during follow-up.
Net connection interrupted, sir. Sir, fasting, they look in the what all in the government setup, they do that fasting and postprandial blood sugar and blood urea, blood creatinine, serum creatinine and blood sugar and height weight I mustard, sir. And urine sugar.
Okay. Ma'am, you want to ask any other thing?
Thank you. You can go on to the next presentation.
Thank you.
Thank you.
So the last presentation will be pharmacy preparedness during phases of pandemic COVID in Odisha. Abstract ID 97 by Dr. Lakshmi Priyanka. Dr. Lakshmi Priyanka, are you there?
Good morning, everyone. My name is B. Lakshmi Priyanka, PG second year Community Medicine. I am going to present on pharmacy preparedness during phases of pandemic COVID in Odisha. I, along with my professor Sonali Kar, have done this study. COVID-19 pandemic is one of worst pandemic that struck world after Spanish flu in 1918. It stalled the entire healthcare system and caused every country to relook at its structure of healthcare delivery and building strategies that can cope and handle the panic caused by disease. Its widespread web-like series put pressure on accessory healthcare systems too, and most affected were perhaps the pharmacies. COVID-19 brought in complete change in city life to begin with. Stringent norms of lockdown, limited movements, home isolation, and desperate demand for an array of supplies and pharmacies. Study assesses the pharmacy in city Bhubaneswar in terms of their preparedness to cope with demands of disease and enhancement of role of pharmacists to provide cost-effective and consumer-friendly services. Objectives were to assess preparedness of COVID-19 appropriate norms in pharmacies of Bhubaneswar, to quantify the demand-driven services provided by different types of pharmacy in COVID times. Materials and methods. Study site was Bhubaneswar city, which is capital to state of Odisha. Study period was March to June 2021. Study universe. Private pharmacies registered under state drug control in Bhubaneswar city. Study design was an observational point descriptive study. Sampling. It is a multi-stage stratified random sampling. Inclusion criteria were private pharmacies in Bhubaneswar and those willing to participate. Exclusion were pharmacies that are run by government, which were excluded as they have had the stringent regulatory norms and access to data is limited and warrants a separate institutional ethical approval. Drug Control Office of State was approached. A list of pharmacy running under 3 administrative zones of Bhubaneswar was obtained. In each zone, 3 large pharmacies and 2 each from Apollo and Medplus and 3 small pharmacies were approached with a formal consent letter. Thus, 9 large and 12 Apollo and Medplus and 9 small pharmacies, total together 30 samples were taken. A study team was formed with investigator, pharmacy graduates and vaccine motivator staff and given specific responsibilities to observe and note the various study parameters using a pre-designed, pre-tested checklist. Data analysis. All questionnaires were checked for completeness and data was entered in a Microsoft Excel 2007 spreadsheet and analyzed using SPSS software. After application of inclusion and exclusion criteria and depending on willingness, 45 pharmacies at various levels were approached and eventually study results were obtained from 30 consenting and corporate pharmacies. Pharmacy was divided into 3, 40% were middle level, 30 were hospital attached and 30 were independent. Comparison was made between the 3. All staff in the facility-based pharmacy, 91.7% of middle level and 33.3% of small-scale pharmacy have received vaccination against COVID. This was because hospital-attached pharmacy were prioritized due to maximal risk to exposure. Income was greater than 20,000 rupees for the superior level for hospital pharmacies, and for middle level it was 10 to 15,000, and for small level it was less than 10,000. Physical barricades were made between dispensing counter. More was with middle level pharmacies. It was 91.7%, 58.6% for the attached to hospitals, and 44% for small scale. IEC charts on COVID preventions were predominantly put on both in all hospital first and middle level, but 51.5% only for small scale. Approximate mask use was seen in 88.9% for facility based, 66.7% for medium, and 44.4% for small scale pharmacies. Mode of payment involved use of sanitizers to clean hands after receiving money. 50% in middle level and 100% in small scale they used sanitizer, and both were used in 77.7%. Interestingly, in spite of reports, 77.9% of facility-based pharmacies reported a case of COVID positive in last 2 months, in spite of appropriate COVID behavior and full vaccination coverage of all its staff. This re-emphasizes the pertinence of stringent COVID appropriate norms in all levels of pharmacy, as the populations are second liners for disease management. Due to restricted movement on roads and also increased recommendation of home isolation for huge number of asymptomatic, 100% of middle level pharmacy were providing online services. They had a provision of feedback and scores were good. Drugs for severe forms like Remdesivir would be mostly out of stock in the close and middle level pharmacies. Adjuvants like vitamin C, vitamin D, zinc, paracetamol registered highest sales, besides antibiotic like azithromycin and doxycyclines. Conclusion was, it was a simple pertinent study. A great deal of robust preparedness was seen in all levels of pharmacy in city of Bhubaneswar. COVID vaccination is the major gap seen in these pharmacies, as government during the period of study had not made any decision upon opening of private pharmacies to manage vaccination. However, it is strongly concluded that pharmacy can be used as a media for disseminating positive information and service regarding a disease condition, and its multitude presence can be exploited to pass on simple community health messages and behaviors. These were the references. Thank you.
Thank you, Dr. Lakshmi Priyanka, for this nice presentation.
Good afternoon, sir. Thank you for giving me this opportunity, sir.
Can you briefly tell us more about the preparedness of pharmacy regarding procurement of stocks and availability of these crucial drugs? Did you have any data about that, or?
Sir, I have a data, sir. Sir, shall I open data, sir?
No need to open the data. If you can you just tell us overview?
Actually, use of sanitizer and gloves was more in facility based, sir. In middle level pharmacies also it was there, sir. But in small pharmacies they could not be able to maintain all those measures, sir. And IEC charts were available in all the three facilities, sir. Facility based, medium, and small scale pharmacies, sir. But the COVID vaccination was a major gap, sir. In all facility based, they have given vaccination. Medium level, it was up to 60 to 70%, sir. But small scale, only 50% was there, sir.
Okay, what about the Remdesivir?
Sir?
Remdesivir.
Sir?
Availability of Remdesivir.
Sir, availability was Remdesivir. It was stock out, sir. Actually, it was not available. Up to what extent they were asking, sir? Only some Remdesivir was available, and some they have sold it without any prescription also, sir.
Okay. Government purposes you were unable to contact because of the stringent
regulatory norms and all, sir, because of this social maintenance of social distancing. But we have contacted some, sir.
Okay. Okay, Dr. Lakshmi.
Thank you,
Over to Carolina.
Sir.
Did you look for any of the anticoagulants or any oral anticoagulants availability?
Yes, ma'am. Oral anticoagulant availability was up to minimum, ma'am. It was stock out every time. It was stock out, ma'am. It was sold without any prescription, also, ma'am, in small scale pharmacies, ma'am. But in facility based, they maintained. If a prescription is there, they sold, ma'am. In small scale, they have sold without any prescription, also, ma'am.
So that was a major difference, is it, between the large scale and small, many over the counter?
Ma'am, COVID
sale of
vaccination
drugs
was
were
the major gap, ma'am. Small scale pharmacy, they were not able to vaccinate 100%, ma'am. Facility based, most 100% they got vaccinated, ma'am. But even if vaccinated, some of them were affected, ma'am, due to repeated exposures and maintenance of all social distancing and all regulatory norms.
Your study was done in the first wave or the second wave?
No, ma'am. Second, we have
the
done
data
in
is
first
based on
wave
the
and first wave and second wave, ma'am. We have done in both, ma'am. Some we collected in first and some we collected in second.
Did you find any difference between the two?
Yes, ma'am. Even first
Was
wave, they were maintaining social distancing and all promptly, ma'am. In second wave, it was relaxable and negligible, ma'am. Maintaining
Okay, thank you,
mask,
Ms.
social
Yamita.
distance, ma'am. Thank you. Thank you very
Thank you
much,
so much
ma'am.
for your presentation.
I think we have come to the end of the presentations. Now, thank you all. Over to the organizers.
Okay, sir. Thank you, sir. I would like to extend my sincere gratitude to all the chairpersons and delegates for sharing their valuable insights and experiences. The next session will begin at 2:15. I'd like to request you all to have your lunch and kindly join us. Also, all the delegates are requested to have a quick glance at the posters which are displayed in the IPHCon gallery. Thank you, sir, and thank you, ma'am, for moderating the session so wonderfully. And I would like to look forward for your supporting sheets as well. Hope they have been shared with you. Could you receive, sir, ma'am?
Yeah, we will share it shortly.
Okay, okay, sir. Thank you, sir. So we will end the session for now, sir. Thank you.
Yeah, thank you, Caroline, ma'am. Thank you.
Okay, thank you so much. Thank you, Agnes. Thank you, sir. Thank you so much. It's been a pleasure.
Welcome. ഇതിൽ കൊടുത്തിട്ടുണ്ടേ എടുത്തിട്ട അതിൽ അൺമ്യൂട്ട് ഹലോ
റെഡിയാണ്
Good afternoon, everyone. Good afternoon, ma'am. Yes, good afternoon.
Good afternoon.
Good afternoon, everyone. Can you hear me?
Yes, you are audible.
So, Divya, should we start? Should we start? Hope you all had a good meal. We are ready to begin our third and the last session for the day. The sub-theme for this session is COVID and mental health, which is under the theme COVID-19 and related issues. And we will have 9 presenters in the session. And I would like to invite our chairpersons before we begin our session. So the first chairperson is Dr. Bardali, who is a professor at AIIMS, New Delhi. She has more than 18 years of teaching experience. She has more than 18 years of teaching experience, and her expertise is on non-communicable diseases, cancer prevention and control. Just a minute, ma'am. Sorry. Ma'am has also contributed to the WHO package of essential NCD interventions, and ma'am has around 120 publications to her credit. Welcome, ma'am, to the session. Thank you, Divya. Thank you. It's nice to be here. The second chairperson is Dr. Paramita Sengupta, who is the professor and head at AIIMS. And she's a professor since the last 11 years. And she has received an award on International Women's Day. She's presently an editorial member of IPHA. She has published around 50 papers in index national and international journals and wrote chapters in different books and modules. Ma'am is also the principal investigator in 2 projects, one of which is with Johns Hopkins. Welcome, ma'am, to the session.
Thank you. Thank you so much.
The third chairperson for the day is Dr. Manish K. Goyal. Sir is a professor in the Department of Community Medicine at New Delhi, and he has more than 16 years of teaching experience. He has received the Ford Foundation grant by IAPSM, and Sir has many Best Research Paper awards, both at national and international levels. And he has about 70 publications to his credits. We welcome you, sir, to the session. Dr. Baruddin ma'am, you can take over the session from here.
Okay, thank you, Divya. Thank you to everyone present here. And I would like to convey my greetings to my colleagues, Dr. Paramita and
Thank
Dr.
you.
Manish. Nice to see you here in this platform.
Same here.
Yeah. So, yeah, today's, I think this session is going to be very interesting as it deals with a very contemporary and an important subject which evolved over the last 1 year. And I'm happy that, there's so many research activities that have been carried out in relation to COVID and mental health, out of which the 10 most significant and, more relevant studies have been selected for today's session. So without delaying further, I would like to call on the first presenter, Dr. Manikanda Murthy. She will be talking about the sleep disturbances and stress levels among the postgraduate students during the COVID pandemic. So, Dr. Over to you. But Divya, I think they will be playing the video recorded thing, or how are they going to present, or you will be playing the video recorded?
The
recorded presentation.
The video will be played by the VNMC team.
Okay. Scan.
I am Dr. Manikanda Murthy, postgraduate, Madras Medical College. My abstract ID 20. My study topic is a cross-sectional study on sleep disturbances, stress levels, and burnout among postgraduate students during COVID-19 pandemic in a tertiary care hospital, Tamil Nadu. I am Dr. Manikanda Murthy, postgraduate. My guide is Dr. Vijay Kumar, Senior Assistant Professor, Institute of Community Medicine, Madras Medical College. Study introduction: coronavirus, a group of enveloped non-segment positive sense RNA viruses. Outbreak of infectious disease, including COVID-19, are associated with major psychological distress and mental illness, sleep problems, anxiety, stress, public health threat. The outbreak of COVID-19 in India remains a serious health challenge for healthcare workers. Very few studies address the sleep quality burnout of healthcare workers during pandemic events, especially in COVID-19. Studies of the above domain is lacking in the state of Tamil Nadu, especially in to assess the subjective sleep quality using prescribed sleep quality index PSQI, to determine stress level using perceived stress scale PSS, to measure the burnout using Massa burnout inventory among postgraduates. My study methodology: study design, cross-sectional study population, postgraduate students of College, Rajiv Gandhi Government General Hospital and associated institutions. Study area: Madras Medical College and Rajiv Gandhi Government General Hospital and associated institutions. Study duration: 1 month, November 2020. Inclusion criteria: postgraduates who have attended COVID duty from April 2020 with COVID outpatient clinic, inpatient clinics are reward, COVID IPD block, COVID ICU, isolation ward, and COVID care. Exclusion criteria: not perform duties in the above mentioned areas. Methodology: sample size derived.
Actually, there's a lot of echo.
Using the formula S squared PQ by D squared. Sample size alpha value 1.96. Prevalence rate 75%. Sleep quality in parent article. Absolute precision of to derive this total sample size 160. Data collection: a personal postgraduate students of Madras Medical College and Rajiv Gandhi Government General Hospital. Information about the study: Google form questionnaire with consent form. Analysis: the data entered in MS Excel and analyzing using SPSS versus 16. Descriptive statistics expressed in a percentage, and inference statistics done using the test. Consideration: ethical approval is obtained from the Committee of Madras Medical College. Results: the female postgraduate 35% of female graduates and the male 65% of postgraduate participate in the study. Specialty wise, the surgical specialty 28% and medical specialty 72% participate in the study. Perceived sleep quality and perceived stress scale. Perceived sleep quality index global score 0 to 4 considered as a good, and 5 and above is considered as poor. The prevalence of poor quality sleep quality is 95.4%. Overall mean PSQR was 9.0 plus or minus 3.254 standard deviation. PSS score 0 to 3 considered as a low stress, and 14 to 26 is considered as a moderate stress, and 27 to 40 is considered as a high stress. The prevalence of stress severe stress 13.9%, moderate stress level is 75.5%, low stress level 10.6%. Score was 79 minus Maslow-Banot Inventory. I feel 82.5% of participants I have emotionally drained from work. 88.10% of working with people always train for me, and 81.50% of I feel burnout my work, and 76.40% of I worry this job is hardening me emotionally, and 86.10% of in my work deal with emotional problems very calmly. Association between specialty with PSS and PSQI. The specialty is divided into medical specialty and surgical specialty. Associated with the perceived stress scale, P value is 0.601, and specialty association specialty with association of PSQI, P value is 0.598. No statistical significant association between specialty with PSS and PSQI. Association between age category with the perceived stress scale and PSQI. The age category divided into less than 30 years, 31 to 40 years, and above 40 years. Associated with the PSS, the P value is 0.03, and the age category associated with the PSQI, the P value is 1.0. The statistical significance association between age category and PSS with 78% of postgraduate less than 30 years had moderate stress. Association between PSQI and PSS, the perceived stress scale divided into low, moderate, and severe. Associated with the PSQI, P value 0.037. Statistically significant association between PSQI and PSS with 76% of postgraduates with poor PSQI had moderate stress. Implication and conclusion: poor sleep quality and stress among healthcare workers would affect their performance and their clinical skills, thereby increasing the risk of committing medical errors that can affect quality of service delivered to the patient. Therefore, prioritizing the medical health of healthcare workers during the COVID-19 pandemic should be a matter of concern. Periodical interactive session and a de-stress session for the healthcare worker so keep us their mental health. Ensuring daily supplies of protective equipments, meals, and provision of accommodation and places for rest and leisure activities to make the workplace a better one. The reliance of cross-sectional study does not allow us to analyze sleep quality and stress over some time. Thus, data from different stages of pandemic stage are lagging. Our questionnaire did not address potential confounder, example caffeine, nicotine intake, diet, medical history, and coexisting sleep disorder such as obstructive sleep apnea. These are my references. Thank you.
Thank you, Dr. Murthy. That was a very interesting study, and yeah, I am sure there will be a lot of questions, but since we have a time limit,
Thank you, ma'am. Yes, ma'am.
Yes, I would like to invite our co-chairpersons to maybe ask one question each. Dr. Paramita, over to you. Do you have any question for Dr. Murthy?
It's okay. You can continue with the sessions, and then we can ask certain questions if we have time.
Okay, Dr. Manish, do you want to ask any question? Okay, no, nothing. Dr. Manish, you want to say something?
Yes, ma'am. Am I audible, ma'am?
Yes, now you're on.
Yes. Dr. Murthy, just I want to ask.
Good afternoon, sir. Yes, sir.
How we can plan for, you are saying that they might be having a poor sleep quality and all those things. So do you want to address some suggestions for that also? That is my question.
Sir. I am also the postgraduate of community medicine. Okay, sir. I also the postgraduate of third year community medicine PG. Myself and a lot of PGs feeling stress and poor sleep in hostel and duty PG. We share the feeling about the bad sleep and stress. So to aim for to study the postgraduate for COVID pandemic time, sir.
Okay. Is there any other?
These are all factors I tend to study for postgraduate.
There's one question in the chat box. What about the outcome? So Dr. Anish has asked this question, what about the outcome? So if Dr. Murthy can answer that.
Study outcomes. This the prevalence of stress, severe stress in 13.9%, the moderate stress levels in 75.5%, the low stress level in postgraduate is 10.6%. The mass log drain out among inventory, this is I feel emotionally drained out my work in 82.5%, and these are all I found out. For 1 minute, ma'am. Feel out my work 81.5%, emotionally drained and 82.8%, strain duty, my duty work is 88.7%, hardening my job is 76.2%. The most of the facilities sleep is it is moderate stress level, and the PSQA of are bad in sleep quality index, all are in the postgraduate.
Okay. Thank you, Dr. Murthy. Thank you for your clarification. And so let us move on to the next presentation. So the next presentation will be by Dr. Sankar Mani Ranasamy, the psychological impact of work from home among software professionals. So can we get Dr. Sankar Mani's presentation, please?
Morning all. I'm here to do a presentation on the category 67, psychological impact of work from home among software professionals in Tamil Nadu during COVID-19 pandemics. And my name is Dr. Sankar Mani Ranasamy Madhivanan, postgraduate from Institute of Community Medicine. And my guide is Dr. M. Vijayalakshmi, who's professor at the Institute of Community Medicine, Madras Medical College. India has become a digital capabilities hub of the world, with around 75% of the global digital talent present in the country. Software company jobs are known to be more competitive and stressful because of the nature of work like target achievements, night shift, and workload. In recent years, there has been increasing acknowledgement of the important role mental health plays in achieving the global development goals. And in India, the precipitate outbreak of COVID-19 resulted in an economic crisis and a high unemployment rate. Justification: software development process is a learning and communication process requiring greater interaction with the clients, deep understanding of the business process, and insight into the technological innovations. Owing to the pandemic, software professionals are forced to work from home against their routine, and significant changes in their daily lives due to the fear of contracting the virus. These situations put pressure on the professionals, resulting in professional stress, alcohol consumption, and development and risk of developing depression. Objectives: to study the prevalence of professional stress, risk of developing depression, and harmful alcohol use among software professionals working from home during COVID-19 pandemics, and to study the association between professional stress, risk of developing depression, and harmful alcohol use among software professionals during the COVID-19 pandemics. Methods and materials. The study designs a community-based cross-section study and study duration of 2 months from May 2021 to June 2021 with data acquisition of 2 weeks. Study population was software professionals working in Tamil Nadu. Sample size was calculated using the formula n is equal to z square pq by d square, where value of z is alpha at 0.05, p is prevalence of harmful alcohol use, which is 14% based upon study by Darshan et al, and d is absolute precision of 5%. And considering 10% non-response rate, the sample size was calculated as n is equal to 209. And multi-stage random sampling was done, and Chennai City was chosen for the study by simple random sampling. And out of the 4,000 more software companies in Chennai, 4 companies with more than 500 employees were chosen by simple random sampling. And proportional sampling was done among the 4 companies, and 52 study participants were selected from each company. And if any subject did not meet the inclusion criteria, the person was skipped and next name was chosen. Inclusion criteria: adults who are working as software professionals in Tamil Nadu, and adults who were employed prior to COVID-19 pandemics. Exclusion criteria: adults who were not willing to take part in the study, and adults who were on treatment or withdrew from treatment for stress, depression, or de-addiction. Ethical approval was obtained from Institutional Ethical Committee, Madras Medical College, and data collection was done using pre-tested semi-structured questionnaire through Google Forms from software professionals working from home in Chennai who gave consent for the study. Study tool is a questionnaire through Google Forms, which consists of 4 sections. Section 1 consists of social demographic profile. Section 2 includes a question to screen for risk of depression based on the Center for Epidemiological Studies Depression Scale questionnaire. And Section 3 consists of questions for screening for stress based upon the International Stress Management Association UK questionnaire. And Section 4 includes questions to screen for alcohol abuse or dependence based upon the alcohol use disorder identification test questionnaire. Analysis was done using MS Excel, and the data was entered in MS Excel and analyzed using SPSS version 16. Appropriate descriptive and inferential statistics were used to analyze the data. Chi-square was the inferential statistic that was used. And results showed a total of 209 subjects participated in the study, and mean age of study was found to be 30.77 years with a standard deviation of 5.46 years. The minimum age was 19 years and maximum age was 46 years, and 26 to 35 years of age contributed to the major extent of the study, which was just 61.2%. 70.3% of them were male and 29.7% were female. 70% of the study participants were living in nuclear family and 23% were non-nuclear family. 20% of them had some form of comorbidity, while the rest 78% were healthy. 58.8% had lived in a rental house, while 41.2% lived in their own house. The mean monthly salary for the study participant was 54,518. And the figure one shows interpretation of audit tool, where 44% of them were abstinence who never consumed alcohol, and 30% had low risk of alcohol consumption, and 15% had high alcohol dependence, and 11% had harmful alcohol consumption. Figure 2 shows interpretation of ISMA tool, where 3% were least likely to suffer from stress, and 46% were suffering from stress-related ill health, and 51% were more prone for stress. And figure 3 shows the risk of clinical depression, where 19% had no risk of developing clinical depression, 81% had high risk of developing clinical depression. And studying about association between each of them. First, we did a study on risk of depression and harmful alcohol use with risk factor as professional stress, and we found a p-value of 0.5 for risk of depression and risk factor as professional stress, and p-value of 0.039 for harmful alcohol consumption with risk factor as professional stress. And then we did another association where we took a risk of depression and professional stress and alcohol consumption as a risk factor. So the risk with alcohol consumption risk factor, risk of depression was found to be significant with p-value of less than 0.05, and with the risk factor of alcohol consumption and professional stress was found to be significant with p-value of less than 0.043. Then we took a risk of developing depression as a risk factor, and we studied on professional stress and harmful alcohol consumption, where risk of developing depression as a risk factor, professional stress was found to be significant with p-value of less than 0.05, and risk of developing depression as a risk factor, harmful alcohol consumption with a p-value of less than 0.002. And in the matrix shows the high risk of depression among alcohol consumption and professional stress, where based upon this matrix, low level of alcohol consumption and low level of professional stress play a significant role in developing a high risk of depression. Implication in our study, males were more number than females, which reflects similar findings with female contributing only 25% in Europe and 20% in US. In our study, 50.7% found to be professional stress and 80.9% were at risk of depression, and 26.8% had harmful alcohol consumption. Compared to the study by Darshan et al., the professional stress was 51.2%, risk of depression was 43.4%, and harmful alcohol use was 39.5%. Conclusion, the study clearly shows higher levels of professional stress, risk of depression, and alcohol use among software professionals working from home during COVID-19 pandemics, and the levels of professional stress, alcohol consumption, risk of depression has strong association which has statistic significance with a p-value less than 0.05. This will lead to a significant increase in the incidence of psychiatric illness among them. Recommendations: to promote better health, organizations would need to implement frequent online counseling, promote self-care practices, and preventive strategies involving family members. Frequent screening to detect the professional stress, depression, and harmful alcohol use at an early stage, and appropriately addressing these concerns could enable software professionals cope up with their jobs better without compromising their lifestyle or health in this vital scenario. Limitations of the studies were only screening questions were used and no other causal factors for risk of depression, stress, or harmful alcohol use were used. And the study was conducted on software professionals working from home in Chennai, hence the results cannot be generalized. And these are the references that have been used for the study. Thank you.
Thank you. So that is indeed a very nice, interesting study, and it's. I am surprised to see that you could get the, at least 50 participants in each group from each of those, the sites. So it seems to be a very high risk of depression, 81%. So, Dr. Shankar Mani, what is your the ethical issues related to this study? What did you do to those people whom you had diagnosed as at high risk for depression? Did you hear my question? What did you do to the people, to those subjects whom you diagnosed with depression?
He's not there.
He's not there? Hey, he's there.
He's there. Yes, yes.
Can you hear my
mic?
Actually, we cannot hear you, Dr. Shankar Mani. Yes, did you hear my question? What I was asking is, what did you do to the people whom you have diagnosed with depression? From the ethical point of view, what did you do to them? I think he's having some network issues. I cannot hear. Can others hear? Or maybe we can come back to Dr. Shankarmani later on. Once.
Should I ask?
Is it audible?
Yes, now it is audible. Yes. Now, Dr. Pramita has a question for you.
Yes, ma'am.
I just wanted to know, how did you choose the 52 respondents from the 4 companies? Because you said there were so many 500 respondents or something from the company. So what was the mode of selection of samples?
Okay, ma'am. Actually, we spoke to the managers, like HR department. Actually, we informed the HR department and we got a numbers map. And after that, we asked them to choose randomly from the list of employees. We didn't ask them to do like select from one shift. We told them to choose all the members from the company and randomly use a random generator. We told like randomly choose every 10th person from the list you have got from the name of employees in your list.
So it was the HR who selected, HR of the companies who selected the individuals.
But we got the list. No, we got the list from them and we selected the list. We selected the candidates. We got the list from HR, total number of employees list.
Okay, and how many fell out of the study? Because it was in a Google form.
Actually, yes, ma'am. The Google form we gave option like yes or no, and we had like nine respondents who told like they're not willing no. So once they tell no, like it'll directly skip to the last page.
Okay, so another question was like
9 of them
alcohol. No, another question was like alcohol consumption. You said there was much of alcohol consumption. Did you? But you also said that
yes,
more than 70% were males. So it is more likely that they were previously,
yes,
they used to drink. And what did you find out whether they were previous drinkers? They used to drink alcohol or not?
Yes, ma'am. Most of them, they mentioned that they used to drink, but what they told us like their frequency of drinking was very less. But during lockdown, they told like the frequency has increased.
But you can't say that alcohol consumption, because there is more of males and less of females. If it was same proportion of drinker.
Yes, ma'am. But actually, he also found. Pardon, ma'am?
Was there this alcohol consumption was more amongst females also?
Not high, ma'am. There were very less alcohol consumption among women.
Okay, so thank you.
Okay.
Okay, thank you. So let us now move on to the next. Thank you, Dr. Shankarmani. Now we can move on to the next presentation. Let us go to Dr. Hansika Popley. She will be presenting on the assessment of mental health among dental students amidst the COVID-19 era. So can we have her presentation, please?
Greetings for the day. Myself, Dr. Hansika Popley, postgraduate student, Department of Public Health Industry, and I'm here to present a paper on the topic Assessment of Mental Health among Dental Students amidst the COVID-19 era. Introduction. What mental health needs is more sunlight, more candor, and more unashamed conversation. The World Health Organization, as we all know, has declared COVID-19 as a pandemic. It has become one of the major challenges to the public health professionals all around the world. Considering our dentistry as a profession of practice, dental students are perhaps also affected in their immediate and distant future regarding various unlearned manual and cognitive skills, which are very necessary for this profession. Strategies to encourage students to manage their feelings during a health crisis and motivate them to maintain their physical and mental health are the pressing issues for the college and universities residing in India and all over the world. Therefore, the objective of my paper is to inspect the impact of COVID-19 pandemic on the mental health status involving psychological and educational as well as depression score among the current undergraduate students of a private dental college of Sriganganagar, Rajasthan. Material and methods. So the study design and population for this ethical clearance was taken from the Institutional Ethical Committee of the private dental college. Cross-sectional study was conducted in the month of May 2021. A convenient sampling technique was used to pick students for the study. Inclusion and exclusion criteria. All the students studying in the private dental college from first year to final year and interns who agree to participate in the study after signing informed consent were included in the study. Data collection was done by sending them a Google form in a pre-tested and validated questionnaire through the various modes of communication. Total of 250 students were approached, out of which only 219 forms were selected, rejecting the unanswered and partially filled, detecting the dropout rate as 13.6%. Questionnaire was divided into three parts. The first section consists of socio-demographic data, which include age, gender, and year of the study. Second part consists of mental health, and it was divided into psychological impact having 4 questions and the educational impact having 5 questions. And the third was depression, which was screened using the patient health questionnaire number 9. Data was analyzed using the IBM SPSS version number 23, chi-square test, ANOVA, and correlation tests were applied, keeping the level of significance as p less than 0.05. Here are the results of the study. Table 1 shows the demographic characteristics of the undergraduate dental students, and we find that the age of the participants mean age was 21.9. Females were higher as compared to the male with percentage of 66.2. Second year students mostly participate in the study with the percentage of 26. Table 2 shows distribution of the psychological impact items among the undergraduate student, and here we find out that all the results were non-significant, therefore no post hoc Turkey test was applied. Table 3 shows distribution of the educational impact items among the undergraduate student, and here we find out that the future professional perspective item was significant with the course year having a p-value less than 0.05, and therefore the post hoc Turkey test was applied, which showed the significant differences. Table 4 shows severity of depression according to the patient health questionnaire number 9 among the undergraduate dental students, and we find no significant results in this table. But the most number of the students were from the mild depression criteria. Table 5 shows correlation between depression score with the psychological and educational impact, and here we find out that there was a negative correlation between the psychological impact quotients with the depression, whereas there was a positive correlation among the depression score with the educational impact quotients, and the results were highly statistically significant with p-value less than 0.01. Conclusion and implications. From the study, it can be concluded that although COVID-19 has disturbed the life of students and had a very negative effect on the mental health status, as well as there is prevalence of depression too among them, but no significant differences were concluded between the different academic years undergraduate students. According to TCI notice, which was for the advisory of COVID-19 to the dental colleges, it was found out that in the section for the undergraduate students, point number 10, it was found that during this period, it is easy for students to be affected by the disease associated fear and pressure. Dental colleges should be prepared to provide professional psychological services to those who need them. Therefore, even for sub-threshold and minor psychological distress, the government and private colleges should combine to provide continuous and comprehensive mental health care services during this crisis to reduce the risk of escalation complications. Here are my references. Thank you very much for your kind and patient listening.
Thank you. That was a very nice presentation. And I would just like to ask if we can allow just 2 questions. If anyone wants to ask a question? If anybody does.
Why did you do only amongst dental students? Everybody is stressed, right?
Ma'am, actually, I am from a dental college. I'm doing post graduation in a dental college, so it was easy for me in at this time to choose this type of population, as it the communication with the students was good. So I
And
chose.
yours was a convenient sampling, right? Very
Yes,
good. You
ma'am.
presented at least in a community medicine conference. Good.
Thank you,
Ma'am,
ma'am.
I want to ask question. Am I audible?
Yeah, yes, Dr. Manish. Yes. Please carry on.
Dr. Hansika, you are saying that COVID has an impact on the mental status of the students. Have you have some data regarding the mental status or maybe stress level before COVID in this type of population? And so that we can say it is high or low.
No, sir.
So it may be
Actually,
routinely
before
also, without
COVID,
COVID also, the students might be having so much stress and all these factors. And maybe it is
yes, sir,
more
yes, sir.
in
It
routine,
can
and
be
maybe
there.
COVID has reduced it also, because in my perception they are in homes
Yes,
and
sir. Might be
families.
because sir, actually the quota and all the tests and actually classes are also on the online, so maybe the stress has been reduced also. But I think COVID has impacted students, and my study also shows that there is more impact on the psychological impact is greater, but on educational impact it has not affected yet. More
The
impact is
quicker
on the
and lesser
psychological
become.
part than the educational.
First, I want to say whether it is more or less, because can we compare? I think to say that it is high without knowing the baseline becomes too much.
Yes, sir. So I can prepare one more topic like comparison before or after.
You can refer to different studies among undergraduate dental students. What is their routine mental stress level, and then we can compare. If it is high, certainly we should do about it.
Okay, sir. Definitely.
Yes, that's a good point, Dr. Manish. So there is another question: how was sleep quality assessed? But I request Dr. Hansika to just answer that in the chat, since we don't have time for another discussion.
Okay.
So yeah,
Okay,
thank
ma'am.
you. It was very good presentation, and I encourage you to
Thank you,
publish
ma'am.
your study. Okay. Yeah. Now let us move on to the next presenter. We'll like to call Dr. Bijaya Nanda Naik. He'll be presenting on generalized anxiety and sleep quality among healthcare professionals. May we have your presentation, please?
Good day, everyone. Starting with the introduction, COVID-19 was declared a pandemic in March 2020, following that frontline workers were really busy and overloaded with the duties to control the pandemic. Healthcare workers are under constant stress and anxiety, and which is leading to change in the sleeping habits. Factors like high and frequent exposure to COVID-19 patients, long duration of works with erratic schedules, burnouts, and workload, also fear of transmitting the infection to their family members are adding to the stress and anxiety and causing an acute change in the sleep pattern. AIIMS Patna is a dedicated COVID tertiary care center with 500 bed capacity. So, this study was designed with an objective to find the level of general anxiety, to assess the quality of sleep, and to find out the predictors of generalized anxiety and poor sleep among the healthcare professionals working in a dedicated COVID-19 tertiary care institution in Patna, Bihar. To the methodology, we did a cross-sectional study in AIIMS Patna for a duration of 3 months with a sample size of 369 using convenient sampling technique. We included all healthcare professionals, especially medical faculty, residents, and nursing officers from AIIMS Patna involved in COVID-19 management in any capacity. We excluded healthcare professionals who are currently under psychiatric care and already having a sleep problem prior to the start of COVID-19 pandemic. We designed a pre-structured standard questionnaire in 3 sections, which included socio-demographic data, anxiety problem, and sleep problem. To screen the suspected GAD, we used generalized anxiety disorder 7 item with a cutoff of more than or 10 and Pittsburgh Sleep Quality Index to assess the sleep quality with a cutoff of more than or 5. So the data was collected using Google Form platform and the participants were invited via WhatsApp and email IDs. So the collected data in the Google Form was inputted into MS Excel and analyzed using IBM SPSS version 20. Descriptive analysis were conducted to describe the socio-demographic characters and COVID-19 related data in the healthcare professionals. The categorical variables like suspected GAD, quality of sleep were expressed as proportions and percentages, while continuous variables like GAD score and PSQI scores were expressed as median and interquartile range. So we ran a multivariable logistic regression to find out the predictors of generalized anxiety disorder and poor sleep quality among the healthcare professionals. Overall, the statistical significance was attributed to p-value less than 0.05. Coming to the results, so table 1 shows the socio-demographic variables and median generalized anxiety scores among the healthcare professionals. Out of 370 healthcare professionals, 72.4% were within the range of less than or equal to 30 years, 66.5% were males, and 66.8% resided outside the campus, while 45.4% had any one of the habits, and 14.9% healthcare professionals used tobacco currently. Also, 44.9% healthcare professionals had high-risk persons in the family. 20.8% healthcare professionals came in contact with COVID-19 positive patients unprotected, while 19.2% were tested positive for COVID-19. So overall, 14.1% healthcare professionals were suspected to have generalized anxiety disorder and 52.7% were poor sleepers. That is, more than half of the healthcare professionals were poor sleepers. So this figure shows the severity of generalized anxiety disorder among different cadres of healthcare professionals. For the ease of the study, we divided the GAD scores into minimal, mild, moderate, and severe anxiety and found that nursing staff were in higher proportion in mild, moderate, and minimal anxiety, followed by junior residents who were in significant proportion. Coming to the table number 2, it shows the correlates of suspected generalized anxiety disorder among the healthcare professionals. So we included habits, presence of any history of psychiatric illness, high-risk persons in the family, contact with COVID-19 cases without protection, and those who tested positive for COVID-19 into a multivariable logistic regression model and found out that presence of high-risk persons in the family was a significant independent predictor of suspected generalized anxiety among the healthcare professionals with an R-square of 6.8%. Coming to table number 3, which shows the correlates of poor sleep quality among healthcare professionals. Here we included designation of the healthcare professional, habits, presence of high-risk persons in the family, contact with COVID-19 cases without protection, and suspected GAD for a multivariable binomial logistic regression model, and found out that habits, presence of any habits, contact with COVID-19 cases without protection, and presence of suspected GAD were independent significant predictors of poor sleep quality among healthcare professionals with the Nagelkar R-square of 14.9%. Coming to conclusion and recommendation, significant proportion of healthcare professionals were found to have suspected generalized anxiety disorder and were poor sleepers. Presence of any habits, unprotected contacted with COVID-19 cases, and presence of GAD were independent predictors of poor sleep quality. So, healthcare professionals should be given optimum day offs, and administration should employ more human resources at time of such pandemics to ensure optimal mental well-being of the healthcare professionals. Healthcare professionals also need to be talked about roles and responsibilities, the high risk and self-protection, and not only initially but also intermittently. These are my references. Thank you.
Thank you. So this is as expected to the level of general anxiety disorders in the health professionals. But I would just like to ask you one question. Did you do anything after the study? Did you arrange for any counseling sessions, or what intervention did you do after the study?
Yes, ma'am. We contacted the Department of Psychiatry and also from the Department of Community and Family Medicine. We organized a separate counseling, one-to-one counseling session with the persons who we identified who had anxiety. And we had a session of like 20 minutes per person to deal with this. And then we also are yet to like do another post an analysis survey, ma'am, to check the how did the intervention actually affect it. The data I haven't presented here, but then that we have already done.
Good. It's good to know that at least there was something which was done, an intervention rather than just a cross-sectional study.
Yes,
so anyone else has any question for Dr. Rao?
Ma'am, may I?
Yes,
Am I
yes.
audible?
Yes,
Yes, sir. Yes, sir.
Dr. Vijaya, just one query from my side. Do you have the streams of the medical, maybe you are saying the residents you have taken, do you inquire about the streams, different streams, which specialty they belong to?
Yes, sir. I have the data, but then I couldn't present in the presentation here due to the number of slide restriction.
And that is not, is there any difference between the specialty and their sleep and all disorders and general anxiety disorders?
Sir, actually,
because they might have
in the
different
COVID,
roles and responsibilities during COVID.
Yes, sir. I would like to clarify this point, sir, because since this was a dedicated COVID healthcare facility, so departments overall, everyone were involved in the duties. So it was not like only particular medicine department or department of pediatrics individually they have worked. So everyone were given equal responsibilities for the duties. And so we didn't do a stratification while doing the analysis in the healthcare professionals. Sir. So what we did was we clubbed all the medical departments, nursing departments, and then we analyzed the data. Sir.
That's fine. One little query more, let us suppose you have found the independent predictors as risk of getting COVID infections in their family members who are at high risk. So that might be always there, that might not be related
no,
to
that
duties
was
and all
presence
those
of high-risk persons. Yeah, so that was only a part of the study where we tried to assess what was the main reason for anxiety, whether it was the COVID or whether was it the family. So it was like presence of high-risk people in the family was one of the significant predictors for this anxiety. So because most doctors after their duty, they're going back to their home places or the place where they stay. And so the chances, because there was a lot of stigma also in the society to allow the people in the society. So even that also might have played a role here. So yes, sir. So high risk
something that
people
might
in the
be
family.
always predictors for non-medicals also. That will be a strong predictor for non-medicals also, and all the generalized people, strong predictors. So we
yes,
can
sir. Anxiety.
We can plan counseling session with general public along with the medical students, or we can say faculty and residents.
Yes, sir.
That is what I.
Okay.
Thank you.
Thanks. Sir.
Thank you. Thank you, Dr. Rajat, for that very interesting presentation. So now let us move on to the next. If anyone has any other questions, please put them in the chat box and I request the presenters to respond to them. So next we have a presentation from Dr. Anupama Singh. She'll be talking about the prevalence of insomnia in adult population of Ghaziabad. Can we have Dr. Anupama's presentation?
Population alike. Insomnia is a public health challenge because of its association with poor quality of life, work, absenteeism, and considerable medical and societal costs. So insomnia has been underreported during the pandemic, especially among the general population. Most of the studies that have been conducted have focused on insomnia among healthcare workers and frontline workers. Therefore, this study was designed to find the prevalence of insomnia among general population during the lockdown period in India and to determine the factors associated with insomnia. So this is our objective, to find the prevalence of insomnia among adult populations of urban Ghaziabad during the pandemic and to find its associated factors. So this was an observational cross-sectional study which was conducted from 1st April to 15th of July among adult population of urban Ghaziabad city through a house-to-house survey using a pre-designed and semi-structured questionnaire. The sample size was calculated assuming the prevalence of insomnia during COVID-19 among general population as 50% with a Z value of 1.96 for 95% confidence interval and 5% degree of precision. The sample size came out to be 384. However, Ghaziabad district is divided into 5 zones, and so I selected 80 houses randomly from each zone. So there were around 400 houses that were visited and one adult participant was selected from each house. 396 individuals gave consent for the study, so our sample size was 396. The questionnaire that I used had 4 parts. There was socio-demographic information, COVID-19 pandemic related information, then information related to isolation and social attitudes during the lockdown, and lastly we had the standardized scale of insomnia severity index, where a score adding up to be 7 or less was considered normal, where a score of 8 to 14 was considered as sub-threshold insomnia, 15 to 21 was moderate insomnia, and 22 and above was severe insomnia. Data analysis was done using SPSS, chi-square test was used for proportions, and multinomial logistic regression analysis was done for association. So moving on to the results, the mean age of the participants was around 38 years. There were around 51% males, rest were females. Majority of individuals were living in a nuclear family, that is around 70%, almost 70%. Then the marital, mostly the individuals were married, 76.5% were married and 1.8% were divorced. Then prevalence of confirmed or suspected cases of COVID-19 was around 9% at this time I conducted my study, and individuals who were having some family member who had been infected with COVID was around 32%. Then individuals who were exposed to COVID-19 or to general population at their workplace was around 45%. Then individuals who underwent quarantine themselves was around 13.9%, and prevalence of individuals who had family members who underwent quarantine at least once during the lockdown was around 15.7%. So ultimately the prevalence of insomnia was 14.6% in my study. 8% individuals were having mild insomnia, 5.8% individuals were having moderate insomnia, and 0.8 individuals were having severe insomnia. So overall 4.5% individuals were having moderate to severe insomnia. Females had a greater prevalence of insomnia as compared to males. It was slightly higher, that is 1.3:1 was the ratio. So I have tabulated my results and I have marked the significant results with an asterisk. So as you can see that individuals who were divorced or separated had 10 times higher chances of acquiring insomnia as compared to individuals who were married. Similarly, unmarried individuals had twice the chance of acquiring insomnia than individuals who were married. Then individuals who were living alone had 7.5 times higher chances of getting insomnia than individuals who were living in a joint family. Then individuals whose family or friends had been infected with COVID-19 had 3 times higher chances of getting insomnia than those who had not. Then individuals who had come in contact with the COVID-19 cases had twice the chance of getting insomnia. Individuals who had been quarantined at least once during the lockdown period had twice the chance of getting insomnia than individuals who had never undergone any quarantine. Similarly, individuals who had seen death among their family or friends had twice the chance of acquiring insomnia. Practicing meditation was found to have a protective effect against insomnia. So now to conclude, it is COVID-19 is a global health crisis, and insomnia was higher among individuals who were either living alone, who were unmarried, divorced or separated, who had COVID infection themselves or had a case in their family, who had exposure to COVID-19 patients, or who had undergone quarantine or isolation. Then regular ventilation was found to be protective. The limitations of my study were a limited study population, small sample size, and it was a cross-sectional study, so there was no follow-up. So long-term effects need to be studied. These are my references. Thank you.
Thank you, Dr. Annapurna. I just wanted to ask one question. How did you assess insomnia? Which scale did you use? You're muted. Can you please unmute yourself?
Good afternoon, ma'am. Ma'am, I used insomnia severity.
Okay, so to whom did you administer this insomnia at severity scale?
Ma'am, it was in the questionnaire. As I mentioned, there were 4 parts. We asked the social demographic information, then we asked some quarantine related information, and then the score was also there.
So how did you?
Questionnaire.
Okay, so how did you select the respondent? Because
Ma'am,
there are many people in the family, so how did you select the person who
Ma'am, we
responded for this
selected
question?
one adult from one household. First, we selected the households, and then randomly selected an adult member, and then to that member it was a house to house.
So yeah, it's good to see at least you have done a house-to-house visit in this era. Generally nowadays it is only an online survey.
Yes, ma'am, it was difficult because it was conducted from April to July.
So there's a question from Dr. Nish whether the vaccines kind of relief told to the participants to get vaccinated.
Ma'am, actually at the time of the study, it was from April to July in 2020. So ma'am, there was not much discussion about vaccine at that time. So,
and is there any other question from anyone else?
Just one question. Have you addressed the internet use or maybe mobile or screen time from these participants? That might be a strong predictor for insomnia as well.
No, sir, we did not.
Because of COVID, many of them are working so long in screen, and that might be a very strong predictor for insomnia.
Yes, can be, but we did not ask that.
Thank you.
Interest of time, let us move on to the next part of the presentation, next session, next presenter. And I would like to hand over the remaining part of the session to Dr. Manish.
Thank you so much, ma'am. May I invite our next speaker, Dr. Krupala Sandhya Rani. The topic for talk is assessment of anxiety, fear, and perceptions about COVID-19 among lactating mothers in the slum of Andhra Pradesh. So may we have the speaker, please?
Good morning, everyone. I am Dr. Sandhya, final year postgraduate from Department of Community Medicine. Today, I am going to present a study on assessment of anxiety, fear, and perceptions about COVID-19 among lactating mothers in a slum, Andhra Pradesh, and the extensive physiological and somatic changes which occur during pregnancy and post-delivery include unprecedented hormonal fluctuations, which increase the vulnerability of mother to neuropsychiatric disorders. And if these changes are associated with uncertainties and alarming situation of COVID-19, they might fear and feel further anxious about their own health and their children. Comparatively, children are being affected during the second wave of pandemic, which is the cause of concern for the mother. Even though children seem to have less severe clinical symptoms when infected, the proportion of severe and critical cases was high among children under 1 year compared to children of age 1 to 5 years, suggesting infants are at higher risk of severe respiratory failure. And the present study was conducted to explore the perceptions of mothers towards COVID-19 and to assess their related fear and anxiety. And objectives of my study was to explore the perceptions of mothers towards COVID-19 and to assess fear and anxiety, to assess socio-demographic and maternal characteristics along with perceptions associated with anxiety and fear of mothers towards COVID-19. After obtaining IEC clearance, permission from medical officer, and informed consent from study participants, a cross-sectional study was conducted in a selected urban slum, that is Vehicle Section Colony, among lactating mothers with children below 2 years during the month of July 2021. Sample size was calculated to be 73. Out of 113 lactating mothers with children below 2 years, 73 members with their consent participated in the study. 11 houses were logged and remaining participants were at their hometown. And lactating mothers with children below 2 years and who gave consent were included. Mothers who are not available even after 3 consecutive visits were excluded. Data was collected by interview method using pre-tested semi-structured questionnaire with 4 parts. First part is about socio-demographic profile and second part perceptions towards COVID-19. Third part assessing fear using fear of COVID-19 scale and fourth part anxiety levels using coronavirus anxiety scale. Data was analyzed using SPSS version 21 and results were expressed in terms of mean, standard deviation and chi-square was applied to test the significance. These are my results and majority were in the age group of 20 to 22 years and majority were Hindus. 1/4 of the study participants were illiterates and most of the study participants were from middle class socio-economic status according to BG Prasad classification and majority were homemakers. Nearly 34.2% of mothers had history of abortion and more than 50% of mothers were multiparous. More than 60% of the study participants perceived that COVID can affect pregnant mother and they are at increased risk of infection and virus can be transmitted perinatally and virus can be transmitted to newborn. This is fear of COVID-19 scale. It is a 5-point Likert scale. Answers include strongly disagree, disagree, neutral, agree and strongly agree. And the minimum score possible for each question is 1 and maximum is 5. Total score calculated by adding up each item. And most of the participants expressed fear on watching COVID-19 related news and mean score of fear was 26.93 plus or minus 7.6 and more than 50% of the study participants had fear with score more than or equal to 27. This is coronavirus anxiety scale. It is rated on a 5-point scale from 0 to 4 and score more than or equal to 9 indicates probable dysfunctional coronavirus related anxiety. More than 2/3 of the participants expressed anxiety by feeling dizziness, lightheadedness or faint and had trouble in falling asleep and they felt paralyzed or frozen and they have lost their interest in eating and felt nauseous or had stomach problems. And 36.9% of the study participants expressed anxiety towards COVID-19 with score more than or equal to 9. Fear score was high among illiterates and fear score was high among homemakers. Anxiety score was high among mothers who perceived that COVID can affect pregnant mothers and increase the risk of infection and virus can be transmitted perinatally and virus can be transmitted to newborn. Fear score is high among mothers who perceived virus can affect pregnant women and mothers are at increased risk of COVID infection and virus can be transmitted to child and virus can be transmitted to newborn. More than 60% of the study participants perceived that COVID can affect pregnant women and children and transmissible from mother to child and they were at increased risk of infection. 36.9% were anxious about COVID-19 which is in comparison to study done by Michael et al. And in his study the prevalence of anxiety was 42.4%. Fear score was found to have significant association among homemakers and with low educational status, which was high. And there was no statistical significant association between anxiety score and socio-demographic and maternal characteristics. To conclude, mothers are under immense fear and anxiety as COVID can be fatal for themselves and their children. And these are my recommendations: keeping the mothers informed and updated regarding COVID-19, spreading awareness through mass media by sharing success stories of the cure to reduce the panic attacks, and emphasizing on getting vaccinated against COVID-19 by all the eligible family members, and round-the-clock counseling to be made available both online and in person, and easy access to mental professionals to be provided 24/7. These are my references, and my sincere thanks to Faculty of Department of Community Medicine for their support and encouragement, and Dr. Sunil Prashant sir for his support, Medical Officer A&M study participants for their cooperation. This is during data collection, and I'm very much thankful to IPHCon for giving me this opportunity. Thank you.
Thank you, Dr. Sandhya. Any questions? Questions are invited. Ma'am, Dr. Paramita and Dr. Berry, ma'am, please, if you have any questions.
I just have one question. The fear scale for COVID, you're saying, fear scale for COVID, is it a validated scale?
Good afternoon, ma'am. Am I audible, ma'am?
Yes.
Okay, ma'am. It is validated with Cronbach's alpha more than 0.9.
So is it available in Telugu, or what language did you use it for?
It is in English only, ma'am. But I've
English.
converted it into Telugu language.
Okay, so you translated it yourself?
Yes, ma'am.
Okay. So yeah, that's what I just wanted to know, because even if you translate a validated scale, you will again need to validate it, isn't it? Because sometimes
Yes,
the translation changes the meaning of the questions, particularly in this kind of qualitative when you're trying to elicit the emotional aspects or the qualitative attributes. So anyway, that is all from my side. Anybody else has a question? Dr. Nish has, I can see it in the chat box. Maybe Dr. Manish, I don't have anything.
Sure, ma'am. Just one question from my side. Am I audible?
Yes, sir.
Do you plan something for you have said so many things in the recommendation regarding counseling and addressing the fear and promoting vaccination among those people. Have you done these things in the participants itself?
Sir, actually, I was there in a contact tracing team, sir. Daily, we are calling ANMs and medical officer to look after vaccination and all, sir. So most of the people, but these lactating mothers, they usually fear of getting vaccinated, sir. That's why during study, I have suggested them to get vaccinated.
You just have suggested them. Can you address their fears, what fears they are having, and
Yes,
some specific queries which they might be having? And
most of the mothers, they fear that if they get infection, that infection can be spread to newborn also, sir. That is the most fear they're expressing. But I have suggested them to be with family and engage with family and all. And I asked them to get vaccination. And most of the fear was expressed while watching news, sir. That's why I have asked them to watch success stories of cured.
Thank you so much. Thank you.
Thank you, sir.
Any questions from anyone else, please? We can have one more question if anyone has.
Dr. Manish, there's a question in the chat box. Whether the adult participator was aware about the COVID-19 SOP?
No, ma'am. Most of them are illiterates, ma'am. They don't know complete knowledge about COVID and what are all the precautions they have to take, and even they don't know about social distancing also, ma'am. I have informed all these things, ma'am.
Okay, thank you.
Thank you.
May we have the next speaker, Dr. Jitendra Hirani. The topic of presentation is nurses, mental health and workplace safety during COVID-19 pandemic in a tertiary hospital of North India. Dr. Hirani, please.
Hello everyone, my name is Dr. Jitendra Irani, PG resident at Kitanli Medical College Hospital, Udaipur, Rajasthan. My title for e-oral presentation is Nurses, Mental Health and Workplace Safety During COVID-19 Pandemic in Tertiary Care Hospital of North India. Introduction. In December 2019, the World Health Organization was notified about the cluster of pneumonia cases in Wuhan, China. Due to a previously unreported virus SARS-CoV-2, the disease was later identified and notified as coronavirus disease COVID-19. The theme of World Health Day 2020 is to support nurses and midwives. According to the Global Health Workforce Alliance and WHO, India is categorized among the 57 most severe crisis facing countries in terms of availability of healthcare workers. Nurses are the forefront of COVID-19 response. Quite simply, without nurses, there would be no response. Objective of the study. The present study was aimed to assess the mental health status and workplace safety of nurses during COVID-19 pandemic and to determine the potential influence factors. Materials and methods. Study design. It was a cross-sectional study. The data was collected online in two tertiary care hospital in Rajasthan, catering to both general and COVID-19 patients to prevent the spread of COVID-19 infection. Sample size is calculated by the formula n equal to z square pq upon d square, where d is prevalence of the depression among healthcare workers, that is 5.8, obtained by the previous studies. Sample size was 577, including 20% of non-response rate. The study performed was anonymous, administered in English and Hindi, posted on Google Forms. We distributed the study link to nursing supervisors of the hospitals where the study was conducted after obtaining prior approvals. The reminder messages were sent every week in official groups to ensure a reasonable participation rate. The study performer comprised of the following section: demographic information, injury, generalized anxiety disorder, sleep quality, depressive symptoms. We used generalized anxiety disorder 7 scale for assessing anxiety. For assessing the sleep quality, we used Pittsburgh Sleep Quality Index. To assess the depressive symptoms, we used the Patient Health Questionnaire 9. Results. A total number of 580 participants' response were collected and taken for data analysis. The mean age was 28.89 plus minus 5.3 years of participants. 85.3% participants were less than or equal to 35 years of age. 68.3 was male. 86.7% was at rank of staff nurse. 92.1% study participants are married. 31.9% were working with COVID-19 patients. 7.8% participants had an injury within last 1 month. Most injury was needle-stick injury was more, that is 46%. Most injury linked to rust work. Only 23% participants were wearing PPE at the time of incident. On psychometric assessment, it was found that 17% participants were suffering from generalized anxiety disorder. 10.3% participants were suffering from depression. On sleep assessment, observed that 10% of study participants had poor sleep quality. On multivariate regression analysis, it was observed that participants more than 35 years of age, females working with COVID-19 patients and with injury episode in last 1 month have a significant higher risk of developing generalized anxiety disorder. Female nursing supervisor and having injury episode in past were significantly associated with poor sleep quality. Depression was also found to be significantly higher in nursing doing COVID duties at supervisor rank with history of injury in last 1 month. Implication and conclusions. Our study identifies several risk factors that indicates vulnerability and poor mental health outcomes among nursing personnels. Educational intervention in terms of training and counseling are required to provide confidence and psychological support. Therefore, recommended that regular screening of nursing personnel involved in training diagnosis patient with COVID-19 be done for evaluating anxiety, depression, and sleep disorder. These are the references. Thank you.
Any questions?
I have a question, but if there's anybody else who wants to ask, I don't want to be the only one to keep asking the questions. Dr. Paramita, you have anything? I have a couple of questions.
Sure, ma'am, sure. We will learn from you, please.
No, okay. We all learn from each other. Okay, Dr. Jitendra, in your sample size calculation, you have used the formula 4PQ by D square, right?
Yes, ma'am.
So your prevalence was, according to that, was 4.3% prevalence of depression that you took. So what is that data from? 4.3%, what in depression in nurses or in general population?
Ma'am, in medical healthcare workers. Healthcare
Okay.
workers.
What is the reference to the study that you've taken?
It was taken from multinational and multi-centric study.
Which year was the study done? Because it seems to be very low, 4.3% depression.
5.3.
5.3, yes. So,
Ma'am, it was done in 2020 April.
okay, that's good. And another observation that I saw was in male, in the distribution that you showed, male nurses were 68%.
Yeah, ma'am.
Right? So is that commonly, I mean, the ratio of males to female nurses, is it like that in Rajasthan or in your hospital?
Yeah,
because generally we see more of women, I mean, female nurses.
Ma'am, in this part of Rajasthan, the male issue is more than female.
Okay, that's good. That's good. Okay, another last point is I observed that you said that maximum number of participants did not work with COVID patients as compared to those with COVID. So how do you think their responses would be? Because you asked the same questions to the COVID and the nurses who were exposed to COVID patients and those who were not exposed to COVID patients. So do you think that there would be a problem there in the responses? What would be the bias?
There will be response bias.
Why? In what sense? So the patients who, the subjects, your participants who were not exposed to the COVID patients would be having probably a different level of anxiety disorder. I mean, the level of stress or anxiety as compared to those who were exposed, isn't it? So at the baseline itself, I mean, those patients, but were, I mean, if they were not exposed, maybe their level would be, the results would be different. Maybe if you had taken only the patients or the participants who were exposed, maybe the results could have been different, right? Okay, anyway, that was my point. So I don't have any other questions. Dr. Manish, over to you.
Who has not been exposed to these two COVID patients, and we can at least analyze them separately in your study.
Hello.
Yes, that's right. We can't hear you, Dr. Manish. Can you hear? I can't hear Dr. Manish. I don't know about others. Is it my network?
Am I audible?
Yes.
Maybe I will unmute.
Sir, you are not audible, sir. Hello.
Am I audible now?
Yes, sir.
Yes,
now,
yes.
Sorry for inconvenience. Just asking you what you have said yourself in your study findings, the very less number of the nurses are using PPE kits.
Yes, sir.
Why so? Have you addressed this, and do you find some reasons for why they are not using PPE kits while handling the patients?
Sir, they are not using PPE equipments like gloves and all that things. The study was the observation was done on both with COVID, that staff who is working with COVID positive patients and non-COVID patients. And so
But I think in the present scenario, they should be at least using a mask and all those things. Even if they are not dealing with the COVID patients, we advise them to use mask and all these things in hospital settings, in the routine settings also, maybe in public places also.
Yes, sir.
So that needs to be addressed. Maybe you may get back to your study participants and focus on this. So if no more questions, can we have a next presentation by Dr. Ratul? And he will be speaking on the topic loneliness and social support among COVID-19 patients attending a telemedicine center. So may we have Dr. Ratul, please?
Yes, sir. Hello, greetings to all. I am Dr. Ratul Kumar Bosha, postgraduate trainee of Institute of Postgraduate Medical Education and Research, Kolkata. It is my privilege to present before you my article entitled Loneliness and Social Support Among COVID-19 Patients Attending a Telemedicine Center, a cross-sectional study. The morbidity pattern, effect of self-isolation and quarantine, uncertainties in social support are major contributors to loneliness among patients suffering from COVID-19. Telemedicine services have been able to address medical needs of COVID patients while ensuring their safety. However, loneliness and social support system still go unrecognized. There is scarcity of available literature on loneliness and social support of COVID-19 patients who are availing telemedicine services. Keeping this background in mind, the study was conducted with the research hypothesis that COVID-19 patients attending telemedicine center experienced loneliness. My study objectives were to estimate the prevalence of loneliness among COVID-19 patients seeking advice from a telemedicine center of Kolkata, to assess the level of social support experienced by study population, to find out the socio-clinical profile of the study population, to determine the association of loneliness experienced with socio-clinical profile and perceived social support of the study population. My study was descriptive type of observational study, cross-sectional in design, setting was telemedicine center at IPGNER and SSKEMH Kolkata. Data were collected from COVID-19 patients seeking advice from the telemedicine center at IPGNER and SSKEMH Kolkata. Inclusion criteria was age equals to or more than 18 years and exclusion criteria was patient not suffering from COVID-19. The study was conducted over the period of 2 months. Simple random sampling without replacement technique was used, and for the sample size, Cochrane's formula used. 50% taken as prevalence and 5% non-response, it became 403. Study tools were used, pre-designed, pre-tested, structured schedule, Dijon-Dierfeld scale of loneliness, which is 11-item scale to assess loneliness, and multidimensional scale of perceived social support, which is 12-item scale to assess social support. Data were collected through telephonic interview. Among study variables, dependent variables were loneliness and social support, and independent variables were socio-demographic variables and other predictors. Data entered in MS Excel 2010, analyzed in SPSS version 25. Statistical test used Pearson's chi-square test and multivariate binary logistic regression. Ethical clearance were taken from Institutional Ethics Committee of IPGNER Kolkata and informed verbal consent from the participants. From the study, it was found that more than half of the study population belonged to 18 to 44 years age. Over 80% were in home isolation during infection. More than 70% had care providers during infection. Most of them reported that regularly socialized and were engaged in activities that provided entertainment during infection. Figure 1, distribution of the study population according to the loneliness, where 80% patients had experienced some category of loneliness, nearly 35% of the participants had experienced severe loneliness. Figure 2, distribution of the study population according to their social support. 73.7% here respondents had experienced high social support. On binary logistic regression, age group 45 to 59 years had reduced odds of loneliness and male had higher odds of loneliness compared to reference. Those who currently not married, belonging to nuclear family, education up to higher secondary level had higher odds of loneliness compared to reference. Those who currently not married had significantly reduced odds of getting social support. Those had education up to higher secondary had higher odds of getting social support compared to reference. Unskilled, unemployed or others, and those who semi-skilled or skilled in occupation had significantly reduced odds of getting social support, while those who belonging to higher socioeconomic status had higher odds of getting social support compared to reference. Respondents who had single or no chronic disease had significantly higher odds of loneliness, while respondents who were on home isolation during infection not addicted had significantly reduced odds of loneliness compared to reference. Those who had no caregiver self-reported loneliness due to physical distancing had significantly higher odds of loneliness, and those self-reported not or infrequent socialized had significantly reduced odds of loneliness compared to reference. Those who had single chronic disease had no caregiver had significantly reduced odds of social support, while those were on home isolation during infection had higher odds of social support compared to reference. Those slept at night, self-reported loneliness due to physical distancing had significantly higher odds of social support compared to reference. This is a scatter plot showing correlation between loneliness and social support. Our study underscores that quarantine and social distancing lead to elevated levels of loneliness and social isolation. 84% respondents had experienced some category of loneliness. Loneliness and social support are negatively correlated. Pearson's correlation coefficient minus 0.396. So adopting appropriate steps to keep social and familial connections, physical exercise, recreational activities, networking with others using educational and social support programs, reminiscence therapy, and management of emotions and psychiatric symptoms can prevent loneliness and social isolation and thereby help relieve the adverse consequences. These are my references. I'm concluding my presentation. Thank you.
Anyone have any questions? Dr. Parmita ma'am, Harry ma'am, please. Any of the participants, please.
Okay, if nobody's asking anything, I have questions.
Yes, ma'am.
Dr. Ratul, I would just
Yes.
like to know what is this telemedicine center that you're saying? What is it actually? Telemedicine center. How do patients go there?
Telemedicine center, madam, it is the patients are calling in telemedicine center, and we are just the doctors are providing the support and medicine support and
So that is
advice.
inside in the OPD of the hospital?
No, sir, no, ma'am. It is in the telemedicine center in the IPGMA in 8th floor, the telemedicine center in Kolkata.
Okay, so what kind of patients come there? How do
Ma'am, it is
people
only
come
it
there
is,
by appointment?
No, ma'am. It is a regularly call 24 hours. There is a doctor present in the telemedicine center, and the calls are coming in around the clock from the COVID patients.
Okay, so even children also are provided telemedicine services?
It is, yes, ma'am. They have provided the facility, but my study based on the above 18 years.
Above 18, okay. So just one more question is you had a telephonic interview, right? So how did you
Yes, ma'am.
contact these patients? So you had the telephone
Yes,
numbers
ma'am.
of all
First
the
of all,
patients?
yes, ma'am. I have a number of all the list of all the patients who are called in the last 1 month. Then I have from that list I have simple random sampling. I have chosen the by computer generated random number table. I have selected the numbers 403 patients. Then I have called them personally after taking the taking the constant verbal consent. Then I asked the question.
Thank you. So
Thank
I
you,
can,
ma'am.
thank you. I can see another question in the chat box. Dr. Manish, will I read it? Dr. Nish is asking whether mental health counseling sessions were given, whether telemedicine center operates 24/7, how did they provide the medicines, whether staff go to the home to give medicines. There are a
Yes,
lot of
ma'am.
questions. Very
Yes.
interesting concept.
Okay, ma'am. The
Okay.
patients were asking questions, asking their problems, and they are telling. And doctors who are sitting in the telemedicine center, they are providing the medicine. And in the also there is a PDF format they are sending in their mobile also. There is a scope.
You mean so
Yes, sir.
these medicines are provided by the institution, or they are just prescribing it and they have to be purchased by the caller?
They are just writing down in a PDF format, in a prescribed format, and then the prescription already sent to their mobiles in.
But they are not
link
providing medicine; they are just providing prescriptions for all those things.
Prescription in the medicine already there, sir. After hearing their problem, the doctors are prescribing medicines in their prescription to their mobiles. And also in the earlier days, we are providing the medicines through telephone in verbal. Then nowadays, we are providing the medicines in a prescription format.
One more query from my side, just loneliness and social support are, we can say, opposite of each others, and there we expect there will be negative correlations and all those things which we have calculated statistically. So we hope that, I think we need not to have much statistics in this place. These are already, if there is a loneliness, there will be lack of social support, and if there is a lack of social support, there are high chances of loneliness. And I think which you have concluded the things that might COVID-19 is such a disease that I think isolation, and many times we have to go into quarantine and isolation, and loneliness will be there.
Yes.
So impact of loneliness, whether loneliness leads to depression and anything else, and mental, agar uska koi state hua, so that if you analyze that very aspect, that your study might be very useful in that very sense.
Okay.
Do we have any more questions? May we have our last speaker, Dr. Vishalini?
Thank you.
And the topic of the presentation will be COVID-19 anxiety among undergraduate students of a medical college in a Chengalpattu district. May we have Dr. Vishalini?
The topic for my presentation is COVID-19 anxiety among undergraduate students of a medical college in Chengalpattu district, a cross-section study. The World Health Organization announced COVID-19 outbreak initially as a public health emergency on Jan 30, 2020, which was then later declared as a pandemic on March 11, 2020, affecting many countries worldwide. This coronavirus is known to cause diseases ranging from mild to more severe respiratory illnesses. But apart from these respiratory illnesses, this can also have serious effects on people's mental health. So during this epidemic, people might experience fear of getting infected with this COVID-19 virus, which might lead to stress, anxiety, depression, and insomnia. In a recent study by Sai Karthik et al., which was conducted during COVID-19 outbreak in India, 1/4 of adults were found to suffer from depression and stress, and 1/4 from anxiety. Among the college students, specifically during this lockdown period, due to factors like changes in academic structures like online classes, examinations, it is directly associated with anxiety, stress, frustration, and depressive disorders. Quick et al. Did a meta-analysis on anxiety among medical students and found that 1 in 3 medical students were found to have anxiety, which was higher than the general population. So this anxiety was a concern even before COVID-19. So So based on the above factors, the present study was conducted among medical students to evaluate their anxiety levels during this COVID-19. Objectives to estimate the prevalence of COVID-19 anxiety among undergraduate students of the medical college in Chengalpattu district and also to assess the factors that influences anxiety among the medical college students. Materials and methods. It is a community-based cross-sectional study. Study settings in medical college in Chengalpattu district. Study period was for 4 months from December 2020 to March 2021. And the study population included undergraduate students of the medical college in Chengalpattu district. We included undergraduate MBBS students above 18 years from second, third, final years and interns. Exclusion criteria: the dental and nursing students and MBBS students who are not willing to participate were excluded from the study. Sampling technique: we use a simple random sampling technique for collecting the samples, and the sample size was calculated based on the study by Akatur et al. On depression and anxiety among university students during COVID-19. Assuming 95% confidence interval and allowable error of 5%, non-responsive rate of 10%, the sample size was calculated as 197. The data was collected using a pre-tested questionnaire which consisted of socio-demographic factors like age, gender, year of study, family type, marital status, etc., followed by a 7-item questionnaire of corona anxiety scale for assessing anxiety levels. The objective of the study was explained to the participants and informed verbal consent was obtained. The data was collected using a one-on-one telephonic conversation from the participants based on the questionnaire items. The data collected was analyzed using IBM SPSS software. The frequency distribution of the socio-demographic profile was expressed as percentiles, and chi-square test was used to find the association between the socio-demographic factors and the anxiety levels among the students. So coming to the results, distribution of socio-demographic variables. Males constituted about 82, females were 115 of them. Most of them were unmarried, that is 97.5% of the students were unmarried. Coming to the type of family, 159 students were a nuclear family while 38 of them belong to joint family. Most of the students do not have any comorbidities, that is 98%. Most of the students belong to the upper socioeconomic class, which was calculated based on VG Prasad classification. And when asked whether they are staying with parents or alone, 131 of students said they were staying with their parents during this COVID-19. And based on the year of study, 49 students were second year, 47 of them belong to third year, 51 of them were from final year, and 50 students were taken from internship respectively. On the distribution of anxiety level among study participants, we have found that 49 students, that is 24.9%, did not have any form of anxiety, while the remaining 75.1% had some form of anxiety, which included mild anxiety, that is 83 students had some mild anxiety, while 54 of the students had moderate anxiety, and 11 of them, that is 5.6%, had severe anxiety. Association between socio-demographic factors and anxiety levels. We have found some significance between the type of family and the anxiety levels in the students. Similarly, we also found some significance between the year of study and the fact that staying with parents. While gender and marital status did not influence the anxiety levels of the students. Implications and conclusions. This COVID-19 pandemic has resulted in challenging crisis for the public health in the contemporary world, more so among the students' fraternity also. So apart from this rising mortality rate due to COVID-19, the world is suffering from increased psychological outcomes during this COVID-19, with the medical students are more affected and more vulnerable since they are at a high risk of exposure than the general population. So in our study, we have found that there is some association between the type of family and the anxiety levels. So this might be due to the fact that the students get support both mentally and morally from the parents or family members during this pandemic comparatively to the students who are staying alone. So focus on mental well-being of the undergraduate students, especially medical students, is a must, which should require attention and support from the family and society to cope up with this pandemic situation. Also, this increased levels of anxiety seen in the study among medical students might be also due to the fact that the students' curriculum focuses less on disaster preparedness for the students. So they are less aware of how to handle this pandemic, making them more anxious. So properly educating the students prior might help them to have a idea about how to handle this pandemic situation in a better way. These are my references. Thank you.
Question, the presenter is not, maybe if any queries, any questions from audience or maybe chairpersons, we may have some questions. Dr. Paramita ma'am, do you have any questions?
Can I ask a question?
Sure, ma'am.
So that we don't waste time, others can still think about the questions. I have one question. You said that the parents, I mean, there were students who stayed with their parents and some students who stayed alone. So obviously the anxiety level will be less in those who are with the parents, right? But then, so the analysis should have been done separately for those with parents or maybe staying at home, and those who were staying by themselves. So we cannot club them like that, because that is directly, it is going to impact their anxiety levels. And another thing is, what I wanted to ask you, what do you think are the limitations of your study?
Limitations of my studies, I have included interns in my study, ma'am. 50 of the students are interns. Since interns are coming to hospitals and they have direct contact with the patients, this might lead to increased anxiety levels more among the intern population rather than the remaining 3 years, because
So-
they are attending online classes only.
So did you
this,
see that?
result might be
Yeah. So did you do that analysis, the subgroup analysis? Did you see that there was a higher prevalence of anxiety disorders in interns?
no, ma'am. In my research, actually, both the second years and interns had almost similar levels of anxiety. But the population is not actually evenly distributed. I have randomly selected from all the years based on whoever I was able to contact.
Okay. My last question is, in your recommendation, you said that we should teach students about disaster preparedness, about pandemic, right? So did your study address this? Did you ask this question when from the students or from the participants?
No, ma'am. While conducting the study, I didn't ask, ma'am. But after completing the study, recently after the regular classes have been started, I followed up with some students via telephonic conversation and asked them now how they are feeling regarding this anxiety levels. They coming back to this normal classes have somehow improved their levels of anxiety.
Okay, no, generally as a basic rule in any study, like your conclusions, your recommendations should come from the from the study itself. It's not that after you finish, then you probably have interacted with a few of the participants. So that is, I mean, that should not come in the recommendation. If you had asked about this particular question and then they responded that we need more training in disaster preparedness, then that would justify your recommendations. But generally, you cannot just give general recommendations. That is there. I mean, without doing a study, also we know it, right? So your objectives should be aligned with your conclusions, and recommendations should come from the study that you have done, not in any general comments or general impression. That's all that I want to say. Thank you. Good study.
Thank you.
Dr. Peshalni, was the students were working the wards sometime during the pandemic, or they were only studying? That is
The second, third, and final years were attending only online classes. They didn't come to hospital. Only the interns were in the hospital.
Only the interns are there in the wards.
Yes.
And one more question is whether they are following all the SOPs which are they are recommended for the care of the COVID patients, or maybe COVID in the wards during the COVID pandemic. Were they following all those SOPs? Were they trained for all those SOPs?
Ask about that.
Sorry?
Actually, I didn't ask. I didn't ask about that, sir, to students.
And one more question from the audience is, was there any positive connection between the students?
Positive connections. So I didn't get the question. So.
You may reply to them in the chat box. One query from my side, what is the timing of your study? When you have conducted your study?
Data was collected during December, sir, December 2020.
December 2020. And do some of the students or some of the years having exams during that very time?
Yes, sir. I didn't include the exam going back, sir. I took the list of students who were attending online classes at that time.
But do they have exams in some semesters?
Exams were there after that, sir. During that time, there was COVID, sir. So exam was postponed during December and Jan. Exams were conducted only in April.
So that could have increased their anxiety level, no? On one hand, you have the COVID, and other hand is the exam stress. Because there was an uncertainty as to when the exams are going to be held. That also could be one confounder, right? That is a confounding factor.
And on the matter, one more point which strikes to my mind is, you are asking about interns, whether they are having anxiety because of doing duties in COVID ward or because of their entrance exam being postponed and all those things. So they might be having.
The questionnaire didn't mention about the exams. It generally asked about whether they will be afraid of acquiring COVID or do they have thoughts related to people around them getting affected with COVID.
Hello, am I audible?
Yes, sir.
So that might be the reasons. Maybe anxiety may have so many reasons along with COVID. I am not saying COVID-19 not be a reason, or doing duties in the ward might not be a reason, but there might be another reason. So it will be, your study might conclude that also, and we can have reason-specific solutions to address those anxieties and all those things. That is one suggestion from my side. Anyone else have any question? Maybe from any of the participants till now. Do we have all the participants available? All the presenters available? And anyone from the audience or anyone from the chairperson want to have any other questions? Because we still might have time, 5-10 minutes. If we have some questions, we can address those questions to the specific presenters. Otherwise, ma'am.
I don't have any question. If anybody else is there, and I'm happy that we are ahead of time. Generally, we go behind time, but so.
Ma'am, over to you, ma'am, please.
Thank you, Dr. Manish. Thank you for moderating that second half of the session. And thanks to all the participants. I think you've all done very good studies considering the the COVID situation and the restrictions and not being able to do community-based or face-to-face studies. But still you have managed to do all these epidemiological studies, and particularly in the topic like related to mental health. And it is interesting, and I hope that you will all publish these papers and make it a point that you go back and address the queries. We have raised some questions, so those of you who have not been able to answer, or we have raised certain questions about your studies, it's not to demean you or find fault with your study, but it's the effort will be to improve your studies. So if you can improve, do a reanalysis. If not, then you can put them, acknowledge them as limitations, but please go ahead and try to publish your work. That is my final message for today. So with that, I hand over to the organizers. Thank you.
With this, we come to an end of day one of Alphathon. I would like to extend my sincere gratitude to all the chairpersons, mainly to ma'ams and sir, and delegates, those who are participating, for sharing their valuable insights and experience. On behalf of the organizing committee, we would request all of you to kindly join us tomorrow on day 2 of IFACon. Have a wonderful day ahead, everyone. Thank you.
Thank you.
Thank you.
Thank you.
Thank you, ma'am. It was just a pleasure to chair a session with you. Thank you, ma'am.
Thank you, Dr. Manish. It's good to see you on this. We should meet again.
Sure, ma'am. Thank you, ma'am.
Thank you. Thank you.
With this, we would conclude our sessions. Thank you.